with iodine and putting that 5% iodine in the cul-de-sac, meticulous lid dripping and keeping lashes away, and intracameral antibiotics are the key. So again, intracameral antibiotics, lot of options are available. Moxifloxacin is the again the key because of its broader spectrum, less resistance, low MIC, and minimal side effects. Of late, vancomycin was being used tremendously for its for MRSA agents, but because of hemorrhagic occlusive vasculitis, it has been now not longer preferred. Again, post-operatively, most of us are using moxifloxacin antibiotics, and this study has shown that intracameral moxifloxacin along with post-operative moxifloxacin prevent mutant streptococcus MRSA agents. So within 6 hours, the levels are more than what is required to kill a MRSA agent. So 4 hours after the surgery, and intracameral antibiotics do the very good job to prevent most of our post-op endophthalmitis cases. This is again a study which is showing role of fluoroquinolones after the surgery, preventing the post-op endophthalmitis. This is a study done by Alcon Japan, in which they have studied this regime of a 3-day pre-op, the day of surgery, and 14 days post-op moxifloxacin in all cases of cataract, and they have studied bacterial eradication rate, post-operative infection rate, pre-op non-bacterial rate, and post-op non-bacterial rate. So these bacterial eradication rates suggest that the bacteria is no longer there in the cul-de-sac when they start 3 days prior to the surgery. So which was very significantly high. 85% of patients the bacteria were totally eradicated if we start antibiotic 3 days prior to the surgery. And no patient had endophthalmitis in post-operative period. This is a safety profile of moxifloxacin. Only foreign body sensation is the reported side effect. So basically, I would say that amoxifloxacin still leads the antibiotic range, which has all the cover for all bacteria and pathogens leading to endophthalmitis. So another question is that having the same active ingredients enough? So we have a lot of brands in the market. So apart from the active ingredient, there is a lot of other things which help in penetration, efficacy, and side effect profile, which includes drug ionization, pharmacokinetics, and demulcent and tonicity, which has been used. So Vigamox, which we have been...
Say a craniotomy in the next, they love doing that. As surgeons, we love operating. But he just came to us for a second opinion. He had proptosis pressure, but no optic neuropathy. So we decided to go ahead with through the eyelid crease and just debulk the sphenoid wing over here, because in meningiomas, if you know about meningiomas, what really happens is that you can't really treat them completely. They do tend to recover. So what you really need to do is just debulk these tumors, and you can leave a thin cuff of bone. And this can be easily achieved through the eyelid crease incision, just as we do our thyroid decompressions. And he had an excellent result. This is a 3-year follow-up along with radiotherapy. He looks great. He didn't have to go through a big surgery, and you're really sort of saving them from a lot of recovery time, which is much easier with any orbital surgery. Other approaches that we also typically do, transcaruncular, you just make an incision behind the caruncle. Again, very good for medial orbital tumors, for medial thyroid decompressions, and this is essentially what it looks like. You make an incision just lateral to the caruncle, and you can just go back to the periosteum, and any medial orbital tumors that you have can sort of be addressed really well with this approach. Typically, very well used for tumors which are in this area of the orbit, so I think that's a fantastic approach. Again, this is from one of Dr. Millen's papers. This guy, he had, as you can see, he had severe proptosis, and he had an eyelid crease incision and a transcaruncular incision, but at 6 months, it looks like, you can't see any scars. So I think it's really beautiful what we can do with this. Other incisions that we typically use are fornicial incisions. Now, these can be in all 4 quadrants. I think this is something we typically do all the time. Just really good results with these as well, no scarring at all. So the next thing I'm going to talk about is the endoscopic approach. I think this is something which is new and which we can use for apical tumors, because this is for the orbital apex is, what they say, high value real estate, and the chances of causing an optic nerve damage is real. So I think it's very helpful to have another approach to sort of help us with that, what we call the 4-hand technique, where you're doing a combined transorbital and an endonasal endoscopic approach, where what you can do is open the orbit through either the caruncle or laterally, and then you have another set of hands with the endoscope. So you have illumination from one hand, and then you have an approach from the other side, and that's really helpful for these tumors. I think you can really improve the outcomes that you have with these tumors. So typically we use it for medial, orbital apical tumors, and the way to approach this is you can make a transcaruncular incision, and then you can go endonasally as well, dissect the medial wall, and what you can do is just push that tumor out from the orbit into the nose and take it out. So I think it definitely makes it safer, though still it's a very, very high high value real estate. There's still chances of causing optic nerve damage. But I think this is one of the newer things that tend to do really well. The last thing that I'm going to talk about in terms of minimally invasive orbital surgery, and we have done a lot of work over here at AIIMS with this. I think bleomycin is a fantastic drug for any orbital venolymphatic malformations. We usually use a concentration of 1 unit per cc over here, and I think it just has fantastic results. Dr. Nikita, who was a JR at my time, this was her thesis, and this is one of the patients. This was her preoperative image.
Pallavi, I'm sorry to interrupt, but
yes,
if you could summarize.
We're just done. So yeah, this is her post-op. I think it's fantastic. This is one of the guys I had injected. He looks amazing, no surgery. So just the takeaways, most periorbital incisions in general tend to heal well. We can use the endoscope for orbital apical tumors, and injectables are fantastic. So thank you.
Thank you. Thanks. Great.
Thanks, Pallavi. It's always good to hear to your talks. And yes, I think you covered the topic very well. We now have, yeah.
Any questions?
Yeah, actually she has added a little pearls also from a UCLA fellowship that we can make out, and that's really nice, Pallavi. And she's back now practicing in Ahmedabad. All the best. So next we have Dr. Vineet Sehgal, who will be presenting on role of ocular Doppler in clinical practice.
Thank you, sir. So I would be talking about the role of ocular Doppler in clinical practice. After my doing this and learning this for 7 years, still I would say I have more questions than answers that
Can we have the screen, please?
No, it's the other. You're running Pallavi's slides.
Yeah, so can we have the screen for Dr. Vineet Sehgal's presentation?
So,
okay, yeah.
So I still have lot of questions than answers that I can basically tell you. So my slides would be basically there. I would talk about what is the concept of OBF, what are the practical modalities that can measure it, and few interesting cases. So we all know that it's not only the intraocular pressure, the low ocular perfusion pressure and low OBF has been also identified as independent risk factors for glaucoma progression. So not only some IOP related factors, but the vascular factors like diabetes, systemic hypotension and low ocular perfusion pressure, they are also important. Coming straight to the point, we have the blood supply to the eye, and we would be focusing on the short posterior ciliary arteries that are supplying the optic nerve head. So where it fits into my clinical practice? So we have a OPD of Sharpsight Eye Hospital, around 50,000 patients per month, and out of them around 2,500 patients are around primary, secondary or mixed mechanism glaucoma, and we are having the best of the facilities and best of the OT. So now where this fits into my practice? So those patients who are having a normal tension glaucoma, those patients who are having ocular ischemia, vessel occlusion, or where I think that there are some undiagnosed systemic comorbidities. In these cases, we can go for ocular blood flow analysis. So the nomogram is this, that if the patient is of normal tension glaucoma or the primary open angle glaucoma where there is a progression even on target IOP, we consider doing a ocular blood flow analysis. So I have the most experience doing the color Doppler because my better half, she is a radiologist and she is doing it for last 7 years. So we have different nomograms, different wave patterns which we get in the different types of arteries, and not going into too much of details. So my learning experience, I'm not saying that it's a big experience, but we have done around 150 cases so far of every type, and in these cases we basically give a report where we talk about, we write in specific what is the intraocular pressure at that point of time and what are the different values in the different arteries. So I would be just showing 2 cases here. So first case was a 74-year-old male. So after doing a femtocataract surgery, the patient still said that, sir, I am having some blurring of vision. And the first thing is that the cataract surgeon refers it to the glaucoma person and says that Vineet tu hi dekh le yaar kya hona hai ab isme. So everything was fine, visual field, OCT, everything was fine, but it was looking like this patient is not a functional patient. So I was also new. I said, "Chalo yaar, ek baar OBF karke dekh lete hain." So I got a call from my better half, and she said that something we are getting in the Doppler which is not normal. So if you can see here, there are some ectopic waveforms that we are doing. So at the same time, she said, let's do an ocular Doppler in this case also. The patient was only hypertensive, no other cardiac history, nothing like that. And when we did the carotid Doppler, we saw that there is a 100% blockage in the left ICA. So the thing is that first we thought that this is a functional patient, and after doing this, if we saw the ICA, we saw that there was something very big that was there. So that may be the reason of the amaurosis which the patient was getting. So was basically referred for the intervention, but unfortunately the patient could not survive. This was a very, because they are these interventional surgeons, they said that this is too big of a blockage and there would be more chances of bleed at that point of time.
So the patient had TIAs basically, transient
Yes,
tissue.
TIAs.
Oh, okay.
Second case was 75-year-old gentleman. He came to the OPD with the same type of complaints of amaurosis. All ocular parameters were normal. OBF analysis was done and cardiac evaluation was done. So first of all, we saw that there is no detectable left SPCAs in the waveforms. And then we saw that there is some ICA blockage as well. So after the ICA blockage was around 70 to 80%, I think I missed it in the slide, and they did the stenting in this patient. So post stenting, we recorded that there were few waveforms that are coming in the SPCA. So this was the first case in the literature, sir, where we saw that after a vascular intervention, because right now we do not have any specific that we do give dorzolamide or benzolamide or XYZ. We do not have any records right now in Indian literature where we see that the SPCA has actually increased. But in this case, we saw that there was a reversal of blood flow in the SPCA, but with a pinch of salt, the patient was still having the same complaints of amaurosis. So the challenges is there is an expensive technique. We need a trained radiologist. We need to do it again and again. We do not have any long-term or normative data. What is the way ahead? We have to basically calibrate the technique. We have to see that if there is any intervention or drug which can increase the blood flow. I would just take 30 seconds or more. And sir, what we are doing right now is we have got few theses on that because my better half, she's in Safdarjung Hospital. So there are three set of patients which we would be now examining. That the patients who are the primary open angle glaucoma patients who are started on CAI, who are started on PGA, or who are started on beta blockers, what is their parameters. And one thing I have just missed here, the normative data as well for the normal people, because we do not, like a visual fields, we have a normative data, we do not have anything. So changing our treatment just on the basis of any ocular Doppler, I would say no.
So basically,
Thank you,
thanks, great, that was a very nice talk. I mean, have you reported that case where the short posterior ciliary
So we are just, because we are just in process of writing it, and then we are.
The other thing I wanted to ask, I mean, are the orbit people doing Doppler studies to look for tumors and their characteristics, or have you just given up on the ocular Doppler?
I think we had a very beautiful talk by one of the speakers yesterday in the virtual session, where in the TED, especially, they were doing vascular flow markers using the Doppler.
Yes,
and they have described indications for doing a sequential Doppler in thyroid eye disease patients in order to avoid a potential optic nerve compression in these patients, yes.
Okay.
So it has a role in orbital, not specifically in orbital tumors, but congestive pathologies of the orbit, and especially thyroid eye disease.
So that means if a thyroid eye disorder patient comes to us, should we should we get a color Doppler done, and for what? I mean, for what?
That is exactly what we asked the presenter yesterday, and she said the guidelines are not very clear because it's something that's still emerging. But in cases where there is a posterior crowding because of the muscle hypertrophy, we must do a baseline Doppler.
So what does Vineet have to say? Vineet, what do you have to say in thyroid eye disease regarding color Doppler? I think it's something very interesting that Because we see a lot of patients with glaucoma, I mean high pressures and thyroid eye disease, but they do not have any optic cupping. So I think this is something very interesting. We could correlate it with the, and we can send those to you because since you got so much of experience now to Safdarjung Hospital, you have to tell me where to send them. So then, because of the experience, then we need to know. Okay, maybe we can correlate what is happening with the. Interesting. Yeah, yeah.
But you'll have to follow them up after decompression and
Either
see.
we or you,
Yeah.
whoever. I mean, someone is going to.
So now probably we can move on to the next talk, and the next talk is about Dr. Bhagwat Nayak on steroid-induced glaucoma. So Dr. Bhagwat is practicing as a faculty in AIIMS Bhubaneswar. So Dr. Bhagwat, over to you.
Yeah, thank you, sir. Thank you. Respected faculty and dear colleagues, the first of all, congratulations to the RP Center for its 56th Foundation Day. My talk is steroid-induced glaucoma, so I will go first. So this is my first slide. Why I put here? Because when I was a JR, this was the case presentation. In Unit 6, that was the case with 12 years male with VKC. That patient steroid glaucoma, glaucomatous optic neuropathy, then bilateral trabeculectomy, then failed, then that was admitted under us for retrabeculectomy. So I was a JR, I was 100% high responders and 60% low or non-responders in general populations. And topical, periocular, steroids and intravitreal are the major risk factors. So why steroid, what the drug is, basically we know that this is two pathway, inflammatory cascade. One is lipoxygenase pathway, another is cycloxygenase pathway. So steroid, it's inhibit the first gate. It's the phospholipases. So that's why it is a magic drug that can inhibit all types of inflammatory markers. That is a strong anti-inflammatory agent. And these are the types of steroids we use, like intravitreal. Here it is subcutaneous injections, like drops, ointments, pyrimone, as you know, that is very famous. They are using by their self patients, an inhaler and the skin ointment. So ocular conditions like VKC, very much the people start from initially uveitis, pseudophakic, that means cystal macular edema, or any CME light post-vascular occlusion where intravitreal are given. Nowadays, although anti-VEGF has emerged, but still people are doing Arjuts, etc. So we have to keep an eye. And the systemic conditions like arthritis, nephrotic syndrome, interstitial lung disease, other autoimmune disease, as you in a multi-specialty hospital, if you are in ophthalmo OPD, every alternative, that means OPD, the children will come with now to roll out the steroid toxicity. So history, as time is short, 1950, the first they reported the IAP, riser IAP by ACTH, and as you know, the Becker and Mills and Armal.
We'll have to continue, finish quickly.
Oh, okay.
Just last two slides, Bhagwat.
Sir,
There's no time. There's just
okay, so what is the mechanism basically? The steroid decrease the facility of aqueous outflow by stabilize the lysosomal membrane of the goniocytes, inhibit phagocytosis by endothelial cells, and increase the expression of collagen, elastin, fibronectin, induce the expression of cyanoglycotin. And these are the
last two slides.
sir, so much. Oh, okay. So treatment of steroid glaucoma, stop steroids, and these are the algorithm. After starting topical, systemic and depot, check it 2 weeks, check it 4 weeks, check it 1 week if you are given depot, and after that you will have to see whether it is working or not. So what are the take-home message? Do not use steroid in all allergic conditions in every red eye. Avoid steroid in high-risk patients such as diabetes, myopes, positive family history. In weak cases, use steroids in severe refractory cases. Use low potency start like fluoromethalin, inmethylene, or lotifret. Take baseline IOP, note these findings before starting steroid, and regular IOP monitoring after starting steroid. That should be done by every OPD. So thank you for your attention.
So how common is VKC in Odisha and Bhubaneswar area?
Sir, VKC in that area is not so common like in Delhi, like in north. So, but patient come with young patient. Yeah.
Yeah.
Very common in our place. What is said, that I am seeing
So,
cases in the particular this season, March, April, we are seeing 20 to 30% of children come with it, and they continue steroids. They know that steroids are best drug, and they continue without taking any permission or anything. They go to the market, go to the shop, they get the drug, and continue. And they were very happy. After 1 or 2 days, they get the drama. So they come to.
So which part are you practicing, sir? Which
no,
part? Behrampur.
Sir is South Odisha. Basically, we are a referral hospital, like a multi-specialty hospital. So but that patient might not reaching us, no. So, but what that is common in every part of India. The over-counter drugs.
Yes, because we published this where we found
Hi, you are
that there is an increase of the VKC cases in North India. So you have to see over a period of time whether the
no,
VKC
sir.
is actually
I am saying
increasing.
that what in the number of seen we here in Delhi, that amount is not there in our hospital, our area.
But whatever
But
it
yes,
is,
but in
let's
this
say if you see
months they are
in
coming.
2023 you've seen 10 cases.
Yeah, yeah, yeah.
In 24 have
Oh,
you
okay,
seen
huh.
20
That-
cases?
that- that-
in
that
25
increasing.
you've seen 40 cases.
Okay, sir.
So you need to show us a trend whether it's increasing or decreasing.
Yes, sir. Yes, sir.
Jayanand, till then you can probably set your slides.
Okay, ma'am. I will not take much time.
So thank you, Dr. Bhagwat. Next we have Dr. Jayanand Urkure, who will be presenting on intralenticular foreign body. So he was a great surgeon, anterior segment trained in RPC. So Jayanand, from you.
My PPT is not there, I think. Like, no.
Can we have the presentation, the 7th presentation, intralenticular foreign body, Dr. Jayanand.
It's not there.
So maybe till then, Manthan, you can present while Jayanand takes care of his PPT. Next लगा दो आप तब तक.
आनंद उर्कोड़े हाँ
कौन सा ये वाला
हाँ दोनों में से ये
यही वाला ना
I think, Manthan, you go ahead with your presentation on traumatic cataract, the tips and tricks. So Manthan has also been a resident and a senior resident here, trained in cornea refractive. So over to you, Manthan.
Thank you, ma'am. First of all, I'd like to thank organizing committee to giving me such a wonderful opportunity. As we are running short of time, I directly come to one interesting case that we have reported in BMJ case report, showing importance of slit lamp examination and various imaging modalities to diagnose a pre-existing PC defect in a case of traumatic cataract. So it's a case of a 12-year-old boy with history of blunt trauma, 1.5 months back. Patient presented with us with vision hand motion close to face, other eye was normal, and on clinical examination, on slit lamp examination, anterior chamber was very deep, anterior capsule was flat, and there is a sinking cortex sign. With keeping three main important signs in mind, we are suspecting of pre-existing PC defect, posterior capsular defect in this case. So we done few modalities, imaging modalities to confirm the pre-existing PC defect. We have done immersion ultrasonography and UBM. It is showing clear-cut picture of PC defect with lens matter in anterior vitreous. UBM picture is showing clear-cut. There is a oval shape PC defect with lens matter in anterior vitreous. So keeping this in mind, we have performed lens aspirants in the case with in viscoelastic, so it can prevent the vitreous to prolapse in the anterior chamber. Now we are doing anterior vitrectomy. You can see vertically oval shaped pre-exit showing with blue arrows. Its margin is fibrosed, and there is small showing with blue arrows. Its margin is fibrosed, and there is small circular anterior capsular axis. As we know that there is specific other thing for prognostically evaluate this case, but for optimal surgical outcome, we have to see any pre-existing.
Anterior chamber and total cataractous lens. In the lens, you can see a shiny particle, which was most likely a foreign body. So we ordered a X-ray orbit and CT scan. And this was the clinical picture of corneal perforation with lens aspiration with foreign body removal. And we kept a backup anterior vitrectomy in view of possible.
So you just show us the video, Janand, and then we can
Okay,
conclude.
ma'am, okay.
Okay, I think video would be interesting. So I think it is the RPC that gives you confidence, you know, to deal with all these complicated and tricky cases, the way the residents are handling the casualty. And they see all sorts of complicated, I think the most difficult scenario that you would ever face outside. So this is the confidence that you get from this place. And it's nice to see all the alumni here gathered. No, that's okay. This under.
Air bubble.
Okay.
Right now with the torn capsule, I am trying to make it circular, and also keeping in mind to save the as much as capsule for the secondary oil implantation. So here we can see a margin of capsular excess as well as the intralenticular. There was second small foreign body also which was come up with the intraocular magnet. So that is the advantage of using magnet. And now I am continuing with the lens aspiration. And during lens aspiration, I could see the deepening of illumination. You can very well see a large posterior capsular defect here, along with the defect in the anterior highlight face. So I am continuing with the aspirating the rest of the anterior lens matter. And I could complete the entire case without dropping the lens matter into a vitreous cavity.
Very nice.
And now I'm bringing down the pupil with the pilocarpine, the wound hydration, along with the AC formation, and the suture was buried, all the suture were buried at the end. Sorry.
I think very nice, Janet.
Very
This
nice.
was really
Janet.
nice.
Thank
made
you,
our
thank you.
day.
Yeah, it was a very nice video. And did you use any viscoat or anything over the vitreous so that it doesn't come? Viscoat or something while you were aspirating?
I should have used a diluted tripod to better visual the vitreous. That I should have done better. I mean, in that case. And the second case, because it was a soft lens matter, so
it just
it's
came
hardly
out.
need a yeah.
Must
If it
not-
is, it would have been harder cataract than.
So you did
that
it
case.
under low settings?
Yeah. Yeah.
Okay. Thank you, Janet.
Okay.
So I think now we can move on to the next session. Dr. Swati is already here. Ma'am, over to you.
A big thank you to our moderator and our chairpersons. With that, I would like to welcome the moderator for next session, Dr. Swati Phoolzhele. I would also like to invite our chairpersons, Dr. Rohit Saxena, Dr. B.S. Goel, Dr. Santhan Gopal, Dr. Pravin Vasist, and Dr. Rebecca Dhiman. I would request the chairpersons and the moderator to kindly take their seats on the dais. One important announcement to all the speakers, please upload your PPTs and please get your videos checked. We wouldn't be able to play the videos from here because we are running short of time, and each speaker will have 6 minutes for their presentation.
Good morning, everybody, and welcome to this session on strabismus demystified. I welcome the chair on the dais. I have Dr. B.S. Goel with me and our past alumnus. Welcome, sir. Welcome back to AIIMS. I will also request Dr. Santhan Gopal, Dr. Praveen Vishisht, and Dr. Rebecca to please come on the dais so that we can start the session. We will start with the first talk, Dr. Santhan Gopal, who's going to give our keynote address on orthoptech. It's a new device. He has developed an absolutely indigenous, made in India instrument that helps us to treat visual disorders, particularly amblyopia. So I'll request Dr. Santhan Gopal to please start his talk.
Good morning, everybody. I sent it on there. No, here. No, kahan ja rahe ho yaar? That one. Be that as it may, this instrument is useful in treating a number of disorders. I started it as amblyopia of various types. But the users told me, no, it works in intermittent divergent squint, it works in esotropia, it works in fourth nerve palsy, it works in sixth nerve palsy, it works in optic atrophy, and it works in congenital heredomacular dystrophy. I was quite surprised, and I used all of them I treated, and it works. And they taught me where it works, although I was the inventor. So it brought me down to the ground. I told them, give me your opinion. So they gave me this opinion. From layer 4C beta, it goes to temporal cortex, and from there it goes to parietal cortex. You may say, why parietal cortex? These are all extra striate areas which are important for vision. Now the M cells go to LGB 1 and 2 only, and from there it goes to 4C alpha, and from there it goes to superoparietal area, and then it comes down to the parietal, posterior parietal area. Posterior, it's called PPC, posterior parietal cortex, or global sensory motor integration center. Now where is orthoptech here role? The role of orthoptech here is, there are what are called as top-down impulses. That means impulses coming down from the extrastriate areas to the layer 4C beta in occipital cortex. And they stimulate the 4C beta instead of the retinal stimulus. Instead of this electrical activity coming from the retina, the top-down impulses stimulate the 4C beta in occipital cortex. This is how it works. The next question is, how does it work? For that you need to know the synaptic transmission. When the normal retinal impulse reaches the presynaptic membrane in layer 4C beta, the normal electrical impulse releases the glutamate. It's a very secret amino acid in the brain and very well regulated. You can take orally kilograms of glutamate, nothing happens. But there are ways to stimulate this glutamate secretion. So the glutamate goes across the sinus, goes to the postsynaptic membrane, and stimulates the release of a burst of nitric oxide. Cloud is released, which diffuses rapidly back into the presynaptic membrane and stimulates the presynaptic membrane again. So in amblyopia, where is the problem? Is the problem in the glutamate release? Problem in the glutamate uptake by the NMDA receptors postsynaptic membrane? Where is the problem? If we understand the problem exactly, the amblyopia treatment is very simple. So the top-down impulses coming from the frontal eye field area and the parietal area, they end up presynaptically and postsynaptically. And presynaptically, these top-down impulses release the glutamate, and in the postsynaptic membrane, the top-down impulses release nitric oxide. And therefore, the vision improves very rapidly following treatment with this. Because with occlusion, no matter how long you give, there is no nitric oxide release by the postsynaptic membrane. Whereas, and in fact, 40% of all the afferent impulses going to the brain are from the eyes. And the remaining part of the body is from the, they give 60% to the brain. So no wonder eye is most important, and RP center is even more important. Thank you very much.
Thank you very much, sir. An excellent presentation, and as sir said, the instrument is here available, and we of course will be installing it shortly at RP Center. So thank you again for giving us an opportunity to evaluate that. My next speaker I will welcome is Dr. Praveen Vishish, who will be talking on refractive errors in India. He is the head of community ophthalmology at RP Center and one of the leading researchers for community eye care in India and possibly in the world. His publications are phenomenal. His experience is, of course, outstanding, and I'm very grateful that I have the opportunity to work with him for refractive errors. So, Dr. Praveen Vishish, please.
Thank you, Dr. Rohit, for such, I don't know the right or wrong information, but it's really great. In fact, I'll be talking about some component of refractive error in India as a overall burden and strategies for this thing. In fact, as per the World Vision report, which was released in 2019, currently 2.6 billion people are myopic, with uncorrected myopia. And it is estimated that by the year 2050, there will be 5 billion people with myopia. You can understand nearly 50% of population will be myopic by 2050. You can understand huge burden. Beside this, 1.8 billion people are presbyopic, and by 2030, we're expecting 2.1 billion people to be presbyopic. The worst part is that in this region, the Southeast Asia region, the coverage for even presbyopia is just 25%. 75% people who required presbyopic glasses, they are not having presbyopic glasses. And the two key global indicators as per WHO is the effective refractive error coverage and effective cataract surgical coverage. These are indicators for universal health coverage, and as part of the 73rd World Assembly, it was taken as a key indicators globally. As far as refractive error coverage is concerned, it is for distance as well as for near vision, and broadly it means people who are actually having the met need for refractive error, either provided refractive surgery or glasses for spectacles for refractive error, divided by total people who met need plus unmet need or undermet need. Similarly for near vision, it is also met need divided by undermet or unmet need. I would like to share the status in India. We conducted National Blindness and Visual Impairment Survey. As per this survey, refractive error is not an important cause of blindness, but it is the major cause of early visual impairment. 70% of visual impairment is due to refractive error. And among children, around 90% of visual impairment is due to refractive error. Unfortunately, the national survey data do not provide information about effective refractive error coverage, which is the current need. And if we have to achieve 40% increase, we should know the baseline data of refractive error coverage in our country. In fact, the national survey showed that, again, the similar finding, 74% people, they do not have coverage for presbyopia, and the prevalence of uncorrected refractive error is 11.5% country. And beside this, after cataract surgery, one of the important complications, the reason people are not having good vision is refractive error. So this is another area which we have to look for. As for the key strategies under Government of India concerned, there are two key strategies. For children, it is school vision screening program, and for adults, it is basically for vision centers. In school vision screening program, we all know that in 1994, Government of India is ophthalmic assistant for further refraction. And thirdly, the spectacles are provided through a contract through the district hospitals. The Government of India target is having 1 million children to be given vision center for every 50,000 population in country. And this integrated primary eye care center is the approach for this thing. And this is the only mean how we can achieve universal health coverage or universal eye coverage in country. But unfortunately, again, against a target of 20,000 vision centers, we just have 4,000 vision centers in country. The primary eye care is the important, I think the most important priority as far as eye care is concerned, and it is still lacking in our country. We can't achieve universal coverage or effective refractive coverage, whatever is needed, without these vision centers. This is one area we have to work on, but we have very good examples. Some of the examples like Orbis Reach program, they provided spectacles to nearly 4 million population through their school-based programs. Vision Spring initiative. Now they have indigenous spectacles, and Vision Spring is having contract with 18 states in the country to provide spectacles at the in schools basically. Mission for Vision, other INGOs, they have vision of having 500 vision centers themselves alone. This is also a very good example. Then one example for Karnataka, Nayonika Vision Well model. I was surprised that they started with some schools. Again, they are working in nearly 20 states in the country and develop a very good school vision screening models. That means feasibility is there. Unfortunately, government sector, I have not seen even a single hospital who are having primary eye care facilities, vision centers. I doubt about this thing. Luckily, at RP Center, we have initiated this approach. We have 27 vision centers in daily NCRs. Most of the centers have been started with the help of local NGOs or international NGOs. I believe that similar models needed, at least at the government sectors, in all the medical college, in all the district hospitals in the country. Thank you very much. Thank you.
Thank you, Dr. Praveen. An excellent presentation and really opening our eyes to the need for primary eye care. I'll invite Dr. Saranya Devi now, who will be talking on the next important thing in glasses in children, when and how to prescribe. Dr. Saranya is an ex-senior resident from RP Center. She's now in Chennai and going to join, I think, the Agarwal Eye Center. All the best, Saranya.
Professor Tityal sir, the Chief of RP Center, and a special thanks to my guru, my mentor, my inspiration, my motivation, Professor Rohit Saxena sir, and special thanks to Dr. Amar Pujari as well. So I would like to say you can always take a resident out of RPC, but you can never take RPC out of a resident. So it's like a homecoming, coming back home. So thank you for including me in this wonderful scientific sessions. So I'm going to present on glasses in children, when and how to prescribe. I'm presenting a synopsis from what I have learned from the experts. So how is it different? Because we all know the children's eyes are different, and the challenges we face are like they are uncooperative, they have strong accommodation, and the ocular growth keeps happening. So it's not like one rule for everybody, it has to be a customized approach. So newborn eyes, the parameters are entirely different. The axial length grows and the keratometry comes down, and there are changes in other refractive components as well, because of which this process occurs. This is called emmetropization. This is the definition of emmetropization. It is a process where the refractive components and the axial length of the eye changes postnatally. So usually at birth, most of the children are hypermetropes, and a few can have astigmatism as well, but they resolve mostly by 3 years and achieve emmetropia. This is a normal process, but you have to remember special cases like prematures, where because of conditions like ROP, they can have myopia. So this is a graph showing how initially hypermetropia management has been discussed in detail. Here the important point to be noted is, before 3 years, at least one vision examination, vision screening is essential. I don't know how many parents follow this, but we should create awareness about this in the common public. And generally, what sort of symptoms they present with? Difficulty to identify the face. The child faces frequent falls, keeping the screen close, because we are living in a digital era where the children are more exposed to screen than adults also. So keeping the screen close is again another symptom we should consider. And generally, they don't copy from the board. They copy from their neighbor in the school. So these are the various symptoms with which a child can present to us. So how do we go about it? We have to do cycloplegic refraction, because children have strong accommodation, and which cycloplegic agent to choose. This again, the same article, the National Consensus Statement article, has suggested in children less than 5 years, give atropine ointment 1% for 3 days, and then you call the patient on the 4th day. And they have suggested rice grain size of ointment is to be instilled inside the eye, and then we call the patient back for myopia from happening. So there is a cutoff for individual refractive errors, and there is a cutoff for anisometropia as well. If the myopia is more than 5 to 6 diopters, and the difference in both eyes is more than 3 diopters. If hypermetropia is around more than 5 diopters, and difference is more than 1 to 1.5 diopters. If astigmatism is more than 2 to 3 diopters, and the difference is more than 2 diopters, then we should go ahead and do prescription. There are various tables. Again, we have a different table for our children, so we can follow this and prescribe for children, because most of the general ophthalmologists will have their relatives, nieces and nephews coming with the refractive error. We should not jump up to immediately prescribe glasses. Rather, we should look into the details and customize. So that is why I'm going to discuss a few simple case scenarios to highlight the certain points which we should always remember. Here is a simple case of what to prescribe. A 6-year-old child, no symptoms, no strabismus, just walks in for vision screening. You do refraction and you get +1 diopters. Please don't prescribe, because we all know that hypermetropia of up to 4 diopters also the child can accommodate and have good vision. So this is a simple case. In case of hypermetropia, we always prescribe to improve the vision. If there is asthenopic symptoms, we have to relieve that, and to prevent amblyopia. And the most important, to correct accommodative component of the esotropia, we have to give glasses in hypermetropia. Here is another case scenario, a 4-year-old boy with esotropia of 30 prism diopters for distance and 40 prism diopter for near, with this kind of cyclorefraction. We all know in esotropia we have to give full cycloplegic refraction. So how to go about it? In case of esotropia, do full cycloplegic refraction and always give full correction to relieve of the accommodative component of esotropia. Again, you have to check for distance near disparity with +3 glasses. If there is high AC by A ratio, we have to prescribe executive bifocals. In case of exotropia, if there is myopia, always correct myopia and astigmatism. But there is no concrete consensus on hypermetropia, whether to undercorrect or fully correct. But the aim is to improve the vision. We should motivate the outward deviated eye to see properly to achieve fusion. So we have to calibrate and then decide from case to case. This is another case scenario where is a 2.5 years old boy with -2 myopia on cyclorefraction. He always watches TV sitting close. Even though the 2.5 years old boy, the visual need is only near need, but now there is a TV in his world. So we have to prescribe either take the TV away or give undercorrection to this child. There is this another case scenario where there is huge difference in the refractive error, but the child is 14 years old, so we can go ahead and prescribe contact lenses to avoid anisoconia, because anisoconia in itself is a different topic to be discussed, so I would switch on to the next.
Dr. Saranya.
Hurry up. You will have to hurry up.
Yes, sir. In special situations like Down syndrome and aphakia, pseudophakia, ROP and subluxated lenses, we have to give full prescription. In astigmatism, always remember oblique astigmatism is more amblyogenic. Astigmatism in different axes is more amblyogenic, and the threshold decreases as the age increases.
For the child, but always regularly follow these children up. Thank you very much for the opportunity.
Thank you, sir, for that wonderful eye-opener talk. We now have Dr. Vinita Gupta, who is faculty at AIIMS Rishikesh, with us. She will be speaking about infantile esotropia management and the controversies associated with it.
PC Foundation Day for inviting me here. Yeah, so I'll be talking about the controversies and the debatable things which are there while we are dealing with children with infantile esotropia. So whenever we see a baby like this, the factors which we need to consider are the need for early intervention, the difficulty of the reliability of measurements in these children, delayed overcorrections if we do large amounts of biomedial recessions, and if you're doing a later surgery, the accommodated component which comes into play with a high, maybe high AC by A ratio also coming in, and the coexistent other abnormalities of movements which are there, like the inferior oblique overactions or the DVDs or dissociative vertical deviations which are there. Then we have to look at the total number of surgeries which such a patient may require over the lifetime and the repeated risk of exposure of general anesthesia. So the first thing which I'll talk about is the timing of intervention. Is an early surgery or a late surgery which is better for these? So as an ophthalmologist, the question which comes into my mind is, as an ophthalmologist, can I repair the brain which is being affected as a result of the binocular disruption which is happening in these children in cases of infantile esotropia? So there's a Marshall Parks who, and the previous, all the other ophthalmologists over the last 25 years have done a lot of work on that, and the Marshall Parks legacy, which says that even if you're able to bring them to what is monofixation syndrome, we are able to achieve some degree of binocularity. So that is what the work of last 25 years has been saying. So all the proponents of early surgery say, obviously, you will be able to achieve some degree of binocularity, especially if it is done within 60 days of the onset of your strabismus, not exactly from the onset, from the birth, but from the onset of strabismus. So that is what Ing et al. Had done in a study, and it showed that obviously the duration of misalignment, if you're able to repair and align the eyes by whatever way, whether you're using Botox or whether you're using a surgical alignment, you will be able to achieve some degree of binocularity. And another study by Girth, which has shown that he has studied this effect on the cortical motion by using multifocal VEP, and he has achieved that obviously, if you're doing surgery at a standard age, that is after the age of 1 year, obviously it has a worse outcome if we do a surgery before the age of 1 year. And this has been shown by having more symmetric recordings on the multifocal VEPs. So the pros for early surgery is obviously better binocularity. There are a lot more studies. I'm not going to the details of the studies. Can I have a pointer? This is not working. It's not working very well on this. So there are various studies which have shown about the better binocularity. So obviously when you are improving the binocularity, they have seen that obviously the amount of steropsis, which is achieved as almost 13 to 14% as in the early group compared to the late group, and it is beyond just the titmus fly. So some level of Randot stereotopy may be possible in these children by early surgeries. Better binocular visual fields, improvement of the visual behavior overall, and better cosmetic appearance, obviously. So usually, what do we do in early surgery? We are operating usually at the age of 7 to 8 months of age. But the cons against the early surgeries are obviously, it is difficult to differentiate if you are looking very early at around 20 weeks of age, at 4 months of age, whether it is actually true misalignment or is it just an infantile misalignment which is happening with the developmental part. And there are not many studies which have seen that around I would say 20 to 27% infants do have spontaneous resolution occurring. And even the pedic group has done a large series of studies in which they have said if the deviation is less than 40 PD, if it is variable or intermittent, and especially if the children are being examined at roughly around 20 weeks of age, then spontaneous resolutions may occur in these cases. Also, another thing which is proponent for the other group of people who are talking about, who are favoring the late surgery, say that almost 49% of the children have coexistent systemic or neurological abnormalities. They have coexistent systemic ocular diseases, and especially developmental delays or CP, which may not be diagnosed at that particular time, at 6 months. We may not be able to diagnose them. So in children with development delay, they have also an unstable course. So the proponents of late surgery, what they say, difficulty in measurements, the concern regarding general GA at that age, difficulty in doing the surgery per se, post-operative poor control, they may be rubbing the child may rub the eyes, poor prediction of your results, and also does actually the stereoacuity matter, especially when they're for their academic performance as they grow up. Also the issue of budget, repeatedly attending the clinics, and the need for having a standardized or a specialized anesthetic infant care. So, as I would say, there are still two schools of thoughts, but obviously I would go for early surgery, which is our hopeful prediction of giving the best amount of binocularity which we can. Late surgery is easy to justify, but for all the reasons given by the proponents of late surgeries, but I would still favor for early surgery as a hopeful prediction. Now, the second debatable thing is your, obviously, Botox versus surgeries. So Botox, obviously, in early cases, when we are doing it early, can give us stable satisfactory results. It reduces the maximum angle of deviation, allows for the development benignity by the time we are able to do the surgeries, and allows it to be carried even on smaller angles. And there again, there is a meta-analysis of 9 studies which has shown that the mean change of deviation is around 30.7 prism diopters. Total immunizations required is not much, 1.4 to 1.5 times, effect lasting for 8 to 12 weeks. And so there are various studies which have again shown that the success rate is similar to the surgeries, and in terms of gross stereopsis, and no difference in the binocular alignment. And the median age of treatment is obviously earlier with the Botox group. But the proponents of surgical group, obviously they say restoring alignment is our best chance, because obviously it gives us a more stable and more longer duration of alignment, and incidence of undercorrection is less as compared to Botox. So the evidence has been given. Obviously, as I said, the longer duration and more consistent alignment is achieved with the surgery. Number of GA and the risk of GA by repeated surgeries, by repeated GA exposure which may be required for Botox, and the cost which goes up with the Botox is obviously less with the number of surgeries. Surgery, even a single surgery may work. But now, even for some cases, there is a school of thought which says that if you do combined treatments, where if the deviation is less than 40, just do a surgical treatment, but if it is more than 40, in the same sitting, combine it with a Botox injection into the medial rectus muscles. So the consensus for this remains surgery, but Botox can be used in an adjunct. Can I have my slides? Just 1, 2, 3 more debates. Can I have my slides, please? So the next, the slides are not playing. Can I have the slides, please? Excuse me, can I have the slides, please? So third debate is basically the unilateral or the bilateral surgery.
Or you may just conclude if it's not working in want of time.
Yeah,
you have
just
two more talks.
slides. So it's basically, so unilateral versus bilateral surgery, there's no much debate about it. Its consensus is a bilateral medial rectal weakening, which is required because unilateral surgery may give you undercorrections. And the next is to operate inferior obliques or not. So we just need to judge whether there is a primary inferior oblique overaction or not. So look for a large X-cyclo. If we can do a fundus capture of the image in these cases, look for a torsional AHP or no depression deficit. If there is none of these, obviously think of a primary inferior oblique overaction is there. So these 3 things we have to remember: V pattern, elevation and adduction, or a cyclotorsion. If it is documented, then you can operate on an inferior oblique. And the surgery for choice for this would be a recession, or if it's a coexistent DVD, an ATIO would be the surgery of choice. Don't do myectomies. And last is what is occlusion before surgery or after surgery. Most of these children do not have amblyopia because of the cross fixation which is there, and they tend to switch fixation midlines. But if there is amblyopia, do treat amblyopia at the same time. Equal vision before surgery is always more important to get more reliable alignment results in your surgery. Thank you.
Thank you, Dr. Vinita. We now have Dr. Amrita with us, who is also an alumni of RP Center. She is currently in Amrita Eye Hospital, heading the Department of Ophthalmology there. She will be talking about transient visual loss and its management.
Good morning, everyone, dear seniors and friends. It's an honor and pleasure to be here, and I'm going to be talking about my neighbor who came to me early morning one day in my clinic, complaining of having had 3 attacks of transient visual loss in the last 10 days. On examination, she was in many vascular occlusive diseases of the eye, and also acute cerebral infarctions have been found on subsequent MRI imaging studies in patients who presented just with TMVL, and it is highly recommended to evaluate patients with isolated acute retinal ischemia urgently. So in this patient, on detailed history, we could not have elicited any other specific symptoms like no history of fever, weight loss, headaches. Other than headaches, she did not have any temporal pains, she didn't have any neck ache, no other symptoms. So we immediately ordered urgent investigations of CRP, including platelet count, ESR, CRP. We did an FFA, and then we took a neurology and a cardiology consult. Everything was normal except raised ESR and CRP. MRI was normal, CBC was normal. We made a presumptive diagnosis of giant cell arteritis, planned a temporal artery biopsy because a patient above 50 years of age presenting with TMVL, we really have to rule out giant cell arteritis, and immediately decided to start the patient of high dose of steroids. A little bit about giant cell arteritis. As we all know, it's an immune-mediated systemic granulomatous vasculitis which affects medium and large arteries. So the patient can present with vascular headaches, scalp tenderness, a lot of rheumatic symptoms, constitutional symptoms. Even in the eye, the commonest thing that we see in GCA is acute arthritic ischemic optic neuropathy, CRAO, cilioretinal artery occlusions, extraocular muscle ischemia presenting with diplopia may be seen in some cases as a presenting feature. I will not go into the details of the classification criteria of giant cell arteritis, but this nice article by Professor Harry had shown very conclusively that the most strongly suggestive clinical criteria are jaw claudication, increased CRP and neck pain, and raised ESR, but ESR was found to be normal in some of his cases of GCA, biopsy-proven GCAs. So this is a very important slide. I have put it here to show that about half the patients of GCAs would have ocular involvement. Of these, about 40% would have a preceding history of transient monoocular visual losses, even binocular visual losses, and about 2/3 of them would go on to have a permanent visual loss because of AION, CRAO, or combined CION, cilioretinal artery occlusions. And even if the patient does not have any systemic features like they had in our case, it's an elevated inflammatory marker profile is a good enough indication to start these patients of steroids, because as much as 1/5 of the patients with occult GCAs would not have any systemic features. Temporal artery biopsy still remains the gold standard, though there have been many advances in the treatment of, in the diagnosis of GCA by various radiological methods. And the treatment recommended is to start high-dose oral steroids, except in patients who had amaurosis fugax or who have severe ocular visual loss. In them, we can give them one dose of 1 milligram IV prednisolone before starting them on oral steroids. Repeat ESR and CRP every 2-3 days till we get the lowest possible stable ESR CRP values and then taper very, very slowly. How long do we need to give to the steroids? It has to depend on cases. It can be continued at least for 2 years or even more than that. So don't be in any hurry to stop these steroids once you have diagnosed or you suspect in GCAs, because it can cause recurrences. And it has been shown that patients who were started steroids early, this again is a study from the great Professor Harry, in which he showed that if you can start steroids at the right time, at the right dose, you can prevent visual loss in these patients. And even among the cases, if you start early enough, within 5 days, you can prevent visual loss even in patients who have some visual involvement. So that is why I took this case, just to summarize and to point out these issues, that blindness in GCA is preventable as long as you have a high index of suspicion. Do not ignore the symptom of transient monocular visual loss. And even if the patient has a normal ESR, CRP is a more reliable indicator. And don't be in a hurry to stop steroids. Start them early, start them aggressively, and continue them. In my presentation with my tribute to Professor Harry, just for all your information, he himself suffered from diagnosis in mind when we see such patients. Thank you. Thank you.
Thank you, Dr. Amrita. It is often underestimated, but TVL is an important presentation of GCA, and one should not forget to invest and about 7th nerve palsy and way to manage it.
Back to
this case. Now, this is a 27-year-old female with the complaints of abnormal size of the right eye since birth, sometimes watering and occasional redness. So she was really disturbed by the enlarged size of her eye and the fact that it didn't close properly. And what we could really, the loudest complaint was that she was being rejected for marriage, and it was really disturbing the whole family a lot. So we realized that we not only have to improve her, we have to actually now do something, be the Panditji to try and get her married off. So what are the problems that we were facing? There's the lag of thalamus, there's the tremendous lid lag, and you can see there is scleral show more laterally, and of course a lot of lag of thalamus and the abnormal lid fold. So now we have a whole lot of problems to deal with. The congenital 7th nerve palsy is a little different from the actual 7th nerve palsy that we see commonly, like Bell's palsy, because over the years there's been some kind of compensation and some amount of spasticity of the orbicularis. So the lid position, and to counter the spasticity and the lid retraction, gold is chosen because it's inert and easily tolerable. The trial weight can be any metal. We used steel because I'm in a multi-specialty hospital. Stainless steel wires are very easy for me to implanted on the anterior surface of the tarsal plate. So how do we decide what is the weight required? So what we did was we taped stainless steel wire and we saw how much did it bring the lid down. We weren't happy with the first one, we did it again. And once we decided on the correct weight, we then had to ask a goldsmith to make this design. So we gave him the diameters and what all we required. And then he made us a gold plate. So again, we taped the gold plate onto the lid and see if the correction is enough. So this was the first time we were doing it with this goldsmith, and we were not happy, and he was really kind, and better less. Decreased lag of thalamus, and more importantly, the girl was so much more confident. She was actually doing MA, very qualified young lady, but just upset because she was getting rejected. And so this is her final result. And she was very happy, though we are still waiting for the mithai. Yeah, thanks.
Thank you. That was indeed an interesting
सोने के
case.
दांत सुना करते थे, अब सोने की पलक भी आ गई. I think, no, not for you alone. I think there had been very good presentations. Orthoptic role has been emphasized and he really outlined the basis behind it. The good part about it is that one ganglion cell is connected to several cells in the brain, so there is always a chance. And a good amount of review has been brought into for myopia. I think we need to do a lot of it as the statistics show that it is increasing. Timely prescription of glasses and all that is certainly going to help. And I think the whole picture is that we have gained tremendously from the lectures in this series. Thank you very much.
Thank you, sir. Thank you, everybody, and the speakers for a wonderful session. Thank you, everybody, and we'll hand over to the next session.
Hello. Do we have Dr. Aman Pujari in the audience? Okay. With that, I would like to welcome the chairpersons for the next session, Dr. Nupur Gupta, Dr. Tejas Shah, Dr. Ramandeep Singh, Dr. Prafull Maharana, Dr. Devesh Kumawat, and Dr. Saurav Verma. I would also like to welcome our moderator, Dr. Amar Pujari, and I would request him to take the... Request everybody to please settle down. We are about to...
Well, this is a patient who was referred to us as having undergone operated elsewhere, and if you can see, there is hardly any iris tissue from over here, and you can visualize up to this extent. There was a total loss of the iris tissue, and aphakia was there, was sent to us for a scleral fixation of IOL. Of course, we wanted to do scleral fixation of IOL, but with such a large enlarged pupil, it would not really make him happy, and that's why we decided to go beyond it. And so if you look at, I have done a scleral fixation of IOL, and then I would be showing further down how the steps we proceeded. So we create some side ports over here, fill the antechamber with viscoelastic, and with the help of a vitreous forceps, I am trying to unroll the iris, whatever is available, and assessing how much is the iris tissue which is available to me with which I can play. And surprisingly, to my surprise, there was a total retroflexion of 360 degrees iris. The iris was really fragile, as you can see here. And so we had almost 360 degrees iris, but the pupil was quite distorted. So I had to do 4th-row knot pupilloplasty. For that, we create a side port at 7 and 5 o'clock meridian. Through it, the tenoproline suture will go. So these are the side ports being constructed, and through the railroad technique, I put a tenoproline suture which will engage the iris tissue at 7 o'clock. Disinsertion, more than 180 degree disinsertion of iris root with a traumatic cataract. Well, of course, when you are doing a phaco surgery for this particular patient, you have to keep this available iris tissue away from the active ports. And for that, initially, before doing phaco, I am creating side ports and using iris hook to get it out of my active ports, and this is what precisely I do. So after having retracted the iris out of my suction area, main area of interest where the phaco was supposed to happen, I have done the phaco emulsification with IOL implantation. After that, I need to anchor this iris root at 9 o'clock meridian. This is my first intent. And so with that intent, I create a small scleral tunnels over there, because the knots of the tenoproline suture has to be already intrascleral. And here goes the tenoproline suture from one end, and again it is anchored at 9 o'clock meridian. So once I have anchored over here, I realize the whole pupil is drawn this time. At 9 o'clock meridian, and so it is not even acceptable to me. So I do a 4th-row knot pupilloplasty. So it's a combination of iris root disinsertion inserted back with 4th-row knot pupilloplasty. And this is the pre-op photograph, and this is the post-op photograph. Not only IOL has been done wonderfully, but you have put back created an iris pupillary diaphragm. Another case, this is wound repair done elsewhere, traumatic cataract with a iris rolling over here with almost loss of iris tissue. So iris I had up to 7 o'clock meridian. There was a loss of iris tissue from this meridian. So after having done a phaco emulsification with IOL, now I know for sure that this iris I have to get it here, anchor it here. So tenoproline suture is done under intrasclerally after the tunnel, and once I put a suture over there, we realize that there is still a big iridodialysis left over here. So I would be even repairing that part of the iridodialysis, and then I will be approximating the pupil. So this is another anchoring of the iris root dialysis over there. And after having done that, I would assess how much is the pupil, how can I construct. So I need to approximate this iris tissue to here to create a pupil. So with that intent, I do a fourth row knot pupilloplasty, but there is still a lot of iris away from here. So now I will be again anchoring this part of the residual iris to the sclera here by the same technique. So it's a multiple combination of techniques of iris root resinsertion and also, and this is the pre-op and this is the post-op photograph of this particular patient. So you could not only give him a wonderful IOL but also this. Another case of a traumatic disinsertion of iris with subluxated cataract with a vitreous hemorrhage. After having done that, lensectomy, vitrectomy, here I am trying to assess how much is the pupil available, iris tissue available. Luckily, it was the whole iris diaphragm which was available, and my job was easy. I needed to anchor it at 3 places, and precisely that is what we did. And this is the pre-op and this is the post-op photograph of this particular patient. This is a last case I would show. This is the case of it aniridia IOL. Here, the commonest reason why his vision is poor is foveal hypoplasia. Second is his intolerability to the light. So just putting a simple lens is not going to do. You need to put an aniridia IOL in such cases. What we do differently is that in such cases, instead of hooking it with the help of a proline suture, we do a scleral fixation or a glued IOL technique, and that is why we are doing a scleral pockets over here at 10 and 2 o'clock meridian. And after that, the phaco is being done. I will just run through it. And phaco is routine thing. After doing phaco, you need to understand that rigid IOLs, these are rigid IOLs and they are very single piece. Once these optics are gone, we suture that and bring out the haptics through the scleral tunnels here. And once it is externalized, then they are buried into the scleral tunnel, and that gives you more stability. So this is the pre-op and this is the post-op photograph of the same patient, where not only you could cut down on the light which could be more annoying to the patient, he also had a pseudopupil hem. This is another case where we could do a repair, and this is the last case which I would show you. Again, a case which was a pediatric cataract while the haptic got engaged and we had to do a repair. So friends, giving respect to this iris tissue and creating an iris pupillary diaphragm is equally important in rehabilitation of a patient, not just doing a IOL and doing a vitreous surgery. Thank you once more for this opportunity.
Thank you, sir. Any questions? Okay. So we'll take the questions later. So we have our next speaker, Dr. Tejas Shah. So he's going to talk about small pupil phaco without iris hooks or rings.
Good morning, and at the outset, I would like to thank Dr. Tityal, Dr. Namrata, and Dr. Amar also for all the logistics in this invite. Dr. Prashant made my talk quite easy because he stressed the importance of the iris and the pupil. And well, that is something which I actually am trying to talk with you. This is about a simple cataract but with a very small pupil. It's not playing on my laptop. Well, it's okay. Excellent. Well, I cannot control this. Hello? I need to see it on my laptop also. Because this is an unedited video of a surgery which took 24 minutes. And I just wanted, this was for a deferred live surgery. So I need to run it at a 2 times and 5 times speed. Still the bar, okay, there it is. I think I'll be able to do that. Because otherwise it will take 24 minutes to finish. So this is what you end up, and when you look at this, well, you are bound to have the cataract out as well as the pupil round, and probably without any sphincter tears or sphincter. If I can get the counter for the speed. So like I said, this is a deferred live surgery, and the entire surgery took 24 minutes. Well, so what would be your thoughts? How would you be able to tackle this? You want the cataract out, you want the pupil to be round and without any mutilation of the pupil. Well, so what are your options? In fact, we learnt our FACO when there were no hooks, there were no rings, there was not even a bimanual irrigation aspiration. So we were actually forced to do these surgeries and learn all by ourselves without much of a help. Excellent. Thank you. So the first thing that has to be done is a complete iris diaphragm has to be pushed back. Second is that the flap should always be broad and obtuse. The angle of the at the edge of the shearing of the capsule axis should always be broad, and very important is that this capsule axis is not going to run away. Trust me, whatever you do, if you keep your flap flat on the abutting the capsular matter, it's not going to run away. So be bold and do a axis which is bigger than the pupillary margin. If you do that, again, like I said, 50% of your job is done. You may need to keep on coming out in replenishing the viscoelastic inside, but mind well, you need to do that. It is very difficult to do a capsule axis under a high viscoelastic. So you need to be sure to keep putting a cohesive viscoelastic at a place where there is no, you're not actually performing your capsule axis. So in that case, like somewhere over here, right? And it took a long time, probably about 4 minutes, but we were able to finish the axis, and half my job is done. Second, what do you do after capsule axis? Somebody from the audience, what is the next step? Dr. Prashant, what is the next step? Amar, what is the next step after capsule axis? Hydrodissection. Hydrodissection. Well, no hydrodissection. No hydrodissection in such a closed loop, because if you put more fluid, it is going to raise the pressure and the iris is going to come to the wound. So we need to create some space before we put in some more volume of the BSS, right? So now I think I'll go.
If we have all these speakers in the house, if you haven't uploaded your PPTs, please upload it right away at the console. And one more important announcement, let's show some respect to our speakers, our chairpersons and our moderators, and maintain complete silence. If you want to have some personal discussions or a personal call, you can do it outside the hall. Thank you.
Thank you. There is a slight change. Dr. Vardhman Kankare is going to present next because he has next section to attend. So he's going to present smile in difficult situations. Dr. Vardhman, please.
Good morning, friends. First of all, I would like to thank Dr. Titiyal sir, Dr. Rajesh, Dr. Namrata ma'am for the kind invite. And I'm going to discuss with you a topic which is currently making a lot of waves, which is about smile procedures. But I'm going to discuss with you how to perform smile in more complex scenarios. So we all know that smile has actually become a preferred choice of refractive surgery because of its advantage of being flapless and also having less amount of dry eye. The other advantages of smile are not fully proven, such as the biomechanical advantage. I think it is working now. So I think in the centers where the smile is available, currently it has definitely become one of the predominant procedures of refractive surgery. And generally speaking, smile is a very straightforward procedure. You create a lenticule with your Visumax femtosecond laser, then you remove it in one piece by doing dissection, and actually the whole process takes less than 5 minutes. But there were certain disadvantages of smile. One of them was that you cannot correct astigmatism in a good way. And one of the ways that you can compensate for it is by doing what is called as a manual compensation of astigmatism control. So as you can see here, I don't know how clearly you can make out, but there are 2 marks that I have done at the slit lamp. And those 2 marks are going to actually help me manually align your cornea with the femtosecond laser, you have to look at your right eye eyepiece, which has the reticule, and you have to make sure that you are completely aligned with those two marks. In many patients that we see that there is a good amount of cyclotorsion, and if you don't do that, definitely you're going to land up in significant undercorrections. And of course, once we have created the lenticule, the rest of the procedure is very straightforward. Now this is another case in which when we had started dissection, we actually went first posterior and then we had to go anterior because there was a stuck lenticule. So again, this is the Visumax femtosecond laser which is being fired. This is a straightforward case of about 6.5 diopters of myopia. You can see this is the side cut of the lenticule which is being done. This is the small incision. And once I'm going inside, usually I go more anteriorly because I tilt the tip of this instrument slightly upwards, but in this case I went on the posterior side and there was hardly any OBL, as you can see, so the dissection was very smooth. So I actually thought that because the dissection is so smooth, it is because of the lack of OBL, but it was only because I was going repeatedly in the same posterior side. And as you can see, I have now gone to the anterior side by going and tilting it even more upwards. So once I have done that, the rest of the dissection, of course, becomes very, very straightforward. Now this is a smile in presence of corneal scar. As you can see, in this area there is a vertical scar that the patient had because he had an old trauma. And as against our thought process, when we believe that the femtosecond laser does not penetrate the scarred cornea, but if your corneal scar is not too dense, it can very well create a very nice cut. You can see it there. You can see this area where it is slightly undercut is in the center, where you actually have this scar in the visual axis. And now I'm going forward. I'm again tilting my instrument upwards first to go into the anterior layer, then going to the posterior layer, and now with this specialized spatulated instrument designed by Dan Reinstein, I'm dissecting this lenticule in one piece. So as you see in the area where there was this pre-existing scar, I'm very, very careful so that we don't tear the lenticule at this time. Fortunately, this was a moderate myopia, so the lenticule thickness was decently good. So we were not really worried about having any cap tears or lenticule tears as such. So this is the post-op. You can see this small scar still there. This is the post-op, and you can see it's a very well ablated zone. Now this is a case that we have published. This was a patient who had undergone PRK in the past, and after PRK, he has undergone PRK probably when he was just 16-year-old as an enhancement tool for a post-PRK regression or a progressive myopia. Now this is a case in which you can see patient who had very extensive peripheral vascularization. So of course we did not want to make the side cut or the small incision at 12 o'clock because it was full of blood vessels. So of course what you can do with the advent of SMILE is that you can actually customize the incision. So in this case we decided to customize it in the temporal area. And of course if you do that, you cannot dissect this patient on the Visumax. So after this lenticule was created, as you can see now, this is again the Visumax which has docked very centrally, very nicely. And now we are going to start doing the ablation. This is the posterior cut, followed by the side cut of the lenticule, followed by the anterior cut or the cap cut, which is then followed by the small incision which was temporally. Now I shifted this patient to the Lumira microscope. I sat temporally, and then I did the rest of the dissection. You can see the periphery of the cornea is showing neovascularization, and we have managed to completely, let's say, get away from that zone. Now this is a unique case. This was referred to us from our neighboring state. This was a patient who had undergone SMILE elsewhere, but had been referred to us with a progressive epithelial ingrowth in the right eye, which has resulted in a poor visual outcome of 6/36. As you can see, this epithelial ingrowth was isolated in the center, and there was no peripheral contact. The small incision was completely closed, so this does mean that the primary surgeon had probably implanted the epithelial cells when the dissection was done.
Sorry, Dr.
So,
Can you conclude?
Yeah, I'm going to conclude after this. Yes, thanks. So basically then we use the Circle software. The Circle software is actually a software which converts your smile cap into a flap, because we wanted to have the full exposure for the epithelial debridement. And by using that, we actually converted this smile cap into a flap, and then we lifted this flap. After the flap was lifted, we removed the epithelium, not only from the overlying stromal surface, but also from the underlying newly created flap. And this novel use of Circle software helped us to treat this patient and to achieve an excellent visual outcome of 6/9 vision. And this is the case that we have recently published in JCRS. Thank you very much for your kind attention. Thank you.
Thank you, Dr. Vardhaman. So there's one more small change. Dr. Swapna has tried to catch up. So she's going to present next. Then, so Dr. Swapna, please. She's going to talk on ICL combination for Bespoke 6.6. Dr. Swapna, please.
And Dr. Namrata Sharma at the outside. And good morning, ladies and gentlemen. So ICL and various other refractive techniques that we already follow is something that we can use as a bevy of things that we have, from which we can pick out things and incorporate in our practice to achieve optimal correction. So ICL can be combined with multiple techniques. I want the screen to be reflected here also. Yeah, it can be combined with multiple techniques and provide the desired result. Now, why? Because it has a unique placement in the sulcus, which is away from the surface of the cornea, away from the stroma, and also away from the capsule. So so any of these areas can be tweaked to give a desired result. And this can be done in many ways. So either you can use a laser refractive correction, you can use a UVA to stabilize the cornea before you go in, you can use intracorneal ring segments, and the sequence depends on what condition you're dealing with. So consider this 25-year-old patient who has pathological myopia along with some amount of cylinder. So, and his pachymetry, as you can see, is around 496 microns, which is quite grossly inadequate for any type of full correction that can be done on the cornea. So we planned a combination of ICL along with laser vision correction. So now how much to divide between the two depends on, again, the patient and the amount of correction. So here, earlier we used, when the cylinder used to be corrected lesser than the sphere in the older lasers, then we tried to correct the maximum sphere in the ICL followed by the sphere cylinder combination in laser. But now, because both have an equal amount of correction, we are putting the cylinder as well over here. So you can see that we are trying to correct around 18 diopters of sphere and 2.5 diopters of cylinder using the ICL technique, and whatever comes is left behind, that is namely 4 diopters of sphere, will be using a correction using the excimer laser. So now here another factor that comes into play, you can see a toric ICL going on, is the economy. Why is this happening? Can anyone advise? Is there something to do with the resolution? Yeah, so a toric ICL is going there on there, you'll have to take my word for it. And so now, because a toric ICL costs more, costs more than a spherical ICL. Sometimes if you want to just go ahead with a spherical ICL and do the cylinder correction, the laser part also, it's fine. I mean, दूसरी slide पे जाती हूँ, देख लीजिए कैसा हो रहा है, yeah. So that is trans-PRK happening. I use the Schwind laser, and whatever is residual is corrected by that. So the next patient is a 28-year-old keratoconus case. So now when you have keratoconus, it's not just enough to correct the refractive error, you have to make sure that it remains stable as well. So initially for cases where the cone is not way decentered, or if it's not very advanced, we try to do a corneal collagen cross-linking followed by an ICL. On the other hand, if it is an advanced keratoconus, we'd prefer to go ahead with, thank you very much. Yeah, on the other hand, if it's an advanced keratoconus, yeah, we'll prefer to go ahead with an intax before we do the ICL procedure. So you can see that an accelerated C3R is done, which has stabilized the high cylindrical value and the high K value to a much more flatter form, though the pachymetry has decreased by around 60 microns. And the next procedure here would be the ICL. So again, a toric ICL in this case, and which has to be oriented along the correct axis as indicated by the diagram. Though there will be aberrations, more aberrations than in a normal cornea, the procedure having stopped the progression would definitely be beneficial to the patient in correcting vision and therefore improving the quality of life. Now this is an advanced keratoconus where you can see the cylinder is high and also displaced, and you can see that the best corrected visual acuity is way too less. So in such a patient, if you directly put in the ICL, it is not going to benefit. So I start with a femto intax first. So you can see that the segments that need to go in are asymmetric, and once you put in the ICRS, you can have a very regular type of cornea, which you may not even think is that of a keratoconic patient. In some people, you may need to do a corneal collagen cross-linking as well to stabilize if there is some amount of progression. But the sequence I prefer is that you do the ring segments followed by a C3R if a C3R is required. Now, because this patient was older and had a stable cornea, I didn't go with a C3R. So once the segments are done, then you proceed with the ICL. So you can see that the asymmetric segments in the ASOCT are seen over here with the ICL in the sulcus, and that improves. And on the other thing to be noted is that the sphere and the cylinder had come down with the ICRS itself, so that the ICL correction required was much lesser. Now this is another patient with post-LASIK regression, LASIK done 10 years back. And though the pachymetry is okay, he was not okay with going ahead with a corneal ablation, because of which an ICL was kept in the eye. And you can see the LASIK flap over here and the ICL in the sulcus in the post-op ASOCT. Now this is a patient with traumatic cataract. You can see the corneal wound here that had undergone an IOL implantation, a rigid IOL in the sulcus. You can see multiple synechia over here, had a high astigmatism and a poor corrected visual acuity. So again, after ample dissection to create space for the placement of the ICL was placed in the sulcus, and one lucky thing was that the orientation of the ICL, you can see the marks on the cornea over here, was exactly where the synechia were amenable to clearance. And the rest of the synechia in the superior area also prevented this ICL from rotating. So I know I have to stop. I'll just take 30 seconds. Yeah. So now this is the pseudo interface between the two lenses, that is the ICL with the toric marking in the front and the pigmented IOL behind. Now here is a patient with ICL who had cataract. So the ICL was retained along with the placement of a multifocal toric intraocular lens. This was to maintain the multifocality in a high myope. The calculation being done was that the target refraction kept for the IOL calculation was the previous amount of myopia. And the patient attained very good near and distance visual acuity. The last case here is a post-LASIK and post-ICL patient who developed a regression. Now you can see this is the ICL eye because the pachymetry is around 500. This is the LASIK eye with pachymetry around 400. And though the regression was more in the ICL eye and not in the eye where the corneal procedure was done. And here again, a trans-PRK was done as a top-up with the patient achieving the desired corrected visual acuity. So you can see that multiple combinations where you choose wisely and put in, added effects like corneal collagen cross-linking or an ICRS definitely helps in tackling a large range of refractive errors. Thank you very much.
Thank you, Dr. Sapna. We have our next speaker, Dr. Om Prakash Anand sir. So he's going to talk on flax in difficult situations. After this one, 2 are left, 3 are left. Dr. Srinivas, Dr. Amandeep, Dr. Faizal.
Actually, he is like RPC in some our faculty only. He is there here also. We have three speakers. He is moderating next session. You can just stand off, let him present, and let him continue the next session. The same speaker.
Good morning, friends. I'm really thankful to the organizers of RP Center for giving me a chance to share my very small experience over it. A special thanks to Professor G.S. Chityal. Can I control it here? Yeah. So, in fact, my topic to how to use an advanced cataract operating system, that is FLEX, to handle the challenging situation in cataract surgery. So I have selected, though there is no limit of the difficult situations in cataract, I mean they can be anywhere, but I have selected few of the common problems which we comes across almost in every day of our surgery. You know the advantage of FLEX, a very precise capsulorhexis, precise segmentation, softening, and almost negligible energy. So this is my first case where I am just making the cataract surgery in the case of pseudo-exfoliation, where we have to avoid the zonal pressure. I have applied 4-5 segmentation over here and the softening pattern as well. So you can see I am separating the nucleus species without spending much of energy, and it's a very control unaided video over here. And every time you see the eye is in your hand, it have a mild astigmatism as well. So I have just planned and given the program of arcuate incisions along with that. So that will I open at the end of the surgery. So I will handle the not only crystal clear cornea, but I will handle the astigmatism simultaneously. So they are the situations where we have to give a concrete result to the patient. So now I'm opening the arcuates over here. They are 2 in number, and this is all about the case. So it was the ultimate result, the case having 612 vision. A second case which have a corneal astigmatism around 0.63, and 3 is a little hard, and it's a cheesy kind of nucleus which doesn't normally, you cannot just crack it. So you just see by applying the FLEX, you can separate the segments without any energy over here. I'm just rotating, and what you call it is auto separation of the nucleus species. And to aspirate such a simple and soft cataract is not a difficult task. So I'm just handling this situation where if you do with the normal situation, the nucleus turn to the saucer shaped structure, and it's very difficult to remove ultimately. So that part can be handled here. We all come across in the same situation where you just try to hold the nucleus, and it just bite off, and you left behind with a saucer shaped kind of nucleus, which is very difficult to remove, and sometimes will end up with the complication. So here it's just a child game, and we are just removing. I have put the lens, opening the arcuates just to handle the remaining astigmatism. And results are very good. If you just see the cases, the plano unaided vision was 6.6, and this is the beauty of the FLEX if you are applying. This is a 49-year-old patient. Is the next case. It's having a high astigmatism around 2 diopter or the lens plane. I have made the reference marking in advance, but if you see, I think if you can make out here or not, that they are the mark of the corneal mark to align the lens over here. One is here and one is here. I think it's very clearly visible over here. But I have make a double security just to make my reference marking what I was using earlier. And in the FLEX, you need not to make any reference marking. You can make a mark directly on the cornea where you have to ultimately align the lens. So pupil is not very much dilated over here, and I have just make the 8 pieces over there. I am just gently removing and separating the nucleus species, and the way you require very less in energy in handling these cases, even the small pupil. And very controlled phaco, you can go ahead with it. So the last piece is just going up, and after removing the cortical matter, I have placed the lens. And because people have come down, you can see I'm aligning by pulling the iris just to see the lens marking over here with the corneal marking. So this I have done it, and the result was unaided vision 6.6 on day 6. So one more case. It is a little hard case. We all know that hard case is a challenge for all cataract surgeon, and it is same kind of cataract which is very hard, but with the help of a flex, but I have already applied here. So I have made 8 pieces over here, no softening pattern applied, and though I have already pre-chopped the nucleus, but still I have to apply some force to separate because the posterior plate resists to get separated. So mind it, in the cataract surgery, if you cannot make the total separation end to end, you cannot complete the case. So I am just separating the pre-chop segments, and almost I have done it. And once you just made it, I think to
Yes. Look at the Canada and the US, it's much, much higher. Now look at the demographics of wet AMD. 60 to 65, it's 0.4%. More than 80 years, it is 8.2. Now, wet AMD and demographics, if you see, the more occurrence is 8.2% over the age of 80 years. Now the question, debatable question is, why deprive patients up to 80 years of putting a multifocal or any other IOLs if their fundus is normal? This is again a debatable study, a debatable question. Now these are the various studies which have shown short-term outcomes of combined pars plana vitrectomy with epiretinal membrane phacoemulsification, and they have said that the multifocality was achieved and the final visual outcome was delayed due to PCO. And now coming to the next scenario, what if the patient has AMD or geographical atrophy? If the patient is having wet AMD with a multifocal IOL, then definitely there's a lot of anti-VEGFs now available in the market. Interesting thing is the nodal vision, that is the home-based OCT which Novartis is coming up with. It's basically, trying to give an OCT to the home, that is a home-based OCT. It takes around 10 pictures, and if there is any activity, it pings the doctor. This is the artificial intelligence used nodal analyzer. So Usha Chakrabarti has done a lot of studies on this, and she has shown a wonderful results. Now last scenario, in case there is a bleed at the macula with the patients with multifocal IOL. Now what next? Biome versus the contact lens. Yes, definitely diffractive multifocal interferes with the intraoperative view was what shown by a few of the studies. This is the ghost image, arc-shaped image. Various images have been labeled and shown. And they said that definitely the diffractive multifocal IOL may interfere with surgical procedures. Now look at this, what they have done. They have used the helon on the anterior and the posterior side of the lens capsule to get away with these aberrations. This is what they say that it improves the. Now coming to this is my own video. I don't think now with the advancement of these wide angle visualization system, we have anything difficult in viewing of any of these. Can you place the video please? Video. Excuse me. From audio visual please. Video play karna hai. No, this video actually wanted to show how it doesn't interfere while removing the subretinal gliotic bands. It was a case of complex retinal detachments where I tried to remove all those subretinal gliotic bands. Even in the peripheral visualization, I did not find any trouble in any of these visualizing techniques. So that was one thing. आ रहा है वीडियो नहीं आ रहा है नहीं आएगा है उसी में है छोड़ दीजिए. So coming to the last slide, now let's look at one of my senior colleagues, Dr. Andrew Gribrovsky, a beautiful paper published, Multifocal Intraocular Lenses and Retinal Diseases. He said that we are unable to find evidence suggesting that patients with macular disease should be advised against multifocal lenses. Several contraindications for MIOLs in patients with retinal disease have been a hypothetical character and are not evidence-based. More research is needed, especially to address the effect of multifocal IOL on contrast sensor visual functions. So, my dear friends, they say if you can't convince, then please confuse. So, it's best left to you what lens you want to choose in any of these macular pathologies. But definitely, in case there is a large drusen or geographical atrophy or wet AMD, then it's definitely an absolute contraindication. But in rest of the cases, it's just a relative contraindication because we still do not have any solid research-based studies. So thank you very much for the patient listening. Thank you once again.
Operate both the eyes simultaneously in the same sitting. It also helps to provide only a single exposure to high-risk GA, which is again a very big problem in these babies. And it helps to take care of both the eyes in the same sitting. And obviously the second eye has to be treated like a second surgery, which basically means that you again, change the drape, clean drape the eye again, change the fluids, change the instruments, the team rewashes again. And obviously the parents need to know that you're going to operate both the eyes in the same sitting and what are the consequences if something decides to go wrong. So let's look at some of the basic principles why you would like to operate these cases. So this is classically a TRD which appears. You can see laser marks on the right side. So there are various forces at work which need to be relieved if you want to let this TRD settle. So this centripetal force which is trying to pull this TRD towards the disc. Usually there is a band of vitreous which is pulling.
Hello, boss. How are you? Come. Aye, Dinesh. Sir, you want to sit here? Good morning, everyone. At the outset, I'd like to invite Dr. Avninder Gupta, sir. He definitely needs no introduction, and I request him to, as a dynamic and versatile surgeon, requesting him to speak on managing extreme PVR. The tips and tricks, please.
Thank you, Srinivas. Thank you, Professor Titial, and all the RPC team for inviting me here. Wishing you a very happy RPC Foundation Day. I'll be talking about managing extreme PVR tips and tricks. So proliferative vitreoretinopathy is a common cause for failure of rhegmatogenous retinal detachment. It can be pre-existing or it can occur after detachment surgery. Incidence of PVR ranges between 5.1 to 11.7%. The risk of PVR is RD exceeding 2 quadrants. If you have giant retinal tears or multiple tears, then many of your patients can land up into an proliferative vitreoretinopathy. Patients with vitreous hemorrhage, preoperative choroidal detachments, previous failed attempts to reattach, uveitis, and preoperative presence of PVR grade A and B can present as a proliferative vitreoretinopathy postoperatively also. PVR is a repair process. PVR occurs from glial or RP cell proliferations. RP cell migration causes membrane formation resulting in tangential force on the retina, and this tangential force causes a macular star formation, and if it contracts more, it can cause an rhegmatogenous tears or can cause a detachment locally. It can be basically classified into two. It can be classified into an posterior PVR or an anterior PVR. Posterior PVR can be a focal, diffuse or subretinal, and I'll be basically dealing with these three entities, or it can be circumferential, perpendicular or anterior. So this is one of the patient I operated upon. This was a young child. You can see good laser mark, and this patient detached after 3 months of surgery. And you can see multiple star folds infratemporally, nasally and superiorly. So many times you are not able to distinguish where the membranes are. So what I prefer to do in these patients, do a fluid air exchange and do a reti blue dye injection. And once you do a reti blue dye injection, you can delineate the membranes very nicely. The advantage of putting reti blue is you can see actually the membranes here and you can see the edge. Once you see the edge, then your surgery becomes easier. So it is the edge of the membrane. You don't, first thing is you have to create the edge of the membrane, and you can either use an MBR blade or you can use a diamond dusted membrane scraper to loosen the membrane, and the membrane is then picked up with an Eckart forceps, or if the membrane is too stiff, then end opening forceps does do very fine. Because many a times with Eckart, what you do is you tend to tether the membrane. So in these kind of situations, you then use an end opening forceps, and then you can peel almost all the membranes. You can see this membrane is very stiff here. So you have to loosen this membrane with gently picking it up and then remove this membrane. Uh, Also, you can see a lot of membranes over the laser marks. If you peel over the laser marks, then you can create multiple tears here. So it's better to avoid peeling over the laser marks. Then a PFCL is put, the brake, the iatrogenic brake is sealed with the help of an laser, and fluid air exchange is done and oil is put. This is one of the very interesting cases. You can see I thought it was a pretty easy case, two inferior brakes, but patient was very highly myopic. Put a PFCL, did a peripheral drainage from the brake only. But you can see here the part of the retina here in the this part of the retina is not settling down. So if you have this condition, then always you have a doubt. You in myopic, you have left a skytic vitreous. So I put tricot and see whether I have left some amount of skytic vitreous or not. But actually there was no vitreous. So what I came to in conclusion that the ILM is pretty stiff here. Did an BBG staining and peel the ILM over the whole of the inferior arcades. I didn't extend it towards the macula. And many times in myopes, this ILM is pretty stiff and this prevents the retina to fall back. So once the ILM peeling is done, I don't extend it to the macular area, then PFCL is put, laser is done to the brake, and you can see now the retina is settling down. This patient had a good vision post-operatively. This is one of the patient you can see. This is one of the patient you can see very bad PVR. There are subretinal gliosis, almost 8 months old detachment, and we took the patient for surgery. And you can see I have put a PFCL here after doing a vitrectomy. There is a big subretinal band here. And this is preventing, this is actually a napkin ring like a contracture, and this is preventing the retina to fall down. So if you want to do any kind of a subretinal surgery, first remove the pre-retinal membranes. All the pre-retinal membranes are removed. Then a diathermy is done over the subretinal band, and I tried to pull this band out. But you can see here I'm not able to pull this band retracts. So I shift on to a bimanual surgery with a chandelier illumination, and then I use an pulling the rope kind of a technique. You can see whole of the band is coming out here. Once one edge of the band comes out, the other edge of the band is also peeled in a similar, removed in a similar way. And once this band is pulled out, the PFCL is put. You can see there is a flattening of the retina, and this patient post-operatively, if you see, has improved to somewhere around 660 vision with a flat retina. I'll skip this video. Various agents has been tried to prevent proliferative vitreoretinopathy like danorubicin, 5-fluorouracil, colchicine, corticosteroids, retinoids, heparin, but none of the agents have proved a definitive role in preventing proliferative vitreoretinopathy. So to conclude, the introduction of vitreous surgery techniques and longer acting gases and long-term tamponades like silicone oil have elevated the success rate from 35 to 40% to approximately 60 to 75%. Cases which were thought to be inoperable previously, with better instrumentation and technique, we are taking up these cases and giving some kind of vision to the patient. Thank you very much for your kind attention.
Thank you, Dr. Gupta, for such a wonderful presentation. Excellent videos showing PVR and how to remove the pull the rope technique. It was very interesting. So, any comments from the panel or from the house? Anyone wants to make any comment?
Very nice videos, Vrinder. So, like you showed, I think these are what we can do at present. But I was just reading one survey article on PVR, and they have emphasized on the point, like you have also said, that so many things have been tried to prevent PVR, but we are unable to prevent it as of now. So probably there is something in the basic pathomechanism which we still don't know. It's not just a simple inflammation, it's something else. And maybe when we know that better, we may have some pharmacotherapy.
Thank you.
Thank you so much. So next I invite Dr. Vishal Agarwal to talk about retinal detachment, secondary to FEVR management and surgical outcomes. Yes. So Dr. Vishal has extensive experience about these cases, and we look forward to hearing what you have to say. FEVR management with RD is a challenging situation, and I think we all need to learn what the slides are.
Well, thank you, RP Center, for having me here. And it's always a humbling experience to present in front of our teachers and in your mother institute. Thank you again. Okay, thank you. So I'll be speaking on pediatric retinal detachments associated with FEVR, management and surgical outcomes, our experience. Just a small brief. It was first described in 1969, and it's a condition similar to ROP, minus the premature birth. And considerable progress over the years has made the diagnosis and the treatment more feasible and more effective. And but due to frequently asymptomatic course and diversity of signs, FEVR still is an unrecognized entity and is referred late. It's generally bilateral, asymmetrical, and the mean age of presentation is 6 to 8 years. And the hallmark is the avascular peripheral retina, dragging of the vessels, various levels of exudation and retinal detachment in the final stages. Wide-angle FFA is now available and is invaluable to establish the diagnosis and follow-up of these patients. And there's a wide spectrum of clinical signs and features in FEVR, ranging from hyperpermeable blood vessels to neovascularization, traction, macular ectopia, subretinal exudates, vitreous hemorrhage, and finally, as I said, RD, in which case rhegmatogenous is the most common, followed by exudative and tractional. So the purpose of the study was to report the clinical profile, management, and long-term anatomical and visual acuity outcomes of pediatric macula of detachments secondary to FEVR. So it was a prospective interventional study of 14 eyes of 13 children aged between 5 to 6. So after closing the macular hole, another round of base dissection was done. All the membranes were trimmed, and as I told you, that temporal fibrovascular band was not peeled off; it was shaved. And finally, thorough laser was done, and the patient was closed under oil, and the patient did fine in the follow-up. This is one of the cases which is a more advanced case, and the vascularity is not there. It's an old case, and you can see the whole avascular temporal periphery, and this is very ischemic, and the PVD has to be induced very gently, otherwise it will create a rip or a retinal tear. Again, the maneuvers are the same. The main hindrance is the PVD induction. Then you stabilize the posterior pole with PFCL, and slowly, gently take time and remove all the hyaloid remnants with the end gripping forceps. We always place a band, of course, in these patients and do ILM peeling all these cases because the traction extends to the macula, and post-op ERM and macular pucker can be prevented doing ILM peeling in these cases. So this is one of the pics of the post-op buccal patients, post-op vitrectomy patients. And this patient was done laser, and patients who had no neovascularization, just avascular area, were observed. This patient was not included in the study because it had no regma component, only a tractional component. There was peripheral leakage, which was lasered. So coming to the results, the mean age was around 12.14, and the mean acuity was 2/60 in the pre-op period and 6/24 in the post-op period. 10 eyes underwent vitrectomy, 4 eyes underwent buckling, and the mean follow-up was around 3 years. And the anatomical reattachment rates were around 92%. I will not go into the details of every patient. So the thoughts are that FEVR is a rare form of vitreoretinopathy, ranges from a completely asymptomatic entity to a vision-threatening disease. And it's a lifelong disease with regular follow-ups are needed. And the interesting point is that in the Western population, TRD and exudative RD are more common at an early age, whereas here the patients present at later stage with more of rhegmatogenous RD presentation. So the current study represents the largest Indian series of macula of RD secondary to FEVR in a pediatric population. And the primary objective of surgery here is to relieve the traction. And inducing a PVD and completing the vitrectomy are critical to relieve the traction on the retina. Buckling or vitrectomy depends upon the type and the location of the RD and the extent of the fibrovascular proliferation.
The FEVR edge, and you know that you cannot extend the PVD induction beyond that edge. And there was also a break in that area. So do we consider putting a segmental buckle or a band in these kind of cases because the peripheral traction is still remaining
Always
in these, or
clutch, yes.
it always helps.
Yes.
And if whether irrespective of whether the break is there or not there.
Even if it's not there, there is a resident traction and you have
And this decision will be taken intra-op.
You can never relieve the traction. You cannot induce the PVD beyond the temporal edge of the macula in these cases. So you have to put a band.
Vishal said not intra.
You do it pre-operatively or?
All the cases banned in this case. Otherwise, I don't put band in a routine RD. But in these cases, always
You
a
always
band.
put pre-operatively.
A 360-degree
Yeah,
encircling.
whatever. Segmental or a
It's a broad
complete
difference.
encircling band.
That would be an addition, but a 360 we are always using. But
Yeah.
if you have an additional break, then you can support it with
But
an
the additional segmental.
That
band.
can be done.
Okay. Thank you so much, Vishal.
I think one, but my experience in these cases that you never find jelly vitreous in these patients. They are always membranous kind of.
Always membranous kinds.
So, and it's very adherent to all the structures, even at posterior pole.
Exactly.
As you rightly showed. So once you are going in surgery for a severe patient, never expect a jelly vitreous.
Exactly.
Thank you. Thank you.
Right, thank you. Next I'd like to invite Dr. Rajesh Ramanjulu, who will be talking about the role of Abgel, Geraldine sponge in VR surgery.
Good morning, respected teachers. So I'm very grateful to be back here and for the opportunity that has been given. So the topic was, the session was like advances in VR surgery, but I don't know whether this fits in or not. I have not published it, so I thought like let me put it across to you. So it's about 8 years back in a serendipitous morning, I had posted a patient who was a 27-year-old gentleman who had a stated metallic retained intraocular foreign body with two pieces that can be seen on the AP and lateral views. So started with the surgery, thought it might be just a routine, just pull it out and then be done with it. Videos. I did see that it was playing, sorry. Folder nahi copy.
Maybe we can take the next speaker till you.
Yeah.
Ma'am, you want to present? Yeah. Ma'am, you want to start? Okay.
No, my video is not.
Oh, I hope mine is done. But there are no videos here.
डॉक्टर विशाले की टॉक लगा दीजिए.
You're ready? Yes. Yeah, please go ahead.
I think they'll have to reach it.
For complex retinal surgeries. So I'm not going to show you the routine. क्या हुआ? They were ready for you, Rajesh. Anyways, so let's see if the videos play.
So I mean, what all you need for doing, it says diabetic, but is applicable to everything. Choose the right instrumentation because you need the port-based flow limiting which it offers. You also want port very close to the tip because that is going to give you both vertical and lateral access to the membranes that are so very important for us to remove. You need an instrument, preferably a single instrument, which can do all the job for you, including segmentation, delamination. You don't want to keep going in and out with so many instruments, and you want to ability to manipulate tight adhesions in the mid-periphery. So let's see how the 27G actually helps us with all these. You had the same problem? Okay. So can you help with the videos, please? Okay, you come back, Rajesh.
Madam, you can play with your own laptop, I suggest.
I think if you got videos, you kindly play with your own laptop. That will be, I think, better because some AV issue is there. Please play with your own laptops only.
So where am I now? I'll just see it there and speak. Don't disturb anything. Okay. This is. It's okay. So many a times. No. Yeah. Now it's come. So when you go into the periphery, there would be very tight adhesions in the mid-periphery. You can actually use a small gauge forceps just to create a little bit of tenting, just enough to let your, like this, but be sure of the force being used, and you can let your cutter inside work it very close to the retina, and you can do the entire surgery without creating any breaks, because that is the way the diabetic surgery has to be, that you are able to carry it out. So once you have taken care of the mid-periphery, you can come to the center. I mean, it's surgeon's choice whether you take care of this area first or that first. And you can see there is a featured proportional reflux, which I use a lot. So with proportional reflux, you can create the planes, delaminate it, separate it, and do a surgery, very close to the retina without the risk of any retinal breaks. And this is the same patient pre and post-op. Now, it's not only about diabetic. There are certain complex situations where you would like to use your 27G because it's allowing the peripheral dissection, and you can see now with the instrument, there is a problem in the display, but you can create a small localized plane, a kind of a PVD to go in. And with this, you can use your proportional reflux, as I was mentioning. You can keep on separating, aspirating, removing the hyaloid, and subsequently I'm going to show removing even the ILM with the same forceps. Honestly, there is no need to keep changing the forceps or the instrumentations other than the diathermy, and of course the laser whenever you need to. So as you can see, after tackling that area, you can change the direction. Now this is something very important because moving your scissors to the conformity requires expertise. With cutter, you just need to flip, you go to the direction, and when you are in that direction, you can keep on moving. For want of time, I think I'm going to move forward this video if it allows me. And you can see that after the complete this thing, you can get rid of all the membranes and one by one segmental, and you don't end up, this is the end product of dissection. Vitrectomies for uveitic, especially situations like this, where there is acute retinal necrosis and patient develops within 3 days, actually the retinal detachment, and it's bad. Because I wanted it to control it with antiviral, but there was no time and the detachment was progressing. And you want to go into this eye, you don't want a cutter which is, a large gauge. So with this small gauge cutter, you can again, this is the hyaloid we were just discussing just before. You may not be able to peel it off right across the surface, but then you can do a decent enough job working very close to the retina, especially close to the necrotic retina, without the fear of, it's already a sieve-like retina, you're not too scared of the iatrogenic breaks, but then you can cause a huge tear there and you can cause more damage. So 27G allows you an advantage of doing that, and this is the same patient post-operative day 6. You can see the retina is kind of settled nicely, and we did manage him with antiviral later on. Another interesting is oncology, and this is the young girl retinocytoma with retinal detachment, and buccal would have been personally my first choice, but then I asked Santosh, and Santosh said, okay, this is retinocytoma, you don't do buccal, you don't expose sclera, you do small gauge. And this is, I'm just going to take 1 more minute. And this is how it happens in the small gauge. I went in, I used topistican 2.5 milligram as was advised by our friends, brand new cutter, and I thought I will take the sample for cytology. And within 30 seconds, the cutter gets blocked. And these are some of the things you've got to be sensitive about. This is a small gauge and the cutter gets blocked, and then, but very interesting fact which I saw was that topotecan is supposed to cause the whole thing green, and if you see the view from the callisto, it's all green, but on Ingenuity you don't even realize it was green. So I really, when it was comparing, I found it very useful. And the bubbles. Bubbles, when you go very high cut rate, they will come, but they're a bit annoying, but they do not disturb with your surgery. So this time I was wiser. I just completed the whole thing and only then I entered that area, and you can do these. So the last one which I'm going to show is again 1 minute video. This is more to do with this single instrument rather than anything, and is more for fun rather than the requirement, like the ERM peeling. So would you want to do ERM peeling without forceps? Yes, it would be fun. So if you have an integrated OCT in the microscope, you can identify the edge, engage the edge into this, engaged. You can use your cutter, and this is under yellow, under Ingenuity, without any dye so far. So once you have the edge, you can use your edge to peel off the ERM from the surface of the retina without the need for any forceps or any other instrument. Just you have to be gentle, patient, and keep on pursuing the edge. Now in this patient, as you can see, ERM is coming off. The OCT is giving you a guide that it's peeled off or not. And after this, we are going to inject the dye just to see the staining of the ILM, and that's the last 30 seconds of my talk. So once you are done with the membrane, as you can see, the ERM is out. You inject some dye, and that aim of the dye is basically to see the ILM. You can use the same cutter to peel off the ILM as well, So it's just fun. I'm not saying it's very important, it's just fun doing some of these stuff. And of course with the OCT, if you have at hand and you are worried if this is the area of break or something, you can actually confirm it. Not that you can't use your clinical judgment to do it, but it's just fun doing it. So I think my 7 minutes are up, so I will not extend. would just like to thank all my team for helping me recording the videos. Thank you very much.
Thank you, Dr. Vishali, for the excellent talk and those excellent videos. And any questions, if any, from the house?
How do you inject PFCL, madam?
Through this thing. I generally do not use the cases where PFCL has to be injected.
Cases where RD you
For
had
my
shown.
27G, diabetic is my first choice. All my diabetics are on 27G, and all my uveitis patients.
Yeah, that's the biggest disadvantage of 27 in RD surgeries.
Yeah, RDs, that's why I did not show. That's why, because that you cannot, you have to go hybrid.
Yeah.
That you can't do 27. That's why I haven't shown RDs here.
If you want to inject in 27 kg, you can take a 30 kg needle.
Rajesh, aap laga le.
Pressure is a little low. Go inside and inject. I've done it.
Doctors, I'm so sorry for the interruption, but we are very much.
Dr. Rajesh, can you put your.
Doctors, I'm so sorry for the interruption. We are very much behind schedule, so we'll have to move to the next speaker. And one request to everybody, please do not extend your time. Once you hear the bell, you have to conclude the session or we'll have to interrupt you, please.
We have a very strict moderator here.
Yeah.
So after Dr. Rajesh will be Dr. Raju.
Yeah, back to the case. So it's.
Even the timer is saying, I want to pray.
So it was just a 20 gauge at those times. So one of the piece of the retained intraocular foreign body was just in the anterior phase, so could remove it easily using a sandwich technique or a handled shake with a magnet and the forceps. So the real part was then went inside, started doing my PVD induction. So what I could see is there's another foreign body which is embedded into the posterior edge. So you could see that longitudinally it's entered and perforated through the posterior wound. This I couldn't realize. I haven't done a CT in this patient. So I mean, it was the same technique. Took a Makima forceps and pulled it out. And surprisingly, it was the same size, 11 mm. I don't know what I was measuring. But after closing the elongated suture, when I went inside, the globe was collapsing now. I thought, okay, let me inject air since I have already induced the PVD. It's getting even more worse. It's like as if there's a back pressure, and that is causing a collapse. Now I put in PFCL. The strangest thing that I noted was it was percolating through that perforation over there. Now all that fluid, all that air, everything is pushing into that hole, going into the retrobulbar space and collapsing the eye. So dilemma, what to do now? Glue. So I thought, okay, in the conventional way, just try to go and approach it from retrobulbar and see whether you can put that. Try to stop, it's not happening, and still it's collapsing more and more. Try to put in visco, whatever, but still it's collapsing. Luckily, I had one of my colleagues operating, oculoplasty surgeon operating in the other table. So I saw something he was using. So I said, what is this? He said, like, it's a gelatin swab. So I just took a piece of it because I didn't know anything else. It might cause a supracoidal. I just shoved it into it and hit laser and see what happens. So the retina well took it and there was no inflammatory reaction and did well. So the patient after that silicone oil removal also did well and his vision was somewhere maintained at 6/12. So it was, what is this? This is basically a absorbent gelatin swab. It's widely used. It's nothing innovation from my end, but using in that retinal part was what I did for the first time. It was used by dentist, orthopedician, and thankfully for my colleague oculoplasty surgeon who uses it in hemostasis. So I didn't do anything. I was just scared whether it's it's logical to use or not, whether it's ethical to use or not. So 8 years I didn't do anything, and then waited for another situation such to appear. So you can see this is a patient who has, next video, yes. So who had recurrent retinal detachment, almost 6 surgeries, this is the 7th one, and the regma was exactly on the CR atrophy. So nothing, I couldn't laser or cryo or do anything. Repeated staining to see if there's any cortical vitreous. Nothing was there, it was completely dead, but the break was not getting adhered to the underlying retina. So did an air fluid exchange, small piece of gelatin swab again, because it takes nearly about 3 months for it to completely get absorbed. By then there is a thin layer of gliotic membrane onto that. So it prevents the hole from getting, and there is no traction also. This is the second indication. Going forward, wanted to see if there's anything else that can be done with same kind of a regma where we cannot close. This is an ODP patient who had recurrent retinal detachment with subretinal oil. Again, this is the third or fourth surgery. So PVR in the periphery also. Removed the subretinal oil and shoved a small piece of this gelatin swab into that ODP, suspected ODP area, and lasered it. The thing that we have to always, the first time I don't know how I did it accidentally, but when you want to use this, the eye should be dry. You can't take it into a fluid thing because it just disintegrates. So you need to have a dry eye, that is after air fluid exchange you can shove it in and finish up with the laser part of it. The last, this is one of my colleagues who was operating a surgery, RD. You can see when she was injecting the PSL, she had not let the fluid come out, and suddenly there was some kind of unsettlement in the thing. When she looked at it, a small bloat of the globe had happened. So there was a small perforation inside but a large tear outside. So she called me up. I went and tried to see whether I can suture the external part, but the external part was very, very posterior and I couldn't close the lip to lip, and it was still leaking. So though even if I had a sclera at this point of time to suture it out, it was not possible. In a desperate measure, I was trying to suture it up, but it was not only the anterior lip was seen, but not the posterior. Did the same thing again. Went and did an air fluid exchange, shoved up the gelatin swab into that thing, closed that space, and did the air fluid exchange and lasered it. So that's the choroidal opening which is there. And now the entire retina, it's again settled completely. No, ma'am. It plugs it properly, and this is 1 week post-op again. Yeah, ma'am, it's sterile, ma'am. It's sterile. So hardly the entire pack costs about 240 rupees, and it's not a oculoplasty domain only. So even the retina surgeons can keep it in handy if you want.
No, all the general surgery people also use it.
Yes, sir.
It's a routine thing. They were last 2 decades. Brand name on again.
Sir, don't worry about the brand name. You have available. Yeah, it's readily available. It's readily available.
Worry about the presence of mind, sir.
Yeah, that's what.
He used the good presence of mind to use some other modalities. Thank you, Dr. Rajesh, for that wonderful presentation.
Injection, I mean, is a very scary kind of thing to deal with. So next, my Dr. Raju Sampagni to talk about surgical management of TRD, subretinal hemorrhage.
How can you remove it?
Audiovisual team can kindly help. Kindly change the.
Yeah, that will remain there.
आप यहीं बैठ जाओ. Excuse me. आप AV टीम. आप ना यहीं बैठ जाओ. आप AV से हो ना, आप यहीं बैठ जाओ.
सर ये डायलॉग तो सुनना ही था सर.
नहीं, he is constantly moving up down, up down. यही आप यहीं बैठ जाओ. यहीं बैठ.
Thank you to the RPC faculty for having me here. My pranams to teachers on and off the stage. And I'll be speaking to you regarding management of subretinal hemorrhage associated with TRDs. Sometimes they occur spontaneously in previously untreated eyes, and sometimes it's usually unsuspected until you observe it on table, because we would have seen the patient weeks before, we would have advised them the surgery. At that time, they'll just be having a TRD, and when they come to us on table, you will be seeing the subretinal hemorrhages. So these may actually indicate a retinal break, and careful inspection has to be done in these patients. And it can also happen intraoperatively during the surgical dissection. So as regards to the timings, it could be preoperatively only, you could have noted it, or it could happen intraoperatively when you are doing a dissection, or sometimes postoperatively also. Depending on the location, it could be submacular, or it could be localized, not involving the macula, and it could be liquefied or clotted. Here you can see the first case was posted for a vitreous hemorrhage. and patient was seen around 2 weeks or 3 weeks back and directly posted for surgery. So here after the vitreous hemorrhage is cleared, you can see that there's a mound of hemorrhage below the tractional membranes that are there. And when it is localized, it's actually easy, nothing to be worried about. Only thing, make sure you do all the dissection throughout completely, and then come and address the submacular hemorrhage in the end. So here I go ahead and remove all the traction. Use a PFCL to displace it from the center, and go ahead and do the peripheral dissection, do of the laser, and then come to the last part of the drainage through a retinotomy. And this is usually straightforward and simple if it is localized. And make sure you try to drain as much as possible. And this patient actually did well after the surgery. He maintains a vision of 6/9 after oil removal in this patient. The next patient here, months back, he didn't turn up, and then when he came, initially he had a TRD, and then when just before we took him up for surgery, we noted that he had huge amounts of bleed all around, and it was an extensive subretinal hemorrhage that was there in this patient. So then you need to change your plans. You can see the mounts there infro nasally in this patient, and just put a PFCL bubble, and then the other two tractional areas very adherent. As far as the, I went ahead and did a bimanual dissection. Here I'm using cutter as a second instrument, and just using dissection there as a forceps. So advantage is if there's a bleed that happens during the procedure, you can just use the suction to aspirate it and then go ahead and complete the procedure quickly. Just small tips, that's it, nothing extra. Just do the bimanual. Again, we went ahead and did the retinotomy in this patient and drained the subretinal fluid. This patient, you can see here immediately post-surgery. This is first day post-surgery. There is a thin layer of subretinal hemorrhage there, and usually at around 2 to 3 weeks, this tends to get absorbed. This is at 3 months. However, these patients, when they have this such kind of extensive subretinal hemorrhage, the visual gain is not too much. This patient, although has got a decent looking retina anatomically, the vision gain is just counting finger 3 meters. This is another patient who had a secondary rheumatogenic RD, and I planned for a Chandler assisted surgery. Here you can see extensive membranes all throughout. We had a pre-retinal, subretinal hemorrhage, subhyaloid hemorrhage with extensive anterior PVR also in this patient. Anterior membranes were also there in this patient. So went ahead periphery to center dissection in this patient and drained the subretinal fluid. When you are draining the subhyaloid hemorrhage, make sure you make small openings so that you don't it doesn't interfere with viewing. So make small openings and remove the blood. This patient had extensive membranes, so we had to do the dissection very patiently. And try to remove all the membranes. Here you can see the regma here. And injected PFCL bubble and did the drainage. We had to do drainage at multiple places because this was more like loculated, and there was one opening that I had to do here, and then the other one there. And it actually requires a lot of patience to be there because this blood doesn't come off very quickly. It takes time, and we had to increase the amount of PFCL that is there to displace the blood, and keep doing it repeatedly and to remove the retinal hemorrhages. So you can see again I'm injecting the PFCL here to push the blood more peripherally and then go ahead and drain the blood. So then went ahead and did the fluid air exchange. And still some amount of blood was there, but during the air fluid exchange, we were able to drain that remaining blood here. Here you can see. So the macula was free, so rest of the things I didn't try too much to go and remove the last part. I lasered the brakes and injected oil in this patient. And this immediately 1 week post-surgery and 3 weeks post-surgery, you can see how this patient behaved. Maintained a vision of 6/36 with oil inside that. So we had around 10 cases and 6 cases had submacular hemorrhage, and we had used 6 cases Avastin. So it tends to be an uncommon feature. Long-term and advanced proliferative retinopathy cases may have this and usually portend a guarded visual prognosis. I take this opportunity to inform you all that all RPC center, those who are trained at RPC center have all come together under a common brand name called Comet Eye Hospitals. Around 47 of us have come together, and I would seek the blessings of my teachers here. Thank you very much.
Thank you, Dr. Raju, for the excellent presentation and the excellent surgical videos. In the interest of time, I think we'll move to the next speaker. Dr. Dipender, please. Dr. Dipender will be talking about inherited retinal diseases and curvature related retinopathy.
Yeah, thank you, Dr. Parijat, and I thank Professor Titial sir and my friends at RPC for inviting us once again. This is always a very nostalgic and proud moment for all of us alumni who are now in different areas all over the world. And when I think invite comes to your mail from your teachers and your colleagues who are teaching the cream of India, then you start wondering what should I take to Premier Institute. So I thought about it, and I just, like we used to do in our rounds, whatever we read last night, we'll try to bring to our colleagues and give them food for thought. I'm sure they will take it forward in a much better way. So how it started, inherited retinal disease related maculopathy. Actually, I was referred this patient with myopic tractional maculopathy and advanced retinitis pigmentosa. And this was one-eyed gentleman, and he had a very recent drop in vision, like last 3-4 months. He was not able to see properly. His visual acuity was reduced to 5/60. And if you look at the pre-operative scans, he had a schisis, even LHEP, you can make out lamellar hole. And just inferior to macula, I would recommend all the fellows to do a thorough pre-operative scanning for these kind of cases to look for breaks. But there was no break in this case, and it was a detachment affecting inferior macula. So we took up this case for surgery, and I was expecting that this is a high myopic eye. Probably I'll have to do all the adjustments what we do for these high myopic eyes to offset the longer axial length. But when I was doing the surgery, I removed this second layer of vitreous, and I was just searching for any paravascular break by a soft tape, and there was no break. So plan was to peel the ILM, and we have had quite a few cases earlier where we didn't drain this kind of detachment and fluid persisted for years. Sometimes it takes 2 to 3 years to get absorbed. So after peeling the ILM, we spared the fovea because there was a lamellar hole with definitely spare the fovea. We created a drainage retinotomy under PFO, and we could drain this schisis, do laser, and used gas, and you can see there was no adjustment made for high axial length. Regular cannulas, 25 gauge. Patient did remarkably well. He improved to 624, very happy. He was able to do a lot of things which he had stopped doing. And you can see the detachment has settled down. The lamellar hole is going to stay there with LHEP, but visual acuity has improved. So I thought it was just another case, MTM with RP, till I got second case in March to May 2022. Now this was again 56-year-old gentleman having advanced retinitis pigmentosa. We have done cataract for him, and he improved to 6.6 and 6 after cataract surgery. This was his OCT scan in 2016 at the time when we did cataract surgery. Now he returns after 6 years with a drop in vision for last 6 months, visual acuity reduced to 6/36. I was expecting probably atrophy and maculopathy or maybe RP has advanced and he has lost all the photoreceptors at macula. But when we did pre-operative OCT scans for this patient, we realized that besides atrophy, there was a retinopathy which was looking like myopic retinopathy with bacillary layer detachment, Vinod's favorite, and this cystic area over the area of atrophy. And this is very typical of these inherited retinal diseases. So again, and at this point of time, I thought, let me measure the axial length. And axial length was 23.2 only. So it was not a myopic eye, but you can see the curvature. So again, we did autofluorescence to see if he has viable photoreceptors, and he definitely had some. So that's why we planned surgery. And again, as you will see, almost similar surgery, but here I think AIIMS was little different, as you will observe here, especially in the foveal large sciatic areas. I didn't want to deroof it. So as you will observe here, when I reached the foveal region, it was quite adherent. So you have to do it very carefully, and I think one can leave it alone also. And then there was typical this second layer of vitreous which was removed in mid-periphery. And yeah, so even this patient did extremely well, and his visual acuity, you can see at 2 weeks follow-up, fovea getting restored, except this sciatic area which is overlying this area of atrophy. The macula was very well restored and improved significantly to 6/12. So there were just 2 cases experience, and at that point of time I went back into literature and tried to see that has it been described. So I think a Japanese group is very actively working on that, inherited retinal disease related curvature maculopathy. In their first paper, they have found a very high incidence of steeper macular curvature in eyes with retinitis pigmentosa. And they have also devised a way to actually measure it. And I think I would urge all of you to go back and see their method, how they plot these 12 points and calculate the curvature in these eyes. They have termed it as MMCI. And what they found was it also correlates with amount of degeneration in myopic eyes. What they do is they measure the width of EZ line and then try to correlate the curvature with that. So till curvature this EZ line reaches 2000 microns, I think curvature keeps on increasing in a non-linear fashion. And the moment they have just residual 2000 microns of EZ line, after that it doesn't change much. The only limitation in this study was they have checked only the horizontal OCT scans. So I think this has already been described. I have not put all the literature, but all of you can go back and see not only in RP, a lot of other genetic mutations have been associated with colobomas. The same group, a year after their initial paper, actually tried to follow these patients serially, and this was again a retrospective study. What they found was that vertical macular curvature changes much more than horizontal, and I think this is again a very interesting finding. And these patients can develop a maculopathy also when they are getting this increase in curvature. So I think with this, my experience of these 2 cases and whatever limited literature is available, I think I can conclude that steep macular curvature in eyes with inherited retinal diseases does need our attention, and especially I think it's a food of thought for maybe Dr. Rohan and Dr. Vinod, maybe next thesis or something. And we need to monitor EZ width and both horizontal and vertical curvatures in these eyes. And some of these cases, if they have viable EZ line and photoreceptors, can be offered surgery, although RPC gives you that confidence, one case and you start advocating it, but I would wait for more literature. Thank you.
Thank you, Dr. Dipender, for the excellent talk and enlightening us about curvature retinopathy.
What was the exit length in first case, sir?
I think I went on, when he came for last follow-up, it was 24 point something. Some myopia was there.
Yeah,
and you can see the
first
crescent
case definitely had some stephyloma,
Yeah,
and
yeah.
choroidal thinning was much more in the first
Absolutely.
case.
That's why I have sent for publication the second case only. So I think.
That's what I was going to say. You should send your second case for publication.
I sent it. It's already under review.
It
for
is
last
something
year.
novel and
Especially nobody has done surgery for this.
Thank you, Dr. Dipender. Now I'd like to invite Dr. Ramakumar to talk about CSCR spectrum.
इंडोरी पोहा
माइक ऑन कर देंगे, माइक की आवाज नहीं आ रहा है, स्पीकर माइक.
Yeah. Good afternoon all. I thank my seniors, my teachers and my alma mater for giving me this opportunity. As Dipender sir said, he wanted to show something stimulating for the faculty. I came up with something just a common thing, but which has varied presentations, which I could compile all my photographs, and I thought I'll just present here. So thank you for this opportunity. So we all know how a central serous retinopathy, subretinal fluid at macula resolves if you keep waiting and counsel the patient like this. So we know the ink blot, the leaks and the smokestack leaks. But here is a patient who had ink blot leaks to present with, and after I did the laser, 6 months down the line, he developed a recurrent CSCR, and then he developed a smokestack leak. Then again, I had to laser that area again. And we know the multifocal leaks. But here, if you can see, there is a patient who had, to start with, it looked like a ink blot, and later it became smokestack. So this is usually, we don't see these kind of things. And you can see there is a teardrop sign on the OCT at the area of the leak. And here is a patient, 30-year-old male who had subfoveal PD in the left eye and subretinal fluid in the right eye, which was not resolving. Then I had to do laser after doing the angiography. And then he came to me after 1 year, the CSR resolved. The better part of that was usually, which we don't see, the serous PD, subfoveal serous RPD in the left eye, it resolved. Somehow it just happened. And we do see these RP tracks of the chronic CSCR. And this is a patient which prompted me to prescribe antioxidants. It's just usually we see the subretinal fluid takes at least a month or 2 months time to resolve. And such a huge pocket of SRF, it just resolved in 20 days in this patient. So I when I keep waiting for my patients for the SRF to resolve, I just keep prescribing some antioxidant medication, nothing else, no topicals, nothing. So I keep thinking whether that actually acts or not. This is one more patient who gave me a thought that it may work. 71-year-old male, 71 years is pretty atypical for a CSCR. So he had a cataract surgery done 4 months back, and BCVA post-surgery recorded was 6.6 elsewhere, but patient complained that he had low vision even after the surgery. So 618, 6.6, and this was like, you can see subretinal fluid with retinal fluid also. And I did angiography, and there was a leak near the fovea, and then Octa didn't show any vasculature. Then I just, because it was near the fovea, I didn't do anything. I thought I'll just wait and watch how it goes. And I just prescribed him antioxidants, and over a period of 5 months' time, the subretinal fluid disappeared. So whether the antioxidants worked or something, I don't know. Now coming to this patient who 44-year-old female. Females atypical to see with subretinal fluid CSCR for us. So she presented with 636 in the right eye and 66 in the left eye. I was to think CSCR also as a possibility along with. She was not given any medication prior to this. And like there was a disc edema, and you can see the disc leak also along with the point leaks here. So there was a disc leak also. So I was in like there were PDs, and there was a disc leak, there was a point leak. So what to do? So I just started on because like disc edema with vision loss is more important. So I started on steroids, and that disc edema has come down over a period of time. But the PEDs have increased in size, though the subretinal fluid cleared. So like 2 months later, she had large PEDs, but the subretinal fluid was less. But another 2 months down the line, she comes with, this is the patient who had the teardrop sign, that both smokestack and the ink blot thing. So at this juncture, I did laser to the leak, and then she improved well. And last week I saw her at 6.6 with total resolution of fluid, but the PED was still there. So like when you have inflammation and CSCR together, it is difficult to decide what to go for. So I was more important to treat at that time, so I went for steroids at that time. So this is a 60-year-old male who came with blurred vision since more than 3 years. He was being given anti-VEGF injections in both the eyes, and right eye 636, left eye 69. Elsewhere he received a lot, and this was like PEDs, a large PED in the right eye with retinal fluid, and left eye has foveal thinning, but that is the better eye, 6.6 vision. And like I discussed all the possibilities with him, and he opted for continuing the anti-VEGFs for almost 3 months. I gave the injections repeatedly in both the eyes. He was not resolving. And like somewhere in November last year, I thought I'll just, because of the retinal fluid here, I thought I'll just put him on some topical steroids. And suddenly a month later, even the PED resolved. That was like, but at the same time, the left eye didn't show that improvement. I don't know what was going on here. So steroids, some case reports I came to know that chronic CSCR retinal fluid may resolve, but PED subsiding is something. And after a month, because after this I stopped him, like the steroids, and a month later again the PED has come up, but there was no retinal fluid though. So here is a patient who had subretinal fluid, and like I did this angiography, and on OCT I could see a vascular network on the outer retinal slab, and I gave him anti-VEGFs, but I could not see any response. He chose bevacizumab, and once I did a grid pattern laser temporal to the area of the fluid, and a month later I could see some reduction in the subretinal fluid. Whether that laser worked for him at the age of 65 years with a vascular retina on the opta, difficult to say for me. So just sharing my experiences. And this is one like that grid pattern laser working in one of my patients, a 33-year-old male. This is my last case. Presented in January, and he had a CSCR, and then it resolved for a while. Then he came back in May, and then I did all the things like FFA, angiography, the octa. There was no vasculature, and there was a leak at the fovea. So I just gave him like as I usually do, like oral antioxidants, and then got the serum cortisol levels done because it was recurrent and continuously coming. That was normal. And then after getting the cortisol levels, I gave him aldactone also, but it didn't work. And then he lost for follow-up, and when he came back, that time I thought I'll just do, because there was a subfoveal leak again, I did a grid pattern laser, and within a month the fluid resolved. So whether that grid pattern laser works or not, that is something which we need to think about. Thank you.
Thank you so much, Dr. Ramakumar. It's a great series of cases.
This is thermal laser, not micropulse.
Vinod, Rohan, any comment? Okay, so
She's not allowing us to come.
please feel free to comment.
Sir.
Induced. Earlier we used to do PDT for that. So PDT, unfortunately, because dye is not available. So nowadays, what I do is I call it sweep laser rather than grid laser. So yeah, you can say whatever you want to call it. So basically you give few spots of laser here and there in the area of detachment. Nobody knows how exactly it works, but it does stimulate the RP to pump out the fluid, and I think that is what has been working in most of these cases. And I think another important thing in chronic CSC, one of your cases beautifully showed, I think in the beginning, inverted smokestack leak. I think that is again something which is not unusual, but beautiful images.
So now I invite Dr. Ajay Roda to talk about micropulse laser principles and experience.
Thank you, sir. And at the outset, must thank Dr. Titial and the entire faculty and organizers of this foundation. Congratulations for the Foundation Day. Nice for me to follow up on a talk which was just given by Dr. Ramakumar on CSR. I'll be sharing my experience with subthreshold micropulse yellow laser. So just the basis of micropulse laser and a few examples, and I think these two studies done way back in 1970s, they showed that the burn duration, the duration of the burn equals the tissue damage. So as you reduce the burn duration, the tissue damage reduces, and if you reduce the threshold, the expansion of the burn also changes. So basically in micropulse technology, what happens is that you chop off the continuous wave laser into an on time and an off time, so you can have a duty cycle of 5%, 10% or 15%, and based upon the duty cycle, you can target the macula or an extramacular area. What is the difference? In a continuous wave laser, you can, even in TTT as you said, you can actually show damage on the OCT, but on the subthreshold micropulse laser, there is 100% tissue sparing. So that is what is important, and we have three wavelengths available, 532, 577 and 810, and what is being practiced now is the yellow laser. And how does it work? It works by, when you say that you can't see anything what is happening, so how does it work? So there have been experiments which have shown the generation of heat shock proteins, and basically they work by an anti-angiogenic and tissue restorative effect. The next question asked is what should be the submicropulse application strategy, and that has been shown to be a low intensity strategy but a high density. As we collected together and formed the international group of subthreshold micropulse yellow laser, and it's been done on the same principle of what was done for the TTT, but the test spot titration is done in the micropulse mode. Once you test spot titrate it, then you can reduce it by 50%, or some people, as I do it, about 35 to 40%, and it works pretty well, and I'll show you some cases. So this was a dentist who had a chronic CSI, had tried every possible thing, including epineurone, and he came up with, in the right eye he had a chronic CSR, and we suspected a small choroidal neovascular membrane. Other eye he had a CSR with his multiple PEDs, so we went ahead and did micropulse for the left eye. In the right eye he received ILIA. 1 week after micropulse there was a little increase in the fluid, but eventually his vision, he did not actually notice the fall in vision, but eventually the visual acuity improved to 6.6. I have been now following him for almost 4 years, and in 4 years he has received 3 sessions of micropulse laser and he is doing well. So the take-home message from this was, if you have a secondary CMVM, you should not treat it with micropulse immediately. You should treat it with an anti-VEGF agents. And once you know that it has got stabilized, you can treat it with micropulse. Second, micropulse can be repeated in 2 to 3 months. And like this patient, over the period of 4 years, I've done micropulse 3 times in left eye and twice in the right eye, and he has been responding well. This was an ophthalmology resident who used to travel from outside Delhi to me with chronic CSR, and whenever he noticed metamorphopsia, he will come in, and I've treated him with micropulse over 3 times. He has responded well every time, but micropulse is not a treatment that you give and it's cured for life. You may have to repeat it on multiple occasions. So this is just an example of the same patient doing well over a period of time. This was a Major General from Army who had a non-ischemic CRVO. He had a macular edema, and he was advised anti-VEGF. He refused because he read up a lot about anti-VEGF, and when he first came to me, he decided he'll go ahead and do yoga and try to control his BP, which he did, and eventually agreed for the subthreshold micropulse laser. So we did 5% duty cycle in the macular area and a 10% duty cycle in the extramacular area. And those days the titration was done, this is in 2015, where we titrated with 200 micron, 200 millisecond. Now the titration methodology has changed a bit, but the patient has done well. This was 3 weeks post micropulse laser, 6 weeks post micropulse laser, and this is a serial chart over the period of time. He has been now on my follow-up for over 8 years, and the patient has been stable and doing well. This is a 23 years old female, a non-hypertensive, non-diabetic branch little venous occlusion, who had come first time when the patient, I was in Max at that time. We treated her with injection of Avastin. Patient responded well. You can see the large areas of capillary non-perfusion. Received a second injection of intravitreal Avastin. And following that, we decided that we'll demarcate with the continuous wave laser, and the capillary non-perfusion areas we'll fill it up with micropulse laser. I have now a follow-up of this patient for 7.5 years. She just came in January this year. She's now moved to England, and she is maintaining this. You can see here micropulse laser. We could even demonstrate those days with a little bit of angiogenesis occurring. I'll show you better pictures. That possible angiogenesis occurring in the capillary non-perfusion areas, and this is a serial follow-up during 2015. This is in 2018. She is doing well, and she has not received additional micropulse or any more intravitreal injections. And this is in July 2021. This is a serial follow-up on the OCT, where there's a foveal thinning, but overall she's doing well. And this is a wide field picture of the same patient, and you can see here that there is definitive a little angiogenesis. The capillary non-perfusion areas have been treated with micropulse, and she is pretty stable there. So this is the last case again of a branch little venous occlusion. This was post vaccination. This was during COVID time that he received, initially he received eccentrics, and following that the patient was treated with micropulse laser. We did 5% duty cycle in the macular area and 10% duty cycle beyond that. And this patient has now been on my follow for 2 years. This is his picture in July 2022. This is how he is doing, and he is pretty stable. We were thinking that maybe we should treat this area. We're not yet sure about. He is on the regular follow-up. The patient has not needed any additional injections or any additional laser. So the take-home message is micropulse laser works in chronic CSR consistently. In our patients, we have had a success rate of over 95%. And chronic CSR, it may need to be repeated, but we need to titrate the dosage of micropulse, and micropulse also works in cases of venous occlusions with macular edema. Thank you.
Thank you, Dr. Ajay, for this insightful talk and telling us about micropulse laser. If there is last comments anyone wants to make?
When do you switch from 5% of the duty cycle? What's your threshold? You retreat first with the 5% if it is no action, or you directly go in for the 10%? I've seen some people using even 15% of the duty cycle.
So there was a study done which compared 5%, 10% and 50% duty cycle. I have never used 15% in the macular area. 5% duty cycle is what is advised for the macular diseases. 10% duty cycle is what is advised for the extramacular conditions. I was treating with 5% duty cycle with a test burn in the micropulse bone and then titrate in a CSR cases to 30% of that level. This is based upon some rabbit experiments done earlier. We don't have any human experiments where we can see 30% works better or 40% works better, but it's usually so. Now what Jay has done is that everybody is now started treating at 50% of 10% duty cycle on the titration burn. That is what is being practiced now. This study is done on electrophysiology. There is no evidence of any damage to the photoreceptors as such.
So we have done one study we published in IGO on CSC comparing 5% and 10%. We found slightly better effect with 10% and no FAF changes, and also we have shifted to 10%. Overall we found around 70% effectivity. So probably worth a try. not 100%, but probably still worth a try. I also tried in center involving macular edema post anti-VEGFs to try to maybe prevent the recurrence. There we did not find much
of difference.
Now
More
we are
effective
trying
in
it
CSC rather
non-center.
than in DME.
See, another thing what happens is when your machine gets older and your test burn, which was coming to me at 1600 milliwatt at 5% duty cycle, is now coming at 1950, and the maximum limit is 2000 milliwatts. So sometimes if your tip is not cleaned and it is, I'm not getting a test spot at 2000, I will stop, I'll clean my tip, I'll connect it again and then see, and it works. These are small things which...
Okay, so thank you so much. So with that we close this session, and thank you for to all the speakers and my co-chairs for being such wonderful hosts here. And with that, we have a 5-minute, I think, break, and then the next session will start at 1:15. So thank you so much.
Thank you. Thank you. Thank you.
Good to see you.
Hello, hello. Uh,
Check. Can we have everybody settle down? We are going to start with the next session in next few minutes. I would request everybody in the audience to kindly settle down. Please take your seats. We are about to begin the session in next few minutes.
Then she's been on.
Hello everybody, a very good afternoon ladies and gentlemen, and a very warm welcome at RPC Ophthalmic Carnival 2023. We are going to start with the post-lunch session, and for the same I would like to invite our chairpersons, Dr. Radhika Tandon, Dr. Pradeep Venkatesh, Dr. Raj Sekar Vayal, Dr. Parijat Chandra, Dr. Vinod Kumar and Dr. Prashant Bavankure. I would also like to welcome our moderator, Dr. Rohan Chawla. I would request him to take the session ahead.
Okay, so welcome everyone to this session on practice management in ophthalmology. Unfortunately, it's clashed with the lunch, but I think we can have a group discussion and we can take our time. After that, all of us can go and have lunch. So I'd invite the first speaker, Dr. Sumit, who has done a lot of work with innovations in 3D recording.
No, then you'll go back and sit. That's why he'll wait till you finish the talk.
Yeah, it's visible, Sumit.
Good afternoon, everyone. I'll be speaking on innovative 3D recording solutions on how to build your own. I've got no financial disclosures. Now, it is a well-known fact that three-dimensional teaching is helpful in medical learning, and there are many subspecialties, including ophthalmology, which do have 3D recording and imaging solutions. But the problem is that how many of us can actually afford them? And that was the question which kind of motivated me to go ahead and try and build my own. So just took on the basics that how do our these 3D visualizing systems work. First is on the principle of polarizing glasses that you see in the ones which are commercially available, that you have right and left disparate views and which are made and you get an individual input on the basis that you get a polarized light. Second is red-green glasses, and third is active 3D glasses which you see in 3D gaming laptops, etc. The fourth principle, which has often been forgotten or neglected, is stereophotography. I'm sure many of students who have done doctoral thesis in retina would have taken stereo photographs. And with the name of stereo photographs, I hope you remember the stereoscopic catalyst of macular disease still present in the RPC library. So you get, so the principle of stereo photographs is that you take slightly dissimilar images, one from the right side, one from the left, and then you see them with the help of stereo viewer or VR goggles, which are nothing but they are convex lenses, and when the screen is brought very close to the eye, you have got an image which is one image is projected to the right eye, another to the left eye. Now we have seen renewed interest in stereo photography and stereo videography with 3D animated videos. Good afternoon, ma'am. Which you see in malls that often kids enjoy VR gaming and VR glasses. And also, if you see online, you will find a lot of surgeries which have been recorded using the same principle that you can view. So that was the idea. I discussed with Dr. Raju is there. He's been one of my guiding lights. So if you know that what happens in an operating microscope is that you have got an eyepiece, one for the right eye and one for the left eye. You get slightly disparate images, and that leads to the principle of stereopsis. So what we did was that we put a beam splitter in between. Normally this beam splitter is used to attach a assistoscope that you residents, they see that while assisting surgery. So what we did with the beam splitter, I attached one camera on the right and the other on the left. The idea was that I am able to record two videos, one which has got a view what I would have seen for the right eye and other for the left eye. So this is my Lumera eye microscope, beam splitter, and one camera on the right and the other on the left. The right camera gets the view what I would see with the right eye, and the left gets a view what I get with the left eye, and there's an HDMI output to both. Now, what was the challenge with this tin video recording? The challenge was that you have to have two videos which are perfectly centered. They have the same area, they have the same sharpness, they have got the same color composition, and there has to be a temporality, the same temporality, that is, you should be able to record them simultaneously. So the big problem was that you have to start recording these two videos simultaneously, and that is how you can juxtapose them. So what we did initially, I tried recording 2 videos, and then I used to go in iMovies. For example, this is a screen. So you put these videos one over each other, and then using the principle of split screen option in iMovies, I used to put them together. So here it goes. So this is actually just for a demonstration. This is a video which we have put sideways, and that is how it used to appear. So it did meet some success, but the problem was again that how can you ensure, simultaneously you have to press the button, number one. Number two, if today I want, for example, this RP Center program is being relayed live on YouTube. Tomorrow if I want to do a live surgery and I want to relay it on YouTube, it won't be possible. I have to first record it, join them, and then go ahead. So then what was plan B? The plan B was that you often see these TV interviews going on where you have one camera and the second camera, and you get a joint. You can see these people on a sideway view. So I discovered that this is often done with the help of TV mixers. These are in broadcasting studios. These TV, the minimum a good TV mixer will cost you close to 4 lakhs. So what I did, it was kind of a frustration, but then this solution came. I was there at a wedding where I saw that they were having one video from the drone, the other video was coming of the groom. So that was the idea, and I went online and I saw this was a cheap Chinese HDMI mixer. This is called a multi-viewer. This is very popular in weddings. So what does it have? It has got HDMI inputs, and I gave these HDMI input of the right and the left into them, and here I got an HDMI output which actually looked like this. So this is one of my first few recordings of a scleral buckling, where we could get videos which were quite similar. There are individual differences in the glow, that will always happen, and that is how it started. So how to view them? To view them, you can buy these VR boxes, or these are these are basically convex lenses. These are one for 150 rupees. You can get them online. You open it up and you put it on the smartphone. Basically, it is a 13.5 diopters convex lens, so that you can come very close to the smartphone and you will get an individual projection in each eye. So you slide it over the smartphone and you come close. It works on the same principle as a VR box or a VR. And there it goes. So we have also done a validation of that. What we have done in the validation is that we have till now we have shown it to around 30 ophthalmologists. We have shown one 3D video on the smartphone, that is a stereoscopic video. The same video on the laptop, and the same video I have converted into pseudo 3D, so that there is no bias of choice. Otherwise, the person who's looking at a stereo video may have an option, have a tendency to believe that that video is better. So we have shown basically 3 videos of cataract, scleral buckling, and intravitreal injection, and we have evaluated them on various, aspects such as those aspects which I would like my student of cataract surgery to learn. For example, appreciating the anterior chamber depth, appreciating the position of the nucleus, appreciating the tunnel depth, same with the scleral buckling. So I'll not take you into the details of the findings, but what we found that the people, the trained ophthalmologists, they could appreciate the depth better in these 2 stereo videos. But resolution was better in the laptop screen. Why? Because the smartphone screen has an inherent limitation in the resolution in terms of PPIs that is had, but the small the finer stereopsis, such as appreciating the corneal incision depth or the scleral tunnel depth, that honestly they could not appreciate. Otherwise, other aspects like the anterior chamber depth and all those, the explant height, that was appreciated better. So to summarize, I believe this is the start of innovative and affordable 3D visualizing systems, and I wish more residents would have been there who are younger, more dynamic, and they are more tech savvy, and they can take it forward, and we can build a consortia which can move for an indigenous 3D medical technology that can help our students. Thank you so much.
Thank you, Sumit. Firstly, it's really nice that you kept your academic and creative mind and heart alive after leaving RP Center. So that's really creditable. And all of you speaking here have really got innovative ideas. We are going to be running short of time, so I'm going to request if everybody can shorten a little bit so we have some time for interaction. So when you're presenting, just see how you can shorten. And one thing I'll just give you as a food for thought is now there is a CMIE, which has been established at AIIMS, a Center for Medical Innovation and Entrepreneurship. And there are two things I will just share with you right now. One is, don't be very free with sharing your ideas openly. Try to think of, getting it recognized somewhere in the form of a patent, or think of it, because we're very free with our knowledge, because that's how we've always been taught to be, which is good also. But at the same time, we need to capitalize on our ideas and think of ways that you can at least give it some kind of a stamp of your name on it. And the CMIE is worth thinking of. There is a website, and you can look at it, because you can it can be a kind of a place for you to come and develop your ideas and even look at how it can go to industry, because ultimately that is what's going to take your name forward and the institute forward. So I will not talk much more about this, but you can check the website later on. CMIE, Center for Medical Innovation and Entrepreneurship at AIIMS. It is going to be something like a corporate research section. Just currently the research section is handling projects related to, funded projects. This is like, they're more proactive, and they are encouraging these ideas. And when we have the ideas in our country, why not, need to think of a platform, and they have various models of how you can have a place, to build on it further, and they have new places in Jhajjar and all also. So I know you all very, very busy people, but worth thinking of with these ideas. So can I go ahead with the next speaker, Thiru Malesh? Okay, Rajshekhar. Okay. Okay, so Dr. Rajshekhar is next, and he's going to talk about patient centricity in eye care. So this is the potpourri, but it's all linked to best delivery and innovative ideas. So we have patient centricity in eye care, Rajshekhar. So Rajshekhar, which batch were you? When did you pass out?
I was here between 90 and 93, and did senior residency from 93 to 96. 96 left AIIMS.
Good. Good.
And thank you, ma'am. So, good afternoon, everybody, respected chair and my dear friends and colleagues. So today I would be speaking about patient centricity in eye care. So when I say this, what is new is the thing. All of us know what is patient centricity, and we are all committed to that. But can we take a fresh look at what could be the patient centricity in the coming years or the present changing scenarios? So then and now, if you compare, earlier we were talking about patient, now we are more talking about a person who comes with a disease. Cure was important, now it's cure is taken for granted. So nobody praises you for treating something, it's taken for granted. What else is the thing? Earlier people were coming for medical treatment, they were happy with prescription, now they talk about how their experience was. People were afraid of how the surgery would go or whether the treatment would be right or wrong. Now it's not about that. So it's already a guarantee they have come with, either by your brand name or your Google ratings or the word of mouth. So and hence that risk is not there in their mind. Earlier risk perception was high, and hence they were more amenable and receptive to what we say, and they were praising. Now it's no more the case. People had a lot of time and patience probably, and now people are restless. Especially I come from a city, Bangalore. There, if they take appointment at 9 o'clock, 9:05, they'll start fighting, saying, it's already 9 o'clock. So the 5 minutes is not even the time for registration. So that's the kind people have got into. So we can't blame them. The society is turning that way. And then they had a lot of family support. Now it's about individuals. Loyalty was there, people were ready to travel a lot of distances, now they see convenience. Earlier, in a proper consultation or in a disease scenario, The doctor's role used to be around 80% and 20% the support services. So now it's almost reversed. So in the entire treatment scenario, the doctor's role is minimized to 20%. The 80% is taken up by the various, it could be appointment desks, the ambience creating, patient experience teams, or the insurance, so many other things. If you just see, our roles are coming down. And the other changes are longevity is increasing, lot of geriatric population we are dealing with, and hence we have to probably relook at the way we have designed our hospitals. And a lot of comorbid conditions will be there. A lot of patients come to us on wheelchairs, they are on other treatments, they'll have other problems. And hence, how are we designing our setups and how are we caring them? In addition to this, awareness levels also, they have their own definition of the disease, and their access also has improved. You are one of the choices to them. And in the market, it's not one kind of care that goes on. Some hospitals, right from free entry to free coffee tea to everything else free, and the other side it's go on waiting forever. So a lot of things keep happening. So to put them in some kind of a perspective and to have a lot of thinking around it, 5 areas can be thought over that. One is understanding the patient needs. So here seeing them as a person, it could be their lifestyle, there could be degree of visual impairment, their overall dependency on support logistics. Like when we decide on a surgery, we will also have to look into who will come with them, from how far they are traveling, where are they staying. All those things also are important, because those things are going to help them take a decision of choosing a place A or place B or place C. And from that point I'm saying, and empowering patients, that's the second point, so we may have to literally teach them ophthalmology here. There was a time when we were just doing things, and if they finally get the vision or if they become better, they were happy. Now they want to know what is happening and what is the treatment, what are the risks, benefits, so many other things. And hence this is another new challenge when we have to design our work system, that to what extent we are educating them. A simple test is, if a patient is moving out with visual field, litmus test is, I go and ask them, what is the test you have got it done, what do you know about it? If they can explain me what they have got it done and what they come to know of that, that means we have done our job. Otherwise also we would have done our job medically speaking, but not from the point of view of the patient centricity. Third point is probably improving access and convenience. So if they have to meet you again, or if they have to reach out to you, how easy it is and how difficult it is, what are the channels that we have created. So availability was good enough in olden days. Now availability with what ease has come, and then availability with ease and with convenience. They are okay even if you go home and treat. Some people are already doing that. So it's a changing times, and patient centricity is dictating how we have to adapt ourselves. Fourth point could be comfortable environment. So the way we design hospitals, eye hospitals have to be different from the other ones, basically because we deal with a lot of people who come with visual impairment, geriatric population, and then a lot of anxiety around their illnesses, comorbid conditions, so many things. And hence, we may have to take a look at these things also. And fifth point is continuously improving care. Here, involving patient in terms of giving feedback as to how we have to be, so that we can understand, because there is a lot of regional differences, cultural differences in terms of patients' expectations and patients' understanding of the disease and the treatment. So with these few points, I thought I'll say, in addition to being very good doctors, clinicians, and those who are healers, we have to also take care of patient centricity in what we do. Thank you very much for this.
Thanks a lot, Rajshekhar. So he's brought up some certain very important points, and this is universally applicable. Yes, please, Tirumalesh. So universally applicable, and it's very important to be aware of how times are changing, patients are changing, and any tips as to how you train your staff? Just one, because there's such a lot of people, they come with different backgrounds. So what is your process while he's setting up? What is your advice on how to train the staff? No, let's not talk
so as
about
doctors, it's
You're
more
absolutely right, because the doctors also need
because
sensitization.
staff see how we behave, and
Yeah.
hence, it's difficult to have different things.
Yeah.
I also ask my doctors to have a role play, come in as a patient and see
Yeah.
what all things.
Yeah.
I ask them to sit in the patient's chairs and go through the process. Then immediately they'll come to say this could have been better, that could have been
Sure.
better, and things like that. If we think like a patient and walk like a demanding customer, probably it becomes very easier. It's
Right. And
not
this is
rocket science. Only
important,
thing is we don't.
This point is important, that to train everybody together so everybody is on the same page. Excellent. Thank you, Rajshekhar. So, Dr. Tirumalesh. And for the benefit of the people who are from different batches, just tell your years of being an RPC.
So I joined in 2007, ma'am, and I was here for the junior residency and also senior residency for 3 and 3, so total 6 years.
Fantastic.
So the topic that I am going to talk about is the atypical path and what lies ahead. I mean, why I am presenting this is when I told a few people that I am doing a little research, and that's called as translational research. Many people ask me, what is that? We left surgery. So to just say that I have still not left it, I'll just show a small clip of our diabetic membrane that we usually operate in our place. So to do research, it is not really required that you stop doing surgery. You can still operate the most complicated cases and still devote your time to developing something new. So you can see, I practice in a place, in a tertiary center where we have a lot of renal patients, type 1 patients who come with these bad membranes. So we tend to do these surgeries, and Rajshekhar sir had once told me that, research ಮಾಡ್ತಾ ಇದೆಯಾ, don't leave the clinical practice. So I'm still doing those, sir. And the surgical skills that I acquired is thanks to this person who taught me whatever I knew in vitreoretinal surgery, and I should be thankful. They say that you should always choose your boss. So once I finished, I joined Vasan for some time, and then after a while, I went to RP Center, and then I met this guy who's in the red jacket. This guy changed my life forever. What he said was, yeah, clinical practice is good. What is the thing that you can offer me more? Then I told him, sir, I come from RP Center where they taught me about clinical sciences. I don't know nothing much. He said, go meet my team. And then I meet these people. So the one in the blue shirt is Arka Shubhra Ghosh. He has the patent for the AVV vector. The one in the purple shirt is Dr. Swaminathan Setu. He is a immunologist. And these people told that we are doing a little research, why don't you come? So I went to the animal lab the first time. So they were running a diabetic project. They said, can you be on board? I said, yeah, why not? And that's how the journey started. And we were also looking at aqueous biomarkers from where we gathered a lot of data. The soluble AIIMS kind of cropped up many times. In patients who were non-responders, this particular molecule used to come up again and again and again. So we all know that diabetic retinopathy is a complicated disorder. It follows multiple pathways. We know that the RP has some problem. We know that the RP is under stress. We also know that the endothelium is under stress. We know that the neurons are under stress. And these are the pathways, and you can see that there are subgroups of each molecule which can be investigated to develop newer treatments. So coming to AIIMS and why we followed it, I'll give you a small this thing. AIIMS is an immunoglobulin-like transmembrane protein, which when activated binds to the leukocytes, and it helps in rolling of the leukocytes. So these leukocytes are the one which kind of damages. So many might ask a question, you are seeing soluble AIIMS in the aqueous, so is it really there? So we took donor eyes and then we subjected to immunohistochemistry. And we found that these AIIMS receptors are present both in the choroidal endothelium and also at the RPE. So we knew that AIIMS is something which kind of has a role in both pathologies at RPE level and endothelial level. So this was a mechanistic phase. We were trying to induce some amount of inflammation in the ARP culture plates. And I'll show you how it looks like. So this is a ARP culture plate. And when you just add NK cells, see the NK cells just swim over it. You can see the underlying RP is healthy, it is not under stress. The NK cells don't do anything. But the moment you induce stress, this is what happens. So what I did in this culture plate was I took RPE, I put a little TNF alpha. The moment it is under both stress with inflammation and also light toxicity, you can see that the NK cells start killing the RP cells. So this is what is happening at the cellular level, even in in our patients where RP is under stress, the endothelium is under stress. So based on this mechanisms, then we also saw what happens if we take a culture plate of HUVEC cells, which is human embryonic endothelial cells, and we subject them to tube formation. And what happens when we add VEGF? We know that it causes neovascularization when we add them. So the tube formation was there. So the one molecule that we were working on was an AIIMS. So we put the AIIMS. You can see that it is as effective as the VEGF in making these tubes. So after that, we thought, okay, let's work on the mouse model. So they put me across to this. So there are two types of mouse that we work on. One is the wild type, and the other one is the spiral SD rats. So the SD rat is the universally accepted model where you take the mice, you put streptozotocin in its peritoneal cavity, you wait for 12 weeks, there is development of diabetes, and then we can see what happens with that. So we were interested in seeing if I put the ICAM after the development of this endothelial leakage secondary to this induction, does it work? And I compared it with the molecule that we always use, which is anti-VEGF in the form of ranibizumab. So I'll show you what happened. You can see that picture A is when there is no STZ and we sacrifice the mice, and this is how the retina would look like on a wet mount. So before we subjected this, we injected the tail vein fitsidextran, and then we sacrificed the mice after 2 hours. So you can see that the moment you put STZ, there is leakage. So if I put ICAM, which I found was, causing the non-response, leakage is enhanced. And already diabetes has VEGF within the mouse eye, and when you put ICAM, it becomes more. So the severity of the disease is probably also affected with this particular molecule. So what happened when we added LFA1 was, it kind of prevented leakage. Now we'll show what happened when you put anti-VEGF. You can see the C window there. There also the leakage kind of reduced, and it was as comparable to the LFA1, if not better. Now, this particular research led on to a lot of collaboration. You can also see a couple of LVPI people here. So these are the people who are also collaborating with us in some cornea work. And you can see Dr. Debash is there. He is the one who kind of guides me when I have doubts regarding these molecules, and I tend to ask questions. He's the one who says, no, you're on the right track, so you have not lost your path. So work on these, because at some point of time, anti-VEGF alone is not the answer to many of our diseases, and it can help. And I came with an agenda of also campaigning for election, so I am contesting for member scientific committee, and I expect your vote. Thank you very much.
Thank you, Thiru. So that is another very exciting area, drug development, drug discovery, and you have to a lot of effort required to do the in vitro experiments. So it's very nice that you are taking time to spend on this basic research as well. So in the interest of time, we'll go ahead with the next speaker, that is Dr. Kaushik Tripathi, who's going to cover another very important area, takeaway points from landmark judgments on medico-legal cases in India. While Kaushik is setting up the slides, maybe any question for Thiru? While the slides are setting up, the moment they come on, we'll shift. And as I said, try to shorten your talks just a little bit, because we all know everybody is brilliant, but we would like to have some interaction. You come all the way, all that distance, so keep a little bit of time. Just skip over something so that we have some, but this is really encouraging. And ICAM, was it intravitreal? Anti-ICAM, and the, you had two things, na? One is you put anti-ICAM and anti-VEGF. So yeah. The diabetes, yes, and after 2 weeks.
To see what happens if I add the recombinant ICAM.
Right, you give it intravitreal.
We saw that it made it more severe.
That was clear.
And then we took the anti-ICAM molecule and we injected
intravitreal.
in the rats which had diabetes, and it showed reduced leakage.
But what was the gap between the injection and the specimen?
About 4 weeks.
4 weeks. So that means clinically we can say it will take 4 weeks for it to regress. But did you look clinically also, or this was not visible clinically?
The SD rats will develop a white rat, so you cannot image them clinically. The wild ones you can actually do an angiography. So what we are doing next is we are inducing ICAM overexpression in wild rats. They we can image, because we can do a fluorescein in rats.
Got it. Thank
Can
you.
I ask?
Yes, Rohan.
Very interesting work. So a lot of people have been studying a lot of these cytokines, these molecules and others. What made you select ICAM?
So like I said, we were collecting data. When we used to give injections to patients, we also used to take the aqueous, because you tend to decompress the AC to reduce the pressure when you give an intraocular injection. So we took a ethics committee approval, and then we collected the aqueous, and we started analyzing. So in the clinical data, wherever there was non-response to VEGF, in all those patients we consistently saw that ICAM was very high, among other inflammatory factors. And ICAM modeling, our group was working on in other diseases as well. So we had the vector ready, we had this thing ready. So that's why we thought, why not investigate that first? And it did work at the first time, and we were able to check into the molecule.
Very interesting. Thank you.
Thank you. Thanks RPC for having me here. I was there from 2010 to 2016 at RP Center. I'll be discussing the summaries of some medical legal cases and our learning from them. This was a case of Joseph I Hospital, Tiruchirappalli. Around 66 eyes, but 61 eyes lost vision and 5 eyes actually partially lost vision due to endophthalmitis due to pseudomonas endophthalmitis. The session court actually awarded a compensation of about 22.5 million rupees to the victims. The reasons were that the hospital was not approved to run. There were the sterility was not maintained, the design and maintenance of operating room were not proper, anesthetists were not there, preoperative laboratory tests, there was no facility, and the point is that the ringer lactate which was used during the surgery was found to harbor pseudomonas, but the honorable court in their judgment they exonerated the makers of this thing, Baxter, because other batch was shown not to harbor this organism. Another case, this was an old case, around 84 persons in Khurja and 15 eyes in Muradabad, they lost eyes vision due to endophthalmitis in 3 cases, and this led to guidelines of how to perform free eye camps. This was another case in which Supreme Court awarded more than 26.5 million rupees as the pediatric actually proper ophthalmological screening was not done in this case. This was a case in which a patient had dengue hemorrhagic fever, and in the ICU he developed bilateral visual loss, and the ophthalmologist saw the patient 13 hours later. He was later referred to AIIMS and he was treated properly, but the court found the doctor negligent, and this State Consumer Disputes Redressal Commission awarded 3.5 million compensation to the patient. Delhi Medical Council and Medical Board previously actually. This was another case in which after LASIK the patient underwent toric ICL, but he claimed for around 60 million compensation, but this was dismissed because the person actually completed higher education and he was gainfully employed and he was active on social media, thus the claims were incorrect. So another thing to ponder is use of bevacizumab. This bevacizumab, though it has been seen and hundreds of literature are supporting its use, but spurious injections have caused multiple eyes to become blind, and as of now the legal aspect of using this thing intraocularly is controversial and caution should be exercised. And this was another case in which compensation was awarded due, as preoperative tests and fitness certificate was not taken. This was another case in which there was improper documentation. The details of ROP including the stage zone was not written, and it was written that just no ROP was seen by the ophthalmologist, but court found that this was inadequate and they thought that neither the doctors had done examination of ROP or not did they advise for follow-up of ROP. This was another case in which 9-year-old child underwent ophthalmic surgery for squint, and ultimately he had asystole and bradycardia and died. So the Consumer Redressal Forum concluded that the consent was not informed consent, and the documentation was abnormal because glycopyrrolate was not written. There was a short form abbreviation glyco was written. This is another case in which a case of pterygium developed ocular damage due to continuous use of mitomycin C. The patient actually did not see the doctor who prescribed mitomycin C, but the problem from doctor's end was that he did not write how long the mitomycin should be drop should be continued. This was another case in which proper post-operative instruction was not given, and the coolie continued to work after cataract surgery and he suffered corneal injury. This was another case in which 1 crore compensation was given for a patient who died during squint surgery due to oculocardiac reflex. This is another case in which a vitreoretinal surgeon put C3 gas inside the eye, and the patient patient claimed that he developed CRAO and optic nerve injury due to this thing, and as he flight to USA. But it was noted by a medical board at AIIMS that he had excellent vision even after he traveled via air, and at USA the vision was actually 20/20/20/30 even after the set air travel. He developed glaucoma later and vision was lost later. So take home points will be pre-cam surgeries will you have to rethink of that, because medical legal implications exist. Medical indemnity cover should be at least 1 crore, and intravitreal avastin is a gray zone, and please exercise caution. Thank you. I'll acknowledge Dr. Arati Heda for helping me make this presentation. This is my team at UC Legal Court team. Thank you.
Thank you, Doctor. It was a nice presentation. If you look at the first case where Pseudomonas was the cause of this thing, but the court went on to, can you show that first slide? Court went on to decide the case on various other factors. So if you go to a court of law, in many cases I have gone in various capacities, the lot of discussion goes on what actually would not have contributed. Other than Pseudomonas, that pollution control board certificate was not the cause of endophthalmitis. It also didn't exist before that. Many other things are not contributory. The discussion goes on a different note. So this is where expert bodies from the societies become extremely important. In the court of law, we have to push the discussion, saying, you know, it has to go to an experts committee. So in that case, if ringer lactate was the cause, they could have gone directly onto that. If our experts, this is where societies should work in lobbying with the courts. One thing.
Should we ask the next person to get the slides loaded?
Yeah.
Yeah. Vivek Dave, please.
But the consumer court, especially the consumer courts, have this habit of not taking the expert opinion into consideration.
See, actually what happens, it is the degree to which we do lobbying. If the expert opinion is backed up by the society like AIOS, which says 25,000 members we have and all that, then that will be taken into account. And entire discussion should happen around the experts' opinion. And second point is some fault with us only. One is documentation is extremely important, but this documentation is also getting stretched to a lot of levels. If you write medicine, then they'll say, did you tell the side effects of the medicine? Did you tell some more side effects of the medicine? There's no end actually. Finally, they can say you have not told everything. And after having told everything, also patient can say that nothing was told to me. You can't go on writing everything. So such gray areas are there. We need lot of society lobbying. Secondly, our research papers, ma'am. Whatever research papers come, if you read if somebody goes on to say that endophthalmitis research and all that, if they do search, nowhere they will say that it could be due to factors other than the hospital or the doctor. There are no such conclusive things will come in any of the research. And if you look into research paper, they will again use some sentences where they balance it out. So in fact, with clear-cut lobby, we have to publish some papers which can protect the doctor, saying, you know, this is the kind of endophthalmitis that can happen beyond human. One example is medication errors. I don't know, what is the medication errors at RP center, ma'am? How much percentage or something like that? Any?
No, we haven't done any analysis as such, but you're talking about the wrong medicine being prescribed?
Yeah, wrong medicine, wrong site, wrong dose, wrong patient.
Very rare, very, very
See,
rare,
we don't do that.
Yeah.
We have to proactively do such research and publish it. So then, you know, somebody else can say that, sir, this is possible, human errors are possible, and hence it's fine. See, we were looking for our NABH data, benchmarking data. 5 to 6% is the errors that is published internationally. 5 to 6% of errors are medication. It may not be 5 to 6% actually, but they project it like that so that no colleague will get affected. So here, no hospital has even 0.1% medication. Anybody you ask, they say 0%. And one more thing is, while counseling, like for cataract surgery patients counseling, or if they come and say, I got good vision, thank you very much, and all that. Nowadays we have started saying good vision is not because of me. Cataract surgery only improved entry of light into the eye. Whether that light becomes an image and then beautiful vision, it depends on other parts of the eye. To that extent, so that if we start taking credit to the fullest extent, then tomorrow that itself will backfire on us. If we limit things to what we have done actually, then that also protects.
Yeah,
Lot
so
of
there are
things.
very important points you've raised, and in interest of time, I'll just put two, 3 points which are important. As you correctly said, that what is the margin of error which is acceptable, and what is the data, what can be taken as a standard. And here I would say that in a way our medical profession is a little bit like the airline industry, and the airline industry also has similar problems, but they have a little bit more seriousness in the way they have their protocols, and they have everything written, which we don't take. So there are errors in the airline also, and it is exactly what happens in the doctor's mind when you're doing surgery, where at that particular point the person in the driving seat or in the pilot seat or on the operating table does take decisions, and often there will be an individual variation, and this is something which courts of law and judges, they don't understand. And once you go in a court of law, often it goes in a total tangent, as you realized over here, that they find some pollution control board, and the whole situation goes haywire. But the point you make is good, that in society we need to reinforce the impression that doctors are generally wanting to take care of their patient. No doctor is going to be intentionally wanting to harm the patient. And it's in society, the perception of the sort of thought process of a doctor and the ethics of a doctor needs to be improved. And we have kind of this kind of a victimization of doctors and criminalization of doctors, which is wrong, and that is what is required from societies, which will be considered valid. And one last point I would like to say, that documentation, as you said, is important, and the patient-doctor relationship and trust. That, when it goes haywire, again, is extremely difficult. There's no simple answer to that. But I'm glad you brought through all these cases, because it's good to be aware. And we also have a whole lot of stories of interesting cases, and we're often in a dilemma, and that can be a whole day's exercise. Maybe one can have it in the future. Ravish, anything important? Quickly.
Thank you,
There are
Ravish.
things that we need to keep in mind for the future, and actually RP Center itself, we don't require any society. RP Center itself is considered often as the port of call for any consultation. So we ourselves can have a kind of repository of information which can be taken as a benchmark to at least have a rough guideline. And this thing about 0.05% rate of endophthalmitis, when we have sometimes a slight increase, now we have a daily reporting of any infection, and we have an infection control monitoring committee, and Rohan and Pradeep Venkatesh have sat on many of those meetings, where the moment the data is going like a few too frequent cases coming, then we look at it, and then again we looked at the analysis, and it was helpful to know that what was the actual percentage and whether it was within the acceptable limits. So it's good to have some kind of repository, but again, it may be 0.05, something may be coming to 0.0512. So you have to remember that lawyers and courts can always take things in the wrong direction, but it's basically important to put things sensibly.
In UK, they encourage reporting such things, ma'am. In a worst case scenario, they'll put the doctor for training and ask him to learn and come back after 15 days, 1 month. Here, is there any such open mechanism where you can report your problem and say, I went wrong here and probably I'll learn and something like that? It's not there, no?
We've started reporting of endophthalmitis now, but we
That's
can
good.
have in-house. So I've just been told that we've just been reminded that we have 3 speakers and 20 minutes. But I've enjoyed the interaction. So if you can make your talk shorter,
Sure.
and then we have a little bit of time to speak. Yeah.
Right. Thank you. I'm Vivek Dave from LV Prasad Eye Institute, Hyderabad, and I was at RP Center 2005, 6, 7, and as a senior resident 8 and large part of 9. This is against the run of play. This is not something innovative, but just a case which taught me persistence, because one thing after the other kept happening. I'll try to run through this quickly. A 17-year-old male, trauma to both eyes by a tire blast 2 weeks before he presented to us. Right eye 2200, left eye hand motions. Both eyes embedded small foreign bodies in the cornea, also multiple retained foreign bodies in the left eye. The patient had a previous intervention elsewhere where a lensectomy was attempted, which was partially done, and a partial vitrectomy was done for endophthalmitis. So we skip to the first intervention. I am clearing out the residual lens of the lensectomy. You can see the blasts on the surface, the small embedded stuff in the surface of the eye. Then a PVD is being induced to clear out all the residual vitreous that was there behind following the partial vitrectomy that was done elsewhere. One can clearly see one of the foreign bodies which was down here behind and here. And as we clear the peripheral vitreous, we see more and more foreign bodies getting loosened up. So many than what were seen on the original ultrasound imaging were found in the eye, all embedded in the peripheral vitreous. With the clearance of this vitreous, all of these foreign bodies sort of got free. Luckily they were magnetic, so a magnet pulls them up. Retina is looking good, fovea is looking good, and you're thinking in your mind, okay, fine, this eye is going to have a very good prognosis. One after the other, you bring them all out using sort of a handshake technique. I'll just take the video slightly forward. Now, there was one foreign body which was there right at the port site. I was not able to dislodge it using my cutter. So put in a chandelier, and now bimanually with depression by the left hand, I'm using the cutter to clear out the vitreous around the foreign body and free it from the peripheral entanglement. Again, removed it with a magnet, and the area which lodged. This was followed by peripheral indentation, and everything seemed fine. I filled the eye with air, and in my mind it was like, patient will come back 2 weeks down the line and I'm likely to have 6, 9. But this is what I have 3 weeks later when the patient comes back. Vision is hand motions, and I see a large giant retinal tear inferiorly. This is an intra-op grab. Now, indentation was done as far as, I'm sure I could not see anything, but this is what it was. There was an inferior large dialysis. So taking him back onto the table, multiple membranes seen, multiple puckers, all of them released. Again, I'll take the video a bit forward to the crux point. Once all these membranes were released, PFCL was injected to flatten the retina. Now what was important here is we see good amount of flattening coming up everywhere except the inferior 2 clock hours. So inferior few clock hours, if you see, the retina still stays taut and sort of raised. So that tells you this will require a radial retinotomy to relax all the stiffness that is present within the retina. So 2 such radial incisions were given after diathermizing the retina there. And after having done that, the retina falls back into position very well, and PFCL fill is completed and endolaser is done. Now this having had some sort of advanced PVR, what was on my mind was to leave PFCL inside, which I have been doing for a few cases recently for PVR cases. In this situation, unfortunately, what I found now was a detachment again. Now this time it was superior. Some amount of PFCL had come into the anterior chamber and the superior tamponade was lost. To complicate things, a small macular hole developed right there at the fovea. So we take him again on the operating room, remove the PFCL. Once the PFCL was removed, now we have a detachment with a macular hole. I cross-checked the size and the dimensions of the hole on an intra-op OCT, and then we go ahead and sort of do an ILM peel like you would in any macular hole. This was under IOCT guidance. Not that you required that, just because we had the facility available. The advantage here was once the ILM was peeled, I left it with a pedicle attached to the edge of the hole and let the flap come over onto the hole, and you could have an immediate sort of a cross check right there on the table to see whether the hole was closed on the IOCT as being seen in the images on the side. So this is again a video grab. This is what was the final peel. At one edge, the peel was still attached. It was not a complete peel, and the flap that was created was just laid down on the fovea there. So the hole closed post-op. This was a grab 2 weeks down the line. This was the OCT, not very clear at this visit, but another month down the line we could see that the retina is attached. A few residual PFCL bubbles are seen in the subretinal space, but because they are not bang at the fovea, leave it. And this is what the OCT looked like. So hole was closed with foveal atrophy, but the patient ended up with a vision of 2200. So just a thing that trauma management can be a long haul. It would test a surgeon's entire surgical skill set. Any subsequent step can ask a different surgical question of the operating surgeon. Yeah. Thank you for your attention.
No, Vivek, in these cases, was CT done before, I presume, or you depended only on ultrasound?
No, I actually do a CT scan in all cases. By default, I do not take a patient up for foreign body removal just on a B scan. Okay. So I'm a strong believer that a B scan can sort of, rule in a foreign body, but it can't really, rule out. If you see it, it's there. If you do not see, you could still have missed it. So the CT showed 4 foreign bodies. At the end, we got a total of 6 inside.
Okay, did you go back and review the CT? No, the reason I'm asking this, could you have placed your port somewhere beyond what you'd done? If you knew there was a foreign body there, maybe you could have placed your port away from that site, and that would have probably made your dissection easier. So if you probably go back and see why the CT had...
Sure, that's a thought. I'll do that.
Patient was aphakic, which is why probably he didn't realize. We have this often with complicated grafts. The graft is clear, patient is aphakic. They cannot see that little haziness that they may get with any problem. So that may be why he didn't realize that his retina had detached and he came so late. And later he wore a contact lens for night vision or whatever.
No,
did you give him it was aphakic, right?
He was aphakic. The contact lens, so this is somebody who was managed about 5 months ago.
Right,
so now the patient has had a silicone oil removal, and we are going to plan for a glued IOL. A contact lens trial was done in general to see the visual potential.
Right.
Current visual potential is 6.9, so he's due for a glued IOL shortly.
But like his iris and all is also quite atrophied. The iris, well, you have to be a little careful for him.
Correct.
Because he may have edge glare and all that. But anyway, good surgery.
Thank you.
So Dr. Brijesh is going to tell us about...
They still tend to be higher. And one of the reasons that gathered from our literature search was the metabolic memory, which keeps on hammering on the patient again and again. Then the census from RP center itself, which showed that there's hardly any screening which is done in India. I mean, 90% of the diabetics have not had their screening. Then there is a lack of secondary prevention, which means that once they are going to develop retinopathy, we don't have anything to do but just to keep on screening them. And then there is a long latent period which we have at our hands. So there is possibly a chance to tackle diabetic retinopathy with some other kind of treatment. So within this, why to study microbiome itself? So the next literature search was what kind of therapies are available. And what I found with my team, I'm sorry about the way the slides look, but they look better over here. But what we found that the gut microbiome probably holds that key which you can tackle diabetic retinopathy in the very early period way in a non-invasive fashion. So then further going into literature search, these papers which I show you are from LV Prasad hospitals itself, and chiefly Dr. Tara Prasad Das is to be given the credit for these. The photograph in front of you is basically a heat map, and what you find over here, if you can see my cursor moving,
Then the red ones are the people with diabetic retinopathy, the blue ones are with diabetes mellitus alone and no retinopathy, and the green ones are the healthy controls. And we find that the gut microbiome in all these individuals is showing some signatures of a variance. So this subsequently we could prove in rats also, and we could prove this for microbiome also, and in the gut. So basically rat diabetes mellitus, as Dr. Thiru also told, it kind of represents type 1 diabetes. So basically type 1, type 2 diabetes, both in rats and humans, showed us these differing signatures. So then again a literature review after literature review. So this was a hypothesis as to why the gut can actually be linked to the retina. What are the possible mechanisms? And I have two of my mentees to thank this for. The one is Dr. Pratima, the other one is Dr. David. One of them has now a faculty at LB Prasad Hospital itself, and we could actually find 6 different ways by which the gut could actually influence the eye and cause retinopathy. So then was the big or the stupid question. So are there microbes inside the eye also? So these are the people, Dr. Shivaji, Dr. Jayasudha, Dr. Shalam project, or rather I worked with them on this project. And these are the inclusion-exclusion criteria. We could analyze 12 people. We balanced them for diet using the UK Diabetes Questionnaire. We took out their aqueous samples, their gut samples. We went through metagenomics. We amplified their DNA, ran it through an amplicon sequencing libraries, and generated what is known as taxonomic profiling, by which we could profile what microorganisms are present. We did lot of quality checks, you name it, rarefaction curves, the way samples were collected, the way negative controls were done. And after that, we developed this heat map, which shows us that in the purple marked people which have retinopathy, a lot of organisms are absent. These red ones means that the organisms are absent. Whereas in healthy controls, as well as people with mellitus, there are some organisms which are present. So there are definite signs of differences. And if you look at these 3 tables, this table tells you about the differences between healthy controls and diabetes mellitus, whereas this table tells you about the differences between healthy control and diabetic retinopathy. And the last table tells us the differences between diabetes mellitus and diabetic retinopathy. And we find that the widest gap is between mellitus and retinopathy. And chiefly the anti-inflammatory bacteria seem to be absent inside the aqueous humor of people with diabetic retinopathy. So we had many limitations, the chief one being that this is a pilot study with 12 samples only. However, there was a lot of rigor in inclusion and in the sampling sizes. Finally, what we concluded was that irrespective of our health, all of us sitting over here probably have some kind of a microbial signature in our eye. This dysbiosis is distinct from what we see in the gut. And then there is a difference between mellitus and retinopathy. So all this is towards a preliminary therapy. And as Dr. Radhika said, keep some time for interaction. So the Buddhu has come back to home. I have still not left RV Center.
Good. Thank you, Rajesh. So any comments from Pradeep or Rohan?
Very interesting, Vijesh. But you identified all these bacteria based on the DNA fingerprint, right?
So, Dr. Rohan, we use a primer for the 16S RNA gene. So this gene is supposed to have been preserved all through the evolution in an organism. So basically what this means is if we get signature of this particular gene, then we are not wrong in speciating them.
So basically it's a genetic analysis. So actually that just shows that there is a fingerprint of the organism in the body. It doesn't show that the organism is actually there in the eye somehow. So that is why some metagenomic studies even from blood have shown that some of the organisms you will find lifelong and the patient doesn't have septicemia ever. So that is why these studies have, I think, a long way to go before we can actually say these organisms.
Absolutely, Dr. Rohan. So I said all of us have signatures of organisms in our eye, and we are now going forward towards metabolomic studies and see whether the genes are being expressed of those particular organisms inside the eye. So I think I'll leave.
Maybe something like the skeleton of, I mean, I'm just using the word skeleton, but the DNA is roaming around somewhere, and then because something about the change in the vascular pattern, that is why it's going into the eye this way or that way. So it's very fascinating, this concept, because first when you're talking about microorganisms inside the eye, you know, you feel very worried.
You feel violated as a
yes,
yeah,
but I think that's what it is. It is some kind of a imprint, fingerprints, skeleton, whatever you want to call it, just like a prion disease kind of thing. But it's interesting and worth looking at. So we go ahead now and hear our Pradeep Venkatesh, and he's going to
Gopal.
Yeah.
Yes, no?
Gopal, we missed out Gopal.
No, he had a
You have a question? Yeah, please tell the question quickly.
No, it is very interesting. Anyway, you are doing the animal studies. Why don't you consider a fecal transplant or something like that next so that
No, absolutely. So there are various ways of using the microbiome for therapy. One of them is fecal transplants, already in some phase trial for diabetes mellitus itself. But I'll not stand in front of my mentor for long.
Yeah, this particular thing is actually not meant for born surgeons, and I'm not a born surgeon. Okay, this was essentially meant for people who need to train to do their surgeries, and I've trained to do my surgeries. Okay, essentially, macular hole, I mean, I had not seen any macular hole surgeries while I did my senior residency, and the first patient I operated on actually was a private ward patient, and I was sure I had peeled the ILM, there's no stain, but the next day, I mean, during the follow-up, the macular hole had actually enlarged in size. And then I really didn't have the faith to go forward and do more surgeries. And subsequently, I regained something. And then because at that point in time, they said you can tap the macular hole edges. And then those patients, 2 of them did close, but then I had RP loss in those patients. And even now, I'm not sure if this particular surgery is very predictable. Although most surgeons feel that they can get and the step that is most critical is getting the flap. Having the ILM fracture is the most important step. And I think there is no particular rationale why we say that we have to do it at 1 to 2 disc diameter areas. And I don't think it is really reproducible. And I cannot really tell my students why I'm doing this particular step. And when you're actually telling them, the usual thing is this: you do this, do that, and then you say that, okay, I'll show it to you. So you're not actually able to translate and tell them why you're doing those actual steps. And that's when more recently, actually, and I've been also wondering why we're not using the macular hole edge itself. And this is the first surgery, actually, I did with the edge peel. And no.
It's from his
Yeah, this is a slide which would be okay. This is one of our patients way back in 2006. You can see a pseudo hole that is there. Okay, following a macular hole surgery, you're seeing almost all the complications that can happen. And in the beginning phase, like when you saw 2 days ago, Dr. Subendra was he was presenting his complications. Okay, and he and Vinod made a comment over there that you need a heart to actually present your complications. And I think almost all of us have had difficulty learning this particular surgery, and we generally do not like to talk about it. It's human tendency, agreed, but I think as youngsters, if I have to get a surgery done, I have to have somebody who I've trained well, and he knows what he's doing, because not everybody is a born surgeon. Okay, and that's where I think this particular approach of, please video, play card लीजिए. This particular thing, because there's a natural 360-degree edge that is there, and if you look at the anatomy of the ILM at this particular region, it goes from 1 micron, it goes up to 3 microns. So you have an adequate thickness of the ILM over here. But what happened was I requested one of my very close colleagues and one of my senior residents to try it, and both of them said they were not comfortable. What actually had happened was they were still using the ILM forceps, and in this situation you need to use the end grasping and not the ILM forceps to initiate the flap, because you already have an edge. And once you have an edge, the end grasping forceps, which it has a larger surface area, is much better than having ILM forceps. Although you can do your surgery completely with an ILM forceps. And yeah, there it's playing, yes. And in this first surgery, if you actually see, I've initiated. I'm sorry, it's kind of taking more time than what I. Yes. Yeah, okay, so initially it's just with the ILM forceps, and the direction of the pull also, you're not seeing that the hole is enlarging. There's a fear that the hole will enlarge, but nothing is happening over here. And obviously, and the depth of the macular hole itself also gives you better stereopsis. Many a times it's kind of a flat surface. It's very difficult to grasp anything where it's taut and on a flat surface. End-on approach to anything is quite difficult, and here the hole itself allows you to have a depth perception. So I personally feel that this particular technique has reproducibility, and there is an anatomical basis for using this particular surgery, and I request even the born surgeons to try it out, and then please give me a critical feedback on this particular surgery. Yeah, one other small thing is that the edge is not flush with the macular hole itself. The ILM edge is a little, little receded away from the macular hole edge. So please don't try and hold the macular hole edge itself. It's a little beyond that. Yeah, that's all I have. Yeah?
Pradeep,
Thank
what
you so
exactly, how is it different from what other people are doing?
Well, the initial thing, ma'am, we actually use the thing from 1 to 2 disk areas away. Like I've just made, I hope this plays.
So you say it doesn't have to be that large.
Yeah, see, we initiate the flap here, way away from the macular hole, and then we strip it off like that.
Okay,
So
and
this is
other
going
people are
from
starting
inside.
at the edge.
You know, I've just started doing this procedure now.
No, I think it's a very good idea.
So this is
It's a
just
good
an animation
concept.
I'd made.
Yes.
And the usual procedure is this. Yeah, this was essentially, like I said, for the youngsters. Yeah.
I think that's
Yeah,
good.
thank you.
Yeah. Thanks a lot, and I think we are okay now for our time. Are you all right? So I would like to congratulate all the speakers and for having made the effort to have come this way and given wonderful talks, and also for the audience for their active interaction. And thank you everyone, and also the co-chairpersons and moderators. Thank you very
Thank you,
much. It was a really enjoyable session. I thoroughly enjoyed it.
Thank you very much. For all those who have still not had lunch, please, you're welcome to have lunch.
Thank you so much to all the speakers, chairpersons and the moderators. The next session will be conducted in the main auditorium. And the next session here in this hall will be starting at 4:30 p.m. to take the session ahead.
Yeah. Koi nahi, there should be someone here with me also. So can we have the first speaker, Dr. Arvind Maurya here? Who's there? Where is he? Is he coming? Or we move on to the next speaker? Yes.
AIIMS faculty has to be. Wherever AIIMS, Delhi or AIIMS, either about AIIMS faculty has to be there.
Okay, so we invite Dr. Arvind Maurya for his talk. The topic is target emmetropia, role of optical biometer. Excuse me.
Good afternoon, everyone, and thank you, Tityal sir, for the invitation. So my topic is the target emmetropia and the role of optical biometer in achieving the emmetropia. So in all the closed cases, the second most frequent cause of claims is because of the biometry errors and wrong IOL power calculation, and it results in payment of damages in 62% of the cases. So the advent of optical biometry started in 1990s. It gives a highly accurate, non-invasive automated method for measuring the anatomical details of the eye, and accurate anatomical measurements are critical for precise IOL power calculation. It has many advantages. It measures to the center of macula along the visual axis, thus calculates refractive or optical axial length, unlike ultrasound biometry, which calculates anatomical axial length only. And the visual and the geometric axis, they do not coincide, and the IOL power calculation, optical axial length is very important. The ultrasound biometer measures still ILM, and since average thickness of retina is 200 micron, distance between ILM and photoreceptor layer, the earlier method of IOL power calculation used to add 200 micron to the measured axial length, but the retinal thickness vary from 160 to 400 micron, and optical biometer measures the true axial length from the anterior corneal vertex to the photoreceptors or to the Brooks membrane. So this IOL Master 700 is there, fully uploaded with all the latest IOL calculating formulas, and it provides full length OCT image of the eye, and it performs 2000 scans per second, and it can identify unusual ocular geometry like the crystalline lens tilt or the decentration. And it has a B-scan star pattern, 3-zone keratometry for white-to-white image catch and fixation check, and green image for markerless toric alignment. It provides all parameters for the latest IOL power calculation formula like the lens thickness, central corneal thickness, axial length, anterior chamber depth, white-to-white measurement, keratometry, and reference image for cataract suit markerless. Key features are scan depth of 44 millimeter, scan width of 6 millimeter, fixation check width of 1 millimeter, and resolution in tissue is 22 micron. Biometry fail in 6% of the patient, whereas the JAIS IOL Master 700 with swept source biometry shows a cataract penetration of more than 99%. These are few examples for the more accurate and repeatable measurement. So we can see the foveal pit. So it shows that it's a good fixation. And there is only 10 micron difference in the axial length, and only 0.02 diopter difference in the keratometry. So it helps to identify the errors. Poor fixation because no foveal pit is visible, and there is a 190 micron difference in the axial length, and more than 0.5 diopter difference in the keratometry. And it also helps in the measurement of the effective lens position after the surgery in all type of age group, like the 8-year age, 38 year of age or 63 years of age, because it is universal library compatible, and distance dependent keratometry measures in different zones of the cornea, and it is upgraded with all the IOL calculating formula, most of them. Also it helps in IOL calculating in the vitrectomized eyes. So they have different viscosity, and measured axial length is always more, and previously conversion factor of 0.71 was needed, but now it is no more needed. So it optimizes our workflow. Cataract suit markerless, allowing markerless toric workflow. No preoperative corneal marking is needed, and no additional measurement for the toric alignment. So it matches the reference biometry image with a real-time view from the microscope, and continuously tracks the live image to provide assistance overlays for toric alignment, incisions, and rexes. It records intra-op snapshots and video in SD quality. So in conclusion, we get fewer refractive surprises by using the optical biometer and the OCT image-based biometry for visually verifying measurements and for the detection of unusual eye geometries. It improves our refractive outcomes, it optimizes our workflow, and the higher cataract penetration rate, on-board toric IOL power calculation, easy delegation, measurement speed, and markerless implantation of the toric IOLs. These are my references. Thank you so very much.
Thank you, Dr. Maurya, for nice coverage of the topic. Yes, truly speaking, optical biometers have really, made life better, particularly when you are planning for a premium IOL, wherein we need good accuracy of IOL power. Any comment or any?
No, what is this latest biometers are the swept source based technology? So do you feel this technology is high-end optical biometers? Right?
Yeah, looking at the Indian scenario, not every ophthalmologist afford these are very expensive, around 60-65 lakh. So immersion biometry is a good choice. But when we are going for the premium IOLs, as Dr. Sinha has said, so then we need to provide reach to that level of expectation in those patients.
Yeah, very true. Actually, science is on one side, economics is on the other side, and we have to balance the two, strike a balance. So whatever.
Biometer which is coming out by Alcon, which is still not there in the market, but it's
Argus, basically they claim that the penetration rate is much higher as far as the denser cataracts are concerned. In IOL
the refractive index measurements. So it segments the anterior chamber, then the vitreous and lens. It takes the exact refractive index. So that is another advantage of that.
Okay.
OA2000 is another good option. Like it's also a swept source based OCT machine, which I personally using for last 7 years, and it has amazing penetration. So cost wise, if you see, it's 21-22 lakhs around, and it has all the formulas, Barrett, Roque, and all those formulas integrated in that. So it works wonderful.
Okay.
So means there's markerless toric facilities there in that?
No.
It's not there. Okay.
That is separate.
Yeah.
Okay.
Okay. So now we move on, and our next.
Thank you so very much.
Yeah. Thank you, Dr. Satyajit Sinha will be talking on preventing runaway rexes.
So to begin with, I'd like to congratulate RP Center on its 56th anniversary. And I'd like to thank Professor Jeevan Titial sir for giving me this opportunity. And with the permission of the chair, I would like to speak on preventing runaway rexes. So the theme of this session is a happy patient, 20/20 patient. And the whole crux of the matter, no matter how well you have done your optical biometry or immersion biometry, so on and so forth, you have to have a good rexis to begin with, even before you initiate your phacoemulsification. So I want to show you this video which is there. So every step that you are making the rexis is very important. I, in my day-to-day practice, use a marker which I put on the cornea, which was made by our friend Dr. Ajay Paul, who we recently lost. That helps me in giving me a guide of going around to make a central round rexis. Even when you are making this parasynthesis, it's very important that it should be of adequate length, that the viscoelastic is not leaking. It's very important that you make a proper main incision also, and you will see that I am blocking the side port and making this main incision, and it should be of adequate length, and then we go ahead and fill viscoelastic again and initiate our rexis. Now I'll be using the mark as a guide, and then I start from the center, and you will see that I am using centrifugal force and initiating the rexis from close by from where I am leaving it. So even though I do not have a femto second laser, but still with the guide of the mark that we have made, we can make a central round rexis. Now there are different types of rexis that you can make. One which is manual, which we are making every day, and with time you become perfect with it. The other one is the Zepto, and the third is the femto one, in which if there is a post-traumatic fibrotic anterior capsule, then it's difficult to use a laser on that. And now these days, when we have a posterior capsule rent, we complete it by making a rexis, but the femto laser cannot be used in posterior CCCC. Now there are times when no matter how hard you try, there is very little you can do, and this is the time you should not let your ego come in between. If you are not able to complete and you feel the rexis is running away, it is about time to just go ahead and use a Vannas and complete the capsulotomy part, and then use low parameters to complete your phacoemulsification. Now there are times when you're worried about the rexis running away, especially when you have promised your patient a high-end intraocular lens. Then you are most careful that you want to complete the rexis properly. But this can happen while doing anterior capsulotomy or while doing posterior capsulotomy. We'll not be discussing the one in which about posterior capsulotomy. We'll be talking about only anterior capsulotomy running away. And in this also, there are two things. One can be predictable. In pediatric cataract, if you are not careful, if you don't have enough centrifugal force, the anterior capsule is so tense that it will run away no matter what you do if you are not careful enough. And one is the unpredictable. You just put a nick and the rexis will run off, and the capsule will just tear off to give you an Argentinian flag sign. So the physics behind which is happening is, one, there may be intralenticular, high intralenticular pressure, and the other is the vitreous thrust which is coming from behind. Now there are different situations, one like in hypermature intumescent cataract, there may be raised vitreous thrust, and if you make faulty primary incision, then the viscoelastic is leaking and the anterior chamber keeps becoming shallow, that will also keep affecting the rexis that you are making. There are other situations also in which, now that we do topical phaco, the patient may be uncooperative. There may be poor visibility through corneal opacities, though the retroillumination that we are using, things have become much more easier through the microscope. Other situations like in Marfan syndrome, there may be subluxated lenses in which all the other parameters that you are doing of putting Sione's ring and all the CTRs and all rings that you are putting in subluxated lens, but before that you have to have a proper rexis made. In situations like in pseudoexfoliation syndrome, where there may be zonular dehiscence or dialysis, situations like where there may be small pupil or floppy recurrent prolapsing iris, sometimes it becomes difficult to make the rexis. Also, once you have made it, you can accidentally damage the rexis when you are entering with the parasynthesis knife, when inserting or removing an iris hook or expanders, and by touch of the phaco tip. When you are making a trench, you may go too forward ahead and touch the rexis margin, and then you can hurt your rexis that you have made. It is very important that you keep a high molecular viscoelastic device in your operating room. It is always important to keep a Otrata forceps. Suppose the rhexis is running away, it's easy to pull it with the Otrata forceps. And using Trypan blue is a good idea to stain the anterior capsule. Now, as I said, in fibrotic anterior capsule, these are cases mostly post-traumatic and require a completely individualized CCE for which an additional application of Vanna scissors or comparable instrument is required. Now, I'll show you in this video that other than the normal, I am trying to make a nick in this video, and I am not able to puncture the anterior capsule to even begin the rhexis, no matter how hard I try. And for paucity of time, I'll forward this video a little bit. Then I go ahead and try to use a rhexis forceps, but still I'm not able to find that. So then now I have put so much pressure on the zone. This was how I was able to complete the rhexis, and the central part was so thick that it wouldn't even open up. Now, for beginners, it's a good idea to do under peribulbar block. It helps in softening the eye and helps in easier management of complications. In case of additional vitreous thrust, one should soften the eyeball with mannitol and always use high molecular weight. When there is intumescent cataract, it's a good idea to put a 26-gauge needle and remove the fluid that is there, the milky fluid. As a rule, use Trypan blue. And in hypermature intumescent cataract, initiate and make a small rhexis or enlarge before and after putting the IOL as per convenience. When there is liquefied cortex and an inadvertent extension of rhexis, liquefied cortex is aspirated first before initiating phacoemulsification with lower parameters. Now this is the small rhexis that we have made. And then you have to take extreme care throughout the rest of the procedure. If the rhexis runs away, complete the procedure from the opposite direction, and undue pressure on the posterior capsule is to be avoided. Post-rhexis runaway, hydrodissection is to be carefully performed. Prolapse the nucleus into the anterior chamber, and phaco is done there in between the layers of the viscoelastic, and it's important to coat the endothelium. Some advocate converting to a can opener capsulotomy and doing SICS. Thank you so much for your patient hearing.
Thank you, Dr. Satyajit, for covering up a difficult scenario. Any comment? Any question?
Always what we do actually,
Yeah.
when we are teaching the PGs, we always tell the fellows to give an equal mix in the all four sides so that the pressure over the zonules will be equal when he is converting.
When he is converting.
Not in the case of phaco. Whenever we are doing SICS, converting to SICS, especially grade 4 cataract, rather one place it is runoff means give the equal amount of cuts in the four directions so that the pressure over the zonules will be same. That's what
That's a good suggestion.
One technique that I have been advocating, that is second massage technique. In cases when there is an increased intralenticular pressure, we just suck, that is aspirate from the center.
Means in the intumescent type of cataract, we can do puncture axis, or we can make a smaller axis and then enlarge it.
Yes,
So-
spiraling is one option.
Yeah,
Spiraling can be done. That is one option. And of course, aspirating out, as Dr. Kungar was telling, is a good idea, that you aspirate and reduce the intralenticular pressure. Dr. Harshul wanted to say something.
So, in cases of extension of the rhexis, I think the key is to maintain closed chamber. So, I never believe in converting into SICS. I believe that phaco is the way, and should not take it out in anterior chamber because nucleus is very bulky. It's difficult to chop in anterior chamber. So, do it in bag only, but divide it into smaller pieces. Don't do much of lateral separation. Most of the cases you get away.
Correct. Too much stress on the zonules. So that is why, for my safety and the patient's this thing, I wanted to convert to SICS.
Yeah.
It's no harm keeping our ego outside.
Correct.
Yeah.
Correct.
True, true, true. Absolutely. Yeah. It's what finally the patient has to get a good visual acuity. That's the most important thing. So thank you very much,
Thank you so much.
Dr. Satyajit. And now we move on to our next speaker. We have Dr. Satyamurthy with us, who will be talking about phacoemulsification in a supra-hard cataract.
At the outset, I would like to thank Dr. Rajesh Sinha, Dr. TTL sir, and the entire organizing team for giving me this opportunity to participate in this very important event. Yeah, it just started. Yeah, right. So now we know that black cataract or any super hard cataract is a challenge, and to ensure good vision post-operatively, it will be a little difficult in not in every case probably, but now with the present technology, which is quite good, and we have a lot of good viscoelastic substance to allow the fragments to come easily. You see here, even though it's been well stained, the anterior capsule cannot be seen because of the poor contrast. The next thing is the hydro dissection. It has to be very gentle and sufficient. Why gentle? Because there's hardly any space, and some of the patients with myopia may have thinner posterior capsule, and so it is likely to tear. So we have to make sure that all the adhesions are broken between the capsule and the lens matter. So now the phaco tip that is to be used, it has to be exposed around 1.5 to 1.25 millimeter, so that it can go up to the endonucleus. And this is a basic phaco machine with a 15-degree straight tip. And here the tip, the phaco chopper that we use is a sharp chopper, about 2 millimeters. It's available in all the Indian makers of the instruments. And then here the technique used is the vertical chop. And this patient was a myope. So that's why, to avoid the sudden deepening of the AC, the first irrigation was started under the iris to prevent that the lens iris retropulsion syndrome. And here, see, the first initially the continuous power was used till to chop the nucleus, and the chopper is digged in front of the tip. Aim not to make full separation of the fragments, it may not be possible. Then the lateral separation, the right hand is stable, whereas only the left hand is moving, and tease the fibers till the crack goes up to the posterior plate, which is very, very important, so that all the fragments are separated. Same thing is repeated. Here the fragments have to be little small. Even in high-end phaco machines, one can use the longitudinal power initially to chop and then convert to the torsional power. So once we have made the fragments, then just one after the other we can start emulsifying at the level of pupillary margin. Here pulse mode was used. Why pupillary margin? Because it is equidistant from the endothelium and the posterior capsule. And now we have created a little space, so keep on rotating the nucleus. And then, so go deep, and tease the fibers and separate the fragments, and then emulsify the fragment at the level. So throughout here it's a edited video, that's why you are not seeing the visco being injected, dispersive viscoelastic. Initially soft shell using chondroitin sulfate and then sodium hyaluronate was used to inject. See, we have come to the last fragment. I had to inject visco into the bag so that the posterior capsule is pushed back. It will not come into, because most of the P serines occur at this stage, and then chondroitin up to the endonucleus, and then dig in front of that, and then make this up to the endonucleus, and then dig in front of that, and then make this separation. See, once the initial chop is done, then the rest everything is the same like what we discussed previously. So then once the fragments are made, it will be easier to remove the fragments. And the chamber stability is quite good with all the new phaco machines. So we need not worry about, and there is no microsurge also, the posterior here. So this is another way of doing it, where if it is not possible to directly chop the nucleus, then make a small trench in the center and then rotate the nucleus so that now you can go deeper and then start chopping. Here make sure that again the fragment goes the cleavage goes up to the posterior plate, and then the fragments are separated. This is another way of doing this, where you make a trench like stop and chop, and then once you go reach the sufficient depth, then you can something like the pseudo-exfoliation syndrome, but still we can manage. So the points to be remembered are the rhexis has to be little big, then hydrodissection has to be gentle but sufficient, and then use copious viscoelastic substance, especially this chondroitin sulfate. I prefer viscoat. I have no financial interest in this product. And then use longitudinal phaco for chopping, and then torsional phaco for fragment removal, and then the emulsification of the fragments takes place at the pupillary margin, and always keep rhexis margin in mind. So thank you very much. Once again, I would like to thank RP Center and the entire organizing team for giving me this opportunity. Thank you.
Thank you, Dr. Satyamurthy. That was, those cases were truly super hard. All were black cataracts and, yeah, Dr. Kudlu.
Sir, actually what I do, he has shown that black cataract. I make 6 or 7 minor chops. Then I go and eat the center part, that egg I take out. I think most of us been doing this. There is also one more method. Of course,
Correct.
when you are doing like, first chop with the sharper chopper. Then I change my chopper to something little bit sharp only, not that too long. Then I eat the center leg. Then you can keep eating the remaining pieces. That is the one.
Correct. Very true.
Yeah, another way is to debulk the central part initially only. Create a crater. Create a crater. So once you create a crater, then crater and chop technique that was described by...
The two horizontal chop, I think, will have less stress on the jonules than the vertical
No, that's
chop.
right. Sir, actually, when the lateral separation, except for the first initial chop, move on.
We can just debulk it altogether.
True. Okay.
If you have access to specular microscopy, you should always get specular microscopy done.
True.
Remaining fragments you can keep on teasing, and then only the pies are created. That's it. Total separation may not be possible in the beginning itself.
The precaution he has taken of a larger rhexis, that also helps you in...
move on to our next talk, and that is by Dr. Krishna Prasad Kudlu. And no. And he'll be talking about mix and match IOLs.
Thanks, Rajesh Bhai, and I thank Professor Tityal and my friend Manpreet for this opportunity. Don't have any financial disclosure for this particular talk. So, as we all know that a natural crystalline lens has got a good accommodation, clear vision at all distance, with a greater contrast sensitivity, with a minimal aberration and no rotational asymmetry. My question to all, can an intraocular lens can do the same job as the natural lens? It's a question. So coming to the multifocal intraocular lens, we have been practicing this for a long period. It has got a gradual diffractive step on the IOL implant to create a smooth transitional between the focal point. Normally you will have a very good visual acuity with a moderately good contrast sensitivity at all distance. But now the lifestyle of the every patient has been changed, and there were the introduction of trifocals, intraocular lens, and also later EDOF lenses. So considering for mix and match IOLs, always patients should always have a strong desire to be the spectacle independence. So always we should take a proper history, and we should also ask about the hobbies like painting or playing cards, or whether the patient is just unusual avid readers. So coming to the, for all these patients, even a short-term glare and halos also will be intolerable. So sometimes when you think about this, always monofocal will be the best option. But if you implant a monofocal intraocular lens, those are very good drivers. Always they have a difficulty in viewing the panel screen on the meters. So this is the consideration. This is a portfolio like one eye multifocal and other eye EDOF. We have been practicing this. So this is my initial study where there was the lenses with the rings only, with both the platform, both multifocal and EDOFs were present. But these are the diffractive lenses from the Zeiss I tried on. Basically these lenses, both multifocal and EDOF lens, they are 909 model. Now they discontinued. It's a toric multifocal. So we used to get a very good result with this patient. So I never had access to Callisto in my early part of my practice. So we used to mark the eye with the marker. Then we used to, after the implantation, we used to rotate during the wherever there is the marking is present. So this is about the contrast sensitivity. Coming to the EDOF lens, basically EDOF lens is an excellent compromise between the benefits of both monofocals and multifocal intraocular lens. Especially more spectacle independence compared to the monofocal intraocular lens with the very fewer side effects compared to the multifocal lens. So if we inject a EDOF lens, normally we tell the patient that they may have to wear glasses for a very fine print. So this is basically, this EDOF lens is a perfect balance between the spectacle independence and the less visual side effect. This is what the EDOF lens initial of Zeiss, that is from the AT Lara. They made something called SMP technology that reduces the glare and halos. These are the few advantages with these lenses. I used more than 100 lenses. Basically less sensitivity for decentration and tilt, and also because of its neutral asphericity design, which does not interfere with the corneal higher order aberration, which is suitable for the post-LASIK patient. So these are the advantages with these lenses. So this is the first lens I implanted in India when I just started. It's quite similar to any of the multifocal lens. Nothing much important about the phaco, I think, as usual. So normally these lenses, normally it comes in something called preloaded blue mix injector that makes our job much easier. So in the end, I want to highlight about the 1 or 2 points about the neural adaptation, that the process that takes place as the brain adapts to changes in the visual information being supplied by the eye's optical system. So I want to tell, visual symptoms are not related to the aberration, they are related to the neural adaptation. The success of a patient outcomes continues to improve because of they have adapted to the aberration. This is what we did. So this is our experience. So what we did, see, all my cataract patient, I do a lot of laser refractive surgery, presbyopic treatment. So I myself check for the dominant eye. Once you are through with perfect with the dominant eye, then normally what I did in first 50 patients, for dominant eye I put a EDOF lens and non-dominant eye put a multifocal. Then this is my inference. More than 90% of the patient at a very good distance and intermediate vision in the dominant eye. Non-dominant eye gives a added benefit of near vision and no glare halos, even comfortable night driving. We had called the patient for 1 week, 1 month, or 6 months follow-up. All patients are extremely happy. So these are the results. Normally 90% of the patient for a distance EDOF lens gives a very good excellent distance and intermediate vision. Adding multifocal to the non-dominant eye gives a very good near addition. So patient will have a very good vision. These are the couple of trials we did with this particular lens. One is from the one Italian company, Minivel and Minivel Proxo. So we put a Minivel in the dominant eye and Minivel Proxo in the non-dominant eye. It's a combination of EDOF and trifocal, and which gives a very good results, no glare and halos. I think further more results has to be, we are doing some of the trials with this particular lens, more trials required for these results. So we are even trying now, okay, the lot of options are coming with the refractive lenses. We just tried with one of the lens from Rayner, the brand name is called EME lens, and no financial interest. We put in the dominant eye EME, and non-dominant we were corrected by 0.5 diopters. So patient had never zero glare and halos, very good near vision, very good contrast sensitivity remained. I think further studies has to be required. This is one more option we started doing. One eye we started putting AIIMS lens from the Johnson & Johnson, and the other eye we started putting the Synergy in the non-dominant eye. We did it on 4 or 5 patients and the results are pretty good. So in the end, I just wanted to tell that if you implant a dominant eye with a lens without rings and non-dominant eye with the rings also, the amount of glare and halos will be much lesser and gives the patient very good happy. So with this, I want to conclude my talk. With all these patients had a very good far and near vision, good visual acuity at distance, 33 centimeter, greater extended depth up to 5 diopters, very good quality of vision and light condition. Once again, I thank Titiyal sir and the whole RP Center people for my opportunity. Thank you, one and all.
Thank you, Dr. Kudlu, for an excellent presentation and highlighting the role of mixing and matching, and that is something which a lot of people are doing.
Even I did for my mother almost 8 years before. I operated my mother around 14 years before. I used to ask her. She used to tell, you did a good job, I can see very well for distance, but near I cannot see. Then the non-dominant eye, I put her the multifocal lens. No glare and halos, she is very, very happy with near vision and with the distance vision also. Similar concept I started doing with what we did do for Press Beyond. Similar concept I am doing on the IOL platform, getting the similar results.
Okay. Okay, that's something.
Of course, we do all other tests like abrometry. We need to look for angle alpha, angle kappa, and all other factors also. We do every investigation before we take up such kind of cases.
Yeah, but I don't know for a dominant eye when you're using a say AIIMS lens, how much angle alpha has a role in that.
No role only.
But yeah, in a trifocal lens, yes, it does have a role.
Yeah.
Particularly when you have those ringed lenses, wherein the central ring should be at least smaller than the.
So initially I used to put
bigger than the.
Initially I used to put a EDOF lens from the Zeiss. That is AT Lara has got rings, lesser rings. In that cases it was very important me to do angle alpha.
Yeah, but the initial lenses had a very small central ring. Wherein the size of the ring was 0.6, 0.7, 0.8 or so. Now these days we have larger sized central ring. So a little bit of angle alpha, like earlier 0.3, 0.4 was required. Even 0.5, 0.6 will do if some lens has a central ring of 1.4 or 1.3. So that is the slight change. Yeah. So that is why a little bit of extra leverage we have attained in terms of angle alpha. Any comment?
Just a thought.
Sort of a butterfly model. Probably that whenever the movement of the eye for when he's seeing for distance and near, I think it may move within the bag. That might be the reason behind this.
I did in one patient minival in one eye and proxa in other eye. Patient had severe photic glare. Means I had to exchange that lens after 1.5 months. Patient was so furious, so annoyed, so unhappy.
Okay.
So photic glare was too much. I got eye trace done. There was a whole lot of internal aberrations which are coming from this lens.
Okay.
So to be careful.
Yeah.
But the
True.
good thing
True.
was that it's a hydrophilic, so after 1.5 months also
Easy to
you could
remove.
exchange.
Yeah.
If it's a hydrophobic platform, it becomes difficult.
Okay, meanwhile I will request Dr. Khunga to come up and
Thank you,
start
Rajesh.
his presentation. Dr. Nupur, you were telling something.
Yeah, I just wanted to ask what is the rationale behind putting an AIIMS in the dominant eye and putting a trifocal in the non-dominant?
Basically
Basically distance dominance he wants and without any risk of
Maybe
glare
both eyes
and photic
trifocal would be a
phenomena.
better option.
No, there is a best option. No? There are some patient, a very sensitive patient. No,
His
like
idea
little
is that
bit.
dominant eye will be more sensitive also, so sensitive to.
चल नहीं रहा है? Okay. So I have no financial interest. So next 7 minutes I'll be basically navigating you through 3 parts. What are the potential causes of post-operative surprises, mainly astigmatic? Prevention, how to prevent these, and how to fix the poor outcomes if we have them. So coming to potential causes of error and prevention, as prevention is better than cure. Tear film we have to check in all the patients, tear breakup time in all patients and stable reproducible results to the patients, tear breakup time in all patients and stable reproducible results on repeated measurements. Importance of measurements in premium IOLs, with toric IOLs and multifocals, 2 optoms to independently do the examination and measurements and get them checked by the operating surgeon. And then importance of patient positioning and importance of correct alignment. So this is how on IOL Master 700 the patient, one of the assistant holds the head. The head has to be straight aligned. So coming to total K, we all know that in case posterior corneal astigmatism, contribution of posterior corneal astigmatism to total corneal astigmatism. So this I have already told in the previous slide. Another error that occurs is because which toric IOL type T3, T4 we are using in high myopes and hyopropes. Because it is the effective lens position is different in these eyes. So average eye, the IOL plane by corneal plane we take as 1.45. Whereas in highly hyperopic eyes it is actually 1.2:1. And in very myopic it goes up to 1.75:1. Thus we have variable ratios with different IOL powers and axial length. So the prevention is we should use Barrett toric calculator here. There's another paper on influence of axial length and corneal power on the estimating power of toric intraocular lenses. So customizing this ratio according to AC depth is very important. The surgical mistakes that we make are inadequate visco removal from behind the lens and overinflated chamber. So this is something which will rotate the IOL in the early post-op period. And second is failure to take into account the impact of surgically induced astigmatism, if there is any, with the particular surgeon. So we all know that for every 1 degree of error in a toric IOL's rotational alignment, there is a 3.3% decrease in correction of astigmatism. And if a toric IOL is misaligned by 10 degrees, that is a 33% loss of toric correction. So if a toric IOL is misaligned by 30 degrees, it is as though you have put a spherical IOL. So it is important to understand the reasons for the residual astigmatism before trying to correct it. So this is a small video how the bubble marking is done, as everyone cannot afford to buy a Callisto and Varion. So the bubble marker, you have to see when you keep it horizontal, the bubble has to be in the center, the 3 parts that we have. And then coming to the marking, we have to keep 0, 180 and 90, all 3 at the marks. And then we put the final axis with the marker. This is a slightly old video. So once this marking is done, so we slightly under-align the IOL and then we remove the visco. Here you see the removing the visco is very important. So now removing the visco from the back is again very important, because posteriorly if the visco is left, so my choice here is that I use a manual Simcoe cannula because it is much more controlled and the IOL does not tilt forward and it does not rotate. So once that is done, we do the final alignment and then we inflate the chamber. The chamber is formed in such a way that it is not overinflated, as I said. So once the chamber is formed, we check with the swab stick and that it is not overinflated. So once there is a post-operative surprise, we have to evaluate it on the, basically slit lamp evaluation is a must. There has been a significant rotation. If we notice that, go in and rotate it into the correct orientation. But first confirm that a second surgery is justified by the potential visual gain and control of astigmatism is achievable by rotating the lens. So we aim is to get the patient's astigmatism down to below 0.5 diopters. This can be done by ascrs.org online tools or directly go to www.astigmatismfix.com. So this is the data entry part. This is the Bidhart and Hadent toric IOL calculator. So once you get the result, the blue is the original axis and the red is the desired axis. And now we have to rotate it early within first 2 weeks. But we have to see that the patient, if a patient needs a different refractive power, the surgeon should act promptly before fibrotic healing can interfere with the procedure. But we should not do before 2 weeks to be sure that the eye's refraction has settled down after surgery. So this is the variant system. Here we are rotating the IOL to the desired axis, and once we have achieved that, I think that should give us good results. So other options that we have are excimer laser ablation, PRK we should prefer, incisional treatments, LRIs, and last is IOL exchange. And if patient is not ready for second surgery, then glasses or contacts. Just briefly 3 scenarios. We have a post-op axis different from the initial axis of implantation. Here we do the rotation again. Then there is an error of -2D sphere, -1.5 cylinder. We can go ahead with the corneal refractive procedure. And if there is an error of +3 diopter sphere, +2D cylinder.
The end was really very useful. Any comment? Meanwhile, I will request Dr. Gopal Raju to connect his laptop.
think we'll
Pranam,
proceed.
anything you would like to say?
Okay, first of all, I'd like to thank RP Center team headed by the Professor Titial sir for inviting us and giving the opportunity. We're all discussing a lot of options for every procedure. Everyone is contributing their own style of functioning. I think this talk will clear you all those things.
Nice topic. Improvisation is the key to stay as a surgeon. So that's a nice topic. Yeah. And very rightly placed in the end of the session as the last talk.
No. See, surgical training, so every resident or whenever there is whenever joins the surgical branch will get the doubt. If every individual can be trained their hands and to become a master. See, even if you are an amateur or a professional, if one human can do it, I think others can definitely do it. So with that conviction and confidence, I think everyone can train their hands. If you divide the human surgical life and then the surgical procedure life, you just divide into a human surgical life and then the procedure life. For example, any procedure life, like the life of ICC, it was 30 years or 15 years, 20 years, like FACO already 30 years. So like that, the life of a procedure or any surgeon's life, generally it is around 30 to 35 years. That's a professional life, active life. So first let us see the surgical procedure life. For example, if you see the pterygium, Bayer sclera ruled about 10 years, then with mitomycin 10 years, then autograph replaced it. Now it's almost past another 10-15 years. But we don't know how long life of a surgeon. So, and the knowledge doubling time, earlier it used to be a lifetime, but now the knowledge doubling time has grossly reduced, has almost halved and even less. Coming to the surgeon's journey or the surgeon's life, every surgeon will have an active surgical life. 30 years is in general. You can't do the same technique, but in that 30 years to survive, you need to improve constantly by improvisation. This by self-improvisations or adopting others' improvisations like these discussions, then activate your feedback channel. That is the most important thing. Accept and try and then accept the change. And there will always a scope for improvement, even if you feel you are the best surgeon. If you compare both the surgeons versus a procedure life from the PG to professional life, compare the technique learned during the post-graduation training versus the 20 years of your practice. Like for example, I have learned only ICC, ECC during PG, but the procedures whatever we are doing now is completely learned after I left the training. Like learning PKP at that time during the residency, and then now you have to force it to learn lets us perceive the location, moment, action of parts of the body. It encompasses the complex sensations including the perception of the joint position, movements. See, if you see how we perform a FACO, our hands basically perform even if you are thinking the sensory and the motor actions, and hand-eye, if you translate into a surgery, it's basically an hand-eye coordination. And with this to happen, practice is the only mantra to improve on this. For amateurs, there is a process. Please, I will advise, there are no residents here. You should be motivated and then follow certain process to master the procedure. And already professionals who are trained surgeons, one needs to improve constantly to survive. First, you have to challenge yourself and then share the knowledge and then observe the other different ways of doing, practice and analyze, stick to whatever is best on your hands, be open for the criticism and the change. See few examples like what we have seen in the challenging cases of the Sachidin sir has shown how the capsular excess can be managed. Similarly, how we use different pupil expanders, iris hooks, to tackle the eye face and other things. short of the time, I'll change the then. To summarize, so improvisation, all of us can become a good surgeons. Practice is the only mantra. Improvisation is the key to become the master. Use proprioception to your advantage. Learn different ways of doing a procedure, but finally what works best on your hand, you should continue to practice and then improve on this. Thank you, Rajesh.
Thank you, Dr. Gopal Raju, and nobody can disagree with what you have told. It's all true. As we are, you know.
Do we have our first speaker, Dr. Kirti Singh? Do we have Dr. Shalini Mohan? I would like to welcome our moderator, Dr. Devang Angmo. I would request her to kindly take the session ahead. Thank you. I would request everybody in the back to kindly settle down. We are about to begin with the next session. I would request everybody to please settle down.
So I think first I would like to call upon Dr. Shalini Mohan. Ma'am, if you are ready. Yeah, so in the meanwhile, I would request people at the back to please come in the front because we have only limited audience. Yeah, that's what, 1-to-1. So, Dr. Shalini Mohan is basically professor, she is a RPC alumni, she is professor in GSVM Medical College, and she would be speaking on MIGS, when and how. Ma'am, over to you.
Yeah. Thank you so much, Dr. Devang. And good evening, everyone, chair and all the delegates in the post-lunch session. So I will be talking about microinvasive glaucoma surgery, when and how. I don't have any financial interest. So as per definition of, from American Glaucoma Society and US FDA, MIGS is implantation of a surgical device, removal of tissue, especially trabecular meshwork, intended to lower intraocular pressure via an outflow mechanism with either an ab interno or ab externo approach, which is associated with very little or no scleral dissection, filtering blebs, and no issues of wound modulation. Moreover, it causes reduction in intraocular pressure, which is around 20%, but definitely it is lesser than trabeculectomy surgery. And the safety profile is better than trabeculectomy surgery. So what are the indications? Mild to moderate primary open-angle glaucoma, pigmentary glaucoma, and pseudo-exfoliation glaucoma, where we can visualize the anterior chamber angle and the pigmented part of trabecular meshwork nicely. So the contraindications are primary or secondary angle closure glaucoma, eyes with any sort of neovascularization, hazy cornea, or angle dysgenesis, and the patients with raised episcleral venous pressures like Sturge-Weber syndrome, and patients of advanced glaucoma. So if we can classify the MIGS, basically it is of 4 types. The first one, which bypasses the trabecular meshwork and drains directly into the Schlemm's canal, which I will be talking. Enhancing uvascleral outflow through suprachoroidal space, which is the CYPAS. Or shunting aqueous into the subconjunctival space, which is the GEN, or decreasing aqueous production by ablation of ciliary process. So when we talk about bypassing the trabecular meshwork, that is getting the aqueous humor directly into the Schlemm's canal, basically it is of 2 types. Either we can place a stent, which can be an eye stent inject or hydrous, or tissue excision, like Kahuk dual blade, which I will be talking, trabectome, GAT, ELT, and ab interno canaloplasty. So Kahuk dual blade, which has come up, which actually came in 2015 and is an ab interno approach via gonioscopic visualization. It is a stainless steel blade where there is a sharp tip at the, here you can see the sharp tip, and designed with the taper for smooth entry through trabecular meshwork. The heel, it fits very nicely within the Schlemm's canal for the smooth advancement, and the ramp, here we can see the ramp that actually stretches the blade nicely and creates a parallel and smooth incision of trabecular meshwork. Like in this photograph, we can see it fits in very nicely and creates a smooth entry, and therefore the surrounding tissue damage is negligible, and therefore in future the chances of fibrosis becomes lesser. So what are the prerequisites? We need a very cooperative patient with good neck mobility. There should not be any head tremors. It should be a cooperative patient, and angle should have been visualized in the clinic itself. Regarding surgeon's preparation, he should be well versed with intraoperative gonioscopy, and you should be knowing your landmarks pretty well. Now, whenever you are planning a surgery of a KBD, what you need to do, you need to modify the orientation of the microscope. Now, you need to tilt the head of the patient 30 to 40 degrees towards nasally, and you need to tilt the microscope towards yours from the temporal incision, particular strip from there, and you need to peel it off so that it opens up nicely. So the efficacy, if we talk about, there are so many studies, and recently a 3-year follow-up study has also been published, and they say that 58 to 70% of patients have achieved IOP by at least less than 20%. It has shown to have better results as compared to trabectome and eye stent in some of the studies, and particular success has been found in pseudoexfoliation and pigmentary glaucoma. Certain people are also using in congenital glaucoma, but I myself don't have any experience in that sense. Another procedure which has been come as a modification of this, which is bent ab interno needle goniectomy, where here what is happening, that 25 gauge needle is being taken and it is modified by bending it just opposite to what we make for capsulotomy. So it is almost 90 degree, and similarly you visualize the anterior chamber angle, and then you again strip the pigmented part of the trabecular meshwork. Now whenever you are doing this, it is although a cheaper option, but then the cutting which you are doing is irregular, so chances of fibrosis in long term is more with bang procedure. There are reports of immediate drop in intraocular pressure. So once you go one side and then rotate it to go to the other side. So we did it 19 patients in our case, where mean IOP reduction was from 17 to 13. Reduction in anti-glaucoma medications were from average of 2 to 1, and more than 20% of IOP reduction was achieved in 73% of patients, although we have a short follow-up of 6 months only. We had the most common complication as hyphema, which is generally self-resolving. So the question is this really a perfect surgery? Because we are excising the trabecular meshwork Schlemm's canal complex, and we are directly allowing the aqueous to go into the Schlemm's canal along with the inflammatory debris, and we are actually avoiding the straining part of the trabecular meshwork. So is it really a ideal surgery? Scarring has been reported in follow-up period, but the best part is at least we are destroying only 1/4 of the trabecular meshwork. Rest 3/4 is already preserved for anti-glaucoma medications to act upon. So to summarize, I would say these new category of procedures, they have acceptable safety profiles and humble efficacy also, but they are unlikely to replace traditional incisional glaucoma surgeries, but then they fill an important void between medical therapy and surgical therapy for mild to moderate glaucoma, and can lower the medication burden from the patients. The horizons are expanding, but we need more studies and with larger group and with larger follow-up. Thank you so much for your kind attention.
Thank you, ma'am, for the wonderful presentation. So, ma'am, just a small question like KDB versus bang, what is your personal,
So intraocular pressure reduction is in both the things, but the thing is that because the excision of the trabecular meshwork is irregular, the chances of fibrosis is more with bang. And what we found was that in patients of bang, the IOP reduction was lesser than with KBD. But then it is a cost
practice.
Covering a topic which is right now my favorite topic because it's called as gaps in glaucoma practice. Are we still missing the boat? We all know statistics, the ignominious statistics of India being home to 20% of the world's blindness. We also know the statistics that 70% of the blindness is preventable, 6% only is caused by glaucoma. But we do know the irreversible blindness and the quantum of glaucoma. The best of plans, the best of surgeries go for a toss if you don't do a gap analysis, and the gap analysis will involve the patient toss. If you don't do a gap analysis, and the gap analysis will involve the patient and the doctor. So we did exactly that. Data analysis from the clinic from 2017 to 19, around 1,700 patients, mixed ethnicity with primary angle glaucoma predominating, open angle glaucoma and angle closure were pretty similar. One-fourth of the patients required filtering surgery or lasers when they came to us, usually the former. 14% were blind in one eye at presentation, which is PL negative. Of all the blind person, PACG comprised a chunk of 46%. Only 20% of these ACG patients had had a prior peripheral iodectomy. 80% were undiagnosed. Most of the PIs were done in our hospital. In the OAG, only 31% were on anti-glaucoma medications. So gonioscopy emerged as a major gap in diagnosing and therefore timely treatment. Second is the patient health-seeking behavior. We did a study of referral practices of doctor and the patient behavior in 500 patients. 43% of our patients lack any formal education. Being a government hospital, that is a scenario. Again, PACG and PAG were almost similar. 48% had severe visual field defect, legal blindness in 37%. It was up from 15% previously. Despite most of them being the residents of Delhi, 73% traveled for 10 to 30 kilometers just for drug refills every month. Delay in seeking treatment of more than 6 months was seen despite a qualified ophthalmologist being the referring physician in 92% and 28% having had a prior cataract surgery. The criteria for referral, as obvious, were high. IOP, dissuspect. Gonioscopy was a mere 5%. Gonio was neither performed nor documented in 80%. When the students of ours who referred to glaucoma clinic, their referral practices were pretty synchronous with the glaucoma fellows. So this was the statistics of us. We do remember the Chennai glaucoma study in 2006, where PSCG was misdiagnosed or treated as OAG in 40%. Remember the Venkatraman study from Coimbatore very recently, 2020, where gonioscopy was missed in 95%. Prabhu's study from 2013, where the glaucoma awareness was pretty abysmal, and so was Maharana's study from Bhopal, where again the awareness of glaucoma was pretty poor. And surprisingly, we found the study from Verma et al., who said undetected lack of angle status information was seen in 74% of patients in Canada, the developed country. So the gap was that glaucoma awareness was very poor. Knowledge, awareness is not enough. Knowledge is even less. Only 8% understood irreversible nature of disease. 5% felt that IOL could reverse the blindness, and the no perceived benefit, difficulty in putting the medications, hand-eye coordination problems, cost, and the need for lifelong medications was perceived as a problem for the patients. This last study was on 200 diagnosed adult cases on more than 6 months of AGMs. Only 39% had an income source. Again, 20% had one eye glaucoma blind. Dependency on the hospital supply was seen in 60%. And this poor adherence again was highlighted because of forgetfulness, fatigue, side effects. 65% were unaware of the continual asymptomatic nature. 50% only understood gravity of missing medications. 53% still felt, hoping against hope that once I start putting medications, it will restore eyesight. When it didn't, they just stopped it. And they mostly they felt that we should tell them how to put the drugs. Almost half said we would prefer surgery because we cannot put the drugs and the dependency on escort. Same aspect were highlighted in the GAP study actually. So the gap was between actually current state to the desired state is still huge. Education is required, not only glaucoma walks, we require to talk to our patients, we require to tell our patients how to put the medication. Surgical option has to be exercised early frequently because forgetfulness, dependency in this elderly cohort is a problem. We do that counseling. This was a patient who came to us with just one spectacle and he said, I don't need so much of vision, because he realized that he couldn't have much vision. Gonioscopy has emerged as a critical element way back from 2006 from Chennai glaucoma study to 2022 recent study, and we do in GNEC the GAP workshops, gonioscopy and perimetry workshop. Last week we just completed the second one. We've trained more than 30 people, and please remember we are all surgeons. We should do a trabeculectomy and a PI in time so that legal blindness doesn't occur. Thank you, so that you don't miss the boat.
And he would be speaking on modification of perioperative anti-glaucoma medications.
Center that made me. I thank TTL sir for giving me this opportunity. So when we are discussing modification of glaucoma medications perioperatively in cataract surgery, these are the scenarios to be considered: lens-induced glaucoma, postoperative glaucoma, ocular hypertension, pseudoexfoliation, glaucoma patients on well-controlled on anti-glaucoma medications, non-glaucoma conditions like crowded anterior chamber, hard cataract, poor endothelial status. Lens-induced glaucoma obviously has to undergo cataract surgery, but till that time the patient is taken up for cataract surgery. The IOP is to be controlled maximum with maximum medical therapy. In this, probably prostaglandin analogs should be avoided because you don't give enough time for the prostaglandin analog to act, and it can induce inflammation also. Same with postoperative glaucoma. Hazardous inhibitors in cataract surgery. You have carbonic anhydrase 2 isoenzyme present on the corneal endothelium. So does carbonic anhydrase inhibitor act on it and cause endothelial problems? But in the study by Tadashi et al., it has been shown that carbonic anhydrase facilitates ion transport impacting corneal endothelial function in bovine eyes, but not in corneal endothelium. So carbonic anhydrase inhibitors can be safely used in perioperatively in cataract surgery. Now you have these conditions where you have other endothelial status, or you expect a lot of endothelial loss during cataract surgery. The anti-glaucoma medication ROCK inhibitor, Rapazidol, has been shown to have an endothelial protective effect in the study by Fujimoto et al. What they did was they had two groups. One group received Rapazidol postoperatively, the other didn't, and it was seen that the group that received Rapazidol had a lesser increase in the corneal thickness postoperatively, and it is suggested that in these conditions where you have a problem with corneal endothelium or expect a problem with corneal endothelium, it might be advisable to use ROCK inhibitors postoperatively in these cases. But the problem with ROCK inhibitors is that it can cause corneal honeycombing. But the good thing about honeycombing is that it doesn't affect the vision, and it disappears once you withdraw it. So it can be safely used. Now, anti-glaucoma medication, IV mannitol, I do use it, and it is good to use it in eyes with a crowded anterior chamber, because it not only 100 ml of 20% mannitol given half an hour or 1 hour before cataract surgery effectively lowers the intraocular pressure and increases the anterior chamber depth, making the cataract surgery safer in these cases. Now, what is the effect of cataract surgery on cystoid macular edema and intraocular pressure? So this study by Lee et al. Has shown that the incidence of CME is significantly greater in patients with primary open-angle glaucoma undergoing cataract surgery, especially in those who are on prostaglandin analogs. And so what happens? Like during cataract surgery, there is prostaglandin release, and it leaks through the vitreous and breaks the blood-retinal barrier and cause a leak. But can this prostaglandin analogs per se cause this leak? No, the study has shown that it doesn't cause, have shown that prostaglandin analogs can play a role in the development of pseudophakic cystoid macular edema. So should we stop prostaglandin analogs for cataract surgery? See, I mean, almost all are very good phacosurgeons, and there's no much inflammation happening, no huge release of prostaglandins. So carbonic anhydrase inhibitors, they act within a week, but it's too weak to replace prostaglandin analog. All others take about which should be made 1 month before cataract surgery. So if you replace it with brimonidine, you have the issue of allergy. You want a quiet eye postoperatively. So do we use it? And timolol, obviously you have the systemic complications and all. And another thing to be considered is, see, how long does the effect of prostaglandin analog last once you stop it? So the effect lasts for about 4 weeks. So based on that, it should be stopped 1 month before cataract surgery. But it is just the IOP lowering effect of prostaglandin analogs that is there. So it is the act of prostaglandin analogs causing the remodeling that occurs in the cellular muscles that causes the intraocular pressure lowering effect that is lasting. It doesn't say that prostaglandin analogs are cystoid macular edema in these cases, and it might be better to stop if possible. So should we stop prostaglandin analogs? Yes, if your ocular pressure by about 4 millimeter and the effect lasts for years. So the strongest predictor for this drop is a higher preoperative intraocular pressure. And so should we change it postoperatively? The studies have shown that there is a possibility of reducing the number of anti-glaucoma medications postoperatively after cataract surgery. So should we reduce them? Yes, but the decision should be based on the level of postoperative IOP and degree of optic nerve head damage and NFL loss. So to conclude, the perioperative IOP control is of critical importance for the best visual results. Though IOP may drop post-cataract surgery, one should reduce anti-glaucoma medications postoperatively only after proper evaluation. Topical prostaglandin analogs stop if there is a high risk of cystoid macular edema. Otherwise, you have to titrate. ROCK inhibitors may be used for endothelial protection. Topical carbonic anhydrase may be safely used. Again, welcome you all to AOC Kochi. Me and Gopal both are there. For anything, please contact us.
Please contact them.
Thank you.
Okay, thank you, Dr. Srini, for the nice talk. So just to wrap up from the house, I would like to ask how many of you stop prostaglandin, and what is the duration? Like, do you stop it a week before, 4 weeks before, or just a way before surgery?
Or do you stop at all?
Don't stop, the last option. So which one? No, first I would like, how many of you stop, don't stop? You don't stop, you continue. You continue post-stop.
But
So you continue till the patients are already using it. Yeah, so, but post-op we stop it.
But what is the regimen? What is the regimen that people are using for post-op? Do you
Everybody's
continue
stopping.
as it is, or
No, everybody's
the entire
stopping.
gamut of medications? Like the patient is on 5 medications, so you do continue from the first day post-op the 5 medications?
Obviously, yes.
Yeah.
You do combined. That's
Yes.
right.
So even for angle closure, even if we're not doing combined, we just do cataract extraction and then start one by one. Maybe on the day of surgery we give Diamox so that to prevent IOP spike.
Shikha,
you're getting
If it is
confused.
5 medications, which means the damage is pretty advanced.
yes.
So just the lens
Next,
removal,
yeah.
learn to control it.
So I would
you
like to
do a
call upon
combined
the next speaker, Dr. Gopal. In the meanwhile, please come on the dais and okay, so sure.
Yeah, so because most of us, as we said in our patients, we have lot of ACGs. So those ones which we have a high lens vault, we anyway go for a phaco. Having said that, only phaco for those with moderate damage. If it is advanced damage, I would not trust phaco unless, which is a very rare scenario, pressure is in the mid-teens with 2 drugs, then we may consider. Most of them do not fall in that category, so we do a combined surgery. For those with 2 drugs with a high lens vault means more than 0.8 to 0.9, we'll just try for phaco alone, lens extraction alone, and see how it works. But we do stop the PGs 2 weeks prior.
2004, why is the slide not moving?
So can you roll the slides, please? Already we are late.
It went to God's own country.
Yeah, so IOP changes after vitrectomy, all right? So we all know about, IOP, how it changes, and post-transconjunctival vitrectomy, we are basically looking at what happens. So you can have gas, oil, buckle, or even vitrectomy itself can actually cause a problem. So first thing what we did was, in 635 patients who underwent 23 or 25 gauge transconjunctival vitrectomy, we looked at day 1, day 7, 1 month, 3 months and 6 months, and 1 day and 1 month following silicone oil removal, what happens. And we found that we defined ocular hypertension as more than 21, and 24% had, that's 154 out of 635 had these problems. And age less than 50, and male sex, and retinal detachment and silicone oil were associated with higher IOP rise. So these were the, male sex, age less than 50, retinal detachment, and oil. These had higher IOP rise. So the mechanism involved were, open angle mechanisms. This is from the literature. Open angle mechanisms or closed angle mechanisms, some ciliary body edema, some other mechanisms, pre-existing glaucoma, etc. So we need to exercise some caution. In early stages, like if there is a silicone oil overfill, you can have a push mechanism causing a pupillary block, an intraocular gas expansion, which cause an acute IOP rise, again pupillary, especially in pseudophakic or aphakics, inflammatory, significant inflammation, trabeculitis, the different mechanisms of pupillary block, malignant glaucoma, and a mixed pre-existing glaucoma. Late, sometimes you can have collapse of the angle, infiltration of the angle with silicone oil, or silicone oil-induced pupillary blocks, as I said earlier, and recurrence of bleed when the posterior pressure increases, or even a suprachoroidal bleed, which is late, steroid-induced, pre-existing glaucoma, and sometimes in failed cases, neovascular glaucoma can come in again. So we need regular IOP checks and slit lamp examinations, UBM, optic disc exam. Field examinations may be difficult post-vitrectomy because there will be a lot of retinal pathologies as well. Now, intraocular gases, usually you should avoid in people who are doing air travel, high altitude, supine posture, underwater scuba diving, etc., and GA, etc. So here, gas expansion is the most common mechanism which causes it, and pupillary block will occur because of that. You can understand that C3F8 increases by about 3 to 4 times in the first 24 to 48 hours, and it can cause a lot of problem. Now, the volume of the gas and the purity of the gas that you are including, the concentration of the gas actually makes a problem. So face down will make the gas go away into the retina, and equisuppressants in YAG-PI and avoid precipitating factors can be done. So I would move on to silicone oil secondary OHT. It's about 2.2% in 6 months, which increases to 56% in 8 months. So between 6 months to 8 months, there is a significant increase in the emulsification of silicone oil, which causes this. So we have, I again did a study, a prospective study, which looked at what would happen in silicone oil. And we looked at, preoperative IOP of less than 21 is predefined as normal. Secondary ocular hypertension was defined as more than 21. This is at about 50 patients. We looked at day 7, day 30, and day 90. We found that day 30, there is a maximum excursion of the increase in, so 5.5 pressure increase. So again, age less than 50, indication for surgery including RRD, diabetic with PDR, lens status in pseudophakic patients, and even the duration of surgery was less, which I could not explain. These were some of the reasons why, in which the pressures were raised in less than 30, in the first week. By 30 days, these were the two things which are significant: indication for surgery for retinal detachment and lesser duration of surgery. By day 90, if the preoperative IOP was less than 15, it was more favorable as compared to more than 16 to 20 or more than 20. And pre-existing glaucoma, obviously we know that it is a problem. And silicone oil emulsification, if there is there, definitely the IOPs were higher. Now, these are the comparisons of with similar studies. Ours was a prospective study, all the others was a retrospective study. And ours had about 47%, and 21% was occurring in about 3 months. Whereas the first study was 11% at the end of 1 year, and the second study was 34% at earlier, and 18% later. So what can be done? Okay, one is to prevent overfill. We have to very carefully titrate at the end of surgery. Basically, we will give anti-glaucoma medications. Peripheral PI inferiorly and antocyrotomy can be performed. Sometimes we will do graded diode laser cyclophotocoagulation. We can remove silicone oil if you find that there is a push mechanism which is because of higher this thing. Gonioscopy is an excellent marker. So all these patients we have to do pre-operative and post-operative gonioscopy. At 1 week post-operatively, trabeculitis, pupillary membrane, expansion of glasses, steroid response, secondary angle closure. Duration is between 1 week and 1 month. And so we should have good follow-up visits and IOP monitoring and gonioscopy prior to vitreoretinal surgery so that we know who are the people at risk. Thank you very much. Welcome you all to Kochi.
Thank you, Dr. Gopal, for the wonderful talk.
I would just like to add that SLT is a very good option in early ocular hypertension, which is not resolving with anti-glaucoma medications and oil-filled eyes. So that really helps to control the IOP, because otherwise there is no dysgenesis of the angle in these eyes, unless, of course, post-traumatic RDI.
I wanted to pitch one question here to all of you glaucoma people.
Animals, that is why they have come on to this frequency. Had that been the thing, why we would have used it like
because a lot of these
QID
patients
or
we cannot use
6RD, why
TAF.
not? Answer kar diya. Yeah, it will further increase inflammation. Now he is meaning to say about beta blockers also. The side effect profile will increase.
Okay, I think
All
that
will
girl is,
increase.
We are using Dr. Devin's time for this.
So next I would like to call upon Dr.
No,
Devin
don't call
to
me.
be-
I'm already here. So
Yes. So thanks for
So
being on the
neovasc-
dais. And sir would speak on current management of neovascular glaucoma.
yeah, so I think
And
just-
sir needs no introduction.
Acha, acha, okay, you're cutting into my time, as she says. All right. So वो देखो उसने 6 मिनट कर दिया मेरा. भाई ऐसा मत कर. 6 मिनट कर दिया तुमने.
कोई नहीं आ जाओ.
Neovascular management. So always treat the primary cause, and we in practice we get diabetes and hypertension or glaucoma related CRVO as the main causes. So I think I've done this talk last year. So just what we are seeing now post-COVID, much more neovascular glaucoma in our practice. 3 situations I'll cover in the next this and the 2 slides. Situation 1 is that the IOP of course is high, the cornea is clear, BG angle is still open. So this will have a good result with the IOP control. The medicines we have to use, the first line are in the first line, brimonidine, timolol, topical CAI, and of course now the ROCK inhibitors. Prostaglandins, if inflammation allows, yes, but these are not the first line. Myotics, usually no, because you have to see if you have to do a PRP. And very important for the pain, if it is there, inflammation, are steroids and cycloplegics. Situation 2 is what usually the patients come to us for glaucoma in the glaucoma clinic. IOP is high, cornea is hazy, the retina has been treated, but obviously now it has progressed, so cornea hazy means the retina person cannot do more. So there are 2 options, and I think what is happening is the second caveat of the first is that the retina was treated, now the retina has not been treated. Obviously there are 2 options here. You can do a paracentesis, give anti-VEGF, see the result, or you can do a tube straight away. So I think that the discretion has to be there. This is the third situation when the IOP is high and suppose there's a vitreous hemorrhage, and that means the retina has not been treated or has been partially treated. So in this we have to give anti-VEGF, probably consider a vitreoretinal surgery and do an endo laser. And always, even if you do a trab or a tube, please consent them and that it's a qualified success. This may not be their last surgery. I think I have finished in time so that we can have discussion.
Yeah.
Don't
Thank
stop
you
me.
so
Don't
much
stop
for
me.
that.
Yeah. Bolo, the girls, please. Bolo.
So the only thing I want to emphasize here, since we are discussing the NVG, that even if we do a trab or a tube after an anti-VEGF or PRP, which takes care of the VEGF, which takes the VEGF out from the eye, and eventually you, even if it is not lasered well, your trab will work to keep the VEGF at bay. But it's very important to keep following up these patients despite being laser. They again show up with new neovascularization because the diabetes is still not so much controlled in these patients. And then your trab will fail, your tube will fail, neovascularization will recur. So it's not a one-point therapy for them.
Yeah.
It has to be like a continuum.
Absolutely. And
Also, I would like to add upon that, like neovascular glaucoma is supposedly to be taken as a medical emergency type of a
Absolutely.
glaucoma, wherein your management should be like you are doing in a warfare. It is not like a normal trap, all the procedures that you are doing.
I just wanted to reiterate.
Do not enjoy stopping you all, but I get paid to exactly do that.
Ma'am, please.
Ma'am, now Dr. Sunita Dubey, ma'am, she is a senior consultant in Shroff Charity, and ma'am would be speaking on management paradigms in glaucoma surgery. Over to you, ma'am.
Since it's only 7 minutes, I'll just cover MIGS. I cannot cover everything. So Shalini has already spoken about MIGS. So I'll be just showing some cases. So there's a common perception that MIGS are employed only after the medication and laser options have been exploited, and they should be done before cutting surgeries like tubes and traps, but they can be done even after. So I'll be showing some cases, and these are the surgeries which we have been performing. The greatest advantage of these procedures which we are doing is that they are excisional and they excise the trabecular meshwork completely, and therefore they minimize the chance of scarring and reocclusion of the meshwork is very nicely visible. So you insert the probe, you engage the trabecular meshwork, you put the Swan-Jacob lens and then start ablating in one direction. And as you can see, this white line, and then rotate the probe and then start ablating in the another direction. And as you keep rotating your gonio prism, as you can see here, you can treat up to 140 degrees of the angle. So it is used even in children, and this is one of the patient with congenital glaucoma, and you see this white line very nicely and this membrane which has retracted. The glaucoma was short standing, it was not long standing glaucoma, and the patient did really well, and you can see very nice clefts, and the pressure was very well controlled. So that is the advantage of having this. The KDB procedure is more or less same as trabectome, but here this is the KDB blade, and it is specifically designed actually to treat the angle. And as you can see here, here you are getting the strip of the trabecular meshwork. You can see this strip which is coming off. In trabectome, it is ablated. Here it is coming off. In this patient also you can see. So the strips on either side have to be removed with the help of microforceps. So on either side, the nice strips, you are getting very long strips, and you remove them, and this is very effective. So again, KDB can be performed after tubes and traps. This was one of my patient, 32-year-old female, post VR vitrectomy glaucoma. The pressures were intractably high. So as we do AGVs in such eyes, the pressure became quite controlled. However, the patient was on 2-3 drops after AGV also, and the tube was in position here. And after 6 months, the patient developed this total cataract. There's the silicon induced cataract in glaucoma. So then since the angle was open, I decided to do phaco KDB and nice cleft here. Another patient, steroid induced glaucoma and intractably high pressure. He underwent multiple surgeries with a lot of scarring here, as you can see here. And here again the angle was open. So I performed KDB goniectomy here. And the patient was on along with the cataract. So you can see a nice cleft here. And then the patient had pre-existing rent also after removal of this cortical matter. So the vitrectomy was performed, thorough vitrectomy, and then the lens was put in sulcus. So the patient did well. So this is GATT procedure, which is again very popular in India now. So after making a side port and the main incision, you visualize the angle and then just do this 2 millimeter goniotomy procedure here to insert your the proline suture, which is mushroom tipped. So once you make this goniotomy, you insert this proline suture here, and just use this micro forceps to advance the suture in counterclockwise direction along the circumference of the Schlemm's canal, and then inject the fluid. Just 1 minute. I can continue.
Yeah, we have.
Okay. So you insert the fluid, and you can see the blanching of vessels here. So that ensures that your collector channels are patent. So these procedures are quite useful. This is one of the patients with traumatic angle. The vision was good. So this is the last procedure, eye stent. It has also been used extensively now in India, and this is the first generation eye stent, and this is the eye stent inject. And this comes with a preloaded injector. So I generally do this eye stent inject, which has 2 eye stents preloaded on the injector. And after doing here, I do first the phaco surgery, and then after doing phaco, you have to identify the angle very nicely. So this is one procedure where the angle you should get an fast view of the angle, where you should be looking at the trabecular meshwork, and with the trocar you just you place the trocar to the center of the trabecular meshwork and keep it perpendicular to the TM, and gently dimple it into the TM. So this ooze of blood is a good sign. That means your collector channels are patent. So when you do it, the next one also you implant 3 to 4 clock hours away, and then you just visualize it gonioscopically. So to summarize, we have now wide range of surgical procedures and novel surgical procedures, and they are now in India also they are getting popular, and they are really useful, not only before doing trab and tube implants, but even in some cases after trab and tube also, that I have seen in my experience. And if you use them judiciously, I think there's definitely a very low risk, and therapy can be monitored.
Thank you, ma'am, for this wonderful video assisted talk. And I think what is your, in the conclusion, you have concluded very crisply regarding the MIGS. What is your take on KDB versus trabectome?
Yeah, trabectome, I have published a paper. I have done more than 100. So the results are pretty good. So, but I realized that in trabectome, it's a plasma ablation. So the PAS formation is slightly more as compared to KDB. Now, with the experience I have learned, earlier I never used to start pilocarpine, but I think pilocarpine is a good thing along with extensive steroids. So if you use pilocarpine, it keeps the angle open, and the chances of formation of PAS are less. Although it looks paradoxical because pilocarpine can induce some inflammation, but if you give a lot of steroids, then the chances of inflammation reduce. So I think KDB also I have done almost 55 cases, and the results are pretty good. So the patients are not completely off medications, but if you can reduce 1 or 2 eye drops or systemic eye drops, even I have done in very advanced glaucomas also who are on Dimox and all. So there is actually reduction of oral medications. I think that is also a big relief for the patient. And then later on you can go in for trabeculectomy or tube. Any glaucoma surgery, even trab, can fail after a few years, and even tube also. So in glaucoma you have to have several options so that you can continue treatment over years.
Thank you, ma'am. Next I would like to call upon Dr. J.S. Bhalla. Sir is professor and academic head of DDU Hospital, and he would be speaking on role of ocular perfusion pressure in glaucoma. Over to you, sir.
Yeah. Thank you, Dr. Devang. At the outset, I'm thankful to RP Center and Professor Tityal for giving this opportunity. We all know glaucoma is a progressive optic neuropathy of unknown origin, and traditionally the diagnosis and treatment has been directed towards the control of increased intraocular pressure, which is the single most important modifiable treatable risk factor. But various trials have shown that glaucoma progression occurs despite the IOP reduction, and these are OHTS, EMGT, CNTGS, Advanced Glaucoma Intervention Study, and SITCH test, which have shown that the glaucoma continues to progress even after the target intraocular pressure is achieved. So glaucoma is a complex disease that cannot be controlled by only the IOP reducing therapies in all the patients. So glaucoma represents a spectrum where mechanical damage causes damage at the higher intraocular pressure and the vascular factors cause damage at the lower intraocular pressure levels. And on top of that, 60 to 80% of the glaucoma patients also suffer from comorbidities which have vascular insufficiencies. So they are going to have decreased ocular perfusion pressure. And way back in 1922, Felix Lagrange said that glaucomatous eye represents a sick eye in a sick body. And we all know about Von Graf glaucoma patients have hypertension and 30% have diabetes, and they all cause decreased ocular perfusion pressure. So in glaucoma patients, decreased blood flow has been reported to occur not only in the optic nerve, but also in the retina, choroid, retrobulbar vessels, brain, and also in the peripheral vascular systems. There is also vascular dysregulation in glaucoma. And why this? So besides the increase in ocular pressure, you have reduced ocular perfusion pressure, OPP fluctuation, and also abnormal dysregulation. So the glaucoma, the World Glaucoma Association sixth consensus publication has documented that low ocular perfusion pressure has been identified as independent risk factor for glaucoma occurrence and also glaucoma progression. But do we have adequate evidence to justify routine assessment of ocular perfusion pressure in all our glaucoma patients? The recent population-based studies have found low OPP to be risk factor not only for development of glaucoma but also for progression of glaucoma. And what is perfusion? Systolic perfusion has enough evidence that there is correlation of ocular perfusion pressure and glaucoma. And what is this? What is the relationship between antihypertensive patient and antihypertensive drugs and glaucoma? The first hypothesis is that the subjects treated for systemic hypertension, they experience large reduction of nocturnal BP, that is nocturnal hypotension, which leads to decreased ocular perfusion pressure in the early morning when the intraocular pressure is high. And hypothesis 2 is that antihypertensive treatment disrupts the vessel's natural ability to auto-regulate. There is already autonomic dysregulation, and the antihypertensive treatment plays more havoc. So Weinreb has stated that diastolic BP has a greater effect than systolic BP in calculating the mean ocular perfusion pressure, and Greenfield has given us the numerical correlation. That is, the diastolic blood pressure has 2 times the difference, that is 4.4 millimeter change in the ocular perfusion pressure. So I'll just rush through these slides. Ocular perfusion pressure, not only the ocular perfusion pressure, but the OPP fluctuation has also been found to be an important risk factor for the glaucoma progression. No single blood flow device at present can simultaneously evaluate all the vascular beds that are relevant to the glaucoma, and none of them is currently accepted as a gold standard for measuring optic nerve head blood flow. And the current OBF imaging modalities are the OCT angiography. And so what are the facts which favor the measurement of ocular abnormalities in glaucoma which extends beyond the eye? These are nail fold capillary abnormalities, association of NTG with CVS, then positive correlation between low glomerular filtration rate and glaucoma, which has been found in the South Korean population-based study, and cerebral vascular deficits are seen on MRI in glaucoma patients. So what are the patients in which we should consider assessing ocular perfusion pressure? A normotensive glaucoma, eyes with disc hemorrhage, patients with progression at low intraocular pressure, and patients who are on multiple antihypotensive drug. So while the relationship between ocular blood flow and glaucoma is well established, the nature is not well established. So circumstantial evidence of vascular evidence involvement of glaucoma has now been bolstered by experimental evidence, and OPP is now established risk factor. So convincing correlation of OPP as a risk factor for glaucoma is just like a high-hanging fruit. It is there, but beyond the reach of our present-day evaluation capabilities, and the ultimate beneficiaries of work in this area will not be researchers, but our glaucoma patients. Thank you, everyone.
Thank you, Balla sir, for such a crisp talk on such a vast topic. So next, I would like to hand over the dais to the retina people, and I would like to invite all the speakers and Dr. Tanuj also for a group photograph.
Hello. Thank you so much to all the speakers, chairpersons and the moderators. With that, I would like to welcome our next chairpersons, Dr. Rajvardhan Azad, Dr. S. Natarajan, Dr. Dinesh Talwar, Dr. Rajpal Vora, Dr. Pradeep Venkatesh, Dr. Parijat Chandra, Dr. Shobit Chawla. I would also like to welcome the moderator, Dr. Rohan Chawla.
Good evening. Is Dr. Rajpal? Good evening. Dr. Rajpal, you are supposed to be here. But Talwar also will be there. All of you can be here so that nobody will be there in the audience. Dr. Talwar also is there. Oh, Dr. Rajpal, you have to be there. Then Pradeep Venkatesh. No, come here. Hey, we want the hall empty. Parijat. Where is Parijat? And Shobit is here. Where is Shobit? You are here. Okay. So, Parijat. Hey, chair there. So thank you and welcome to this experts' perspectives in retinal diseases. First we have Dr. Chaitra Jaydev from Bangalore, Narayan Nethralaya. Wild field imaging for retinal diseases, does it add value?
So thank you, sir. I'm going to go straight to my talk. Dr. Dinesh Talwar, sir, had told us 8 minutes. We argued for 7 minutes and now it's 6 minutes. But I'll try to finish it in 5 minutes. See there? 6 minutes. Anyway, so no financial disclosures. So why we're looking at wide field retinal imaging is because there's actually a study group that changed the entire definition of why it's called wide field. What is posterior pole? We all know what is wide field is when you see all the 4 quadrants posterior and including the vortex vein ampullae. And finally, you have the ultra field where you see even anterior to the vortex vein ampullae in all the 4 quadrants. So that's your ultra wide field. So it describes retinal imaging into the far periphery in a single capture and not montage. Now the traditional retinal cameras that we have about 4 to 6 images that need to be montaged, and sometimes you can only see the posterior port very well. Now the wider field cameras increase the visible retina much more, and then finally you have the ultra wide field which gives us up to 80% of the retina in a single capture. That is your 200-degree view. So this is just to give you a comparison of how a montage would look over a wide field and how much we would miss and how much of overlap there would be. So these are a couple of other, montage images, some more here. So why it's really important is that we get such a better perspective of what we need to see all at one go, whether it's for diagnosis or it's for surgical planning as well. So quickly to look at the evolution of retinal imaging, wide field imaging and ultra wide field is 200 degrees. But what we have at our disposal now is we have the RetCam, we have the Panoret, we have the Optos, the Heidelberg Spectralis, the Claris, the IDON, the Mirante. These are some of the devices that we all have. So when you want to look at the perspective of how each of these visual fields look, so this is just an image which shows how a slit lamp camera image is, where you use a 90 diopter lens. That's how much you see. So probably the previous session of glaucoma specialists would be happy with this view. Then you have the indirect, which we routinely practice in our OPDs with 30 degrees. Then you have the fundus regular cameras, which is 45 degrees. Then the wide field, which is 100. I think this is how much Claris has, and when you montage, you get a bigger view. And then finally, you have the Optomap or the ultra wide field, which is around 200 degrees. So we have the Daytona at our center, and a lot of these images are from that particular device. So this is how a good image without artifacts, lash artifacts, with good media looks, and this is the FAF. I'm going to quickly go through the FAF images. I'm not going to dwell on that too much, but they are definitely helpful, especially when you're looking at conditions like this, where you see multifocal choroiditis. This is a patient with RP here, and this is a patient with choroidal melanoma. So when you go directly to retinal diseases itself, diabetic retinopathy, I think it's extremely important for us, especially when you're looking at a screening point of view. When you don't want to dilate the patients, it's definitely helpful to get it, because they've actually compared a study with ETDRS 7 standard field and found that DR was more severe in at least 20 to 30% of the cases. So these are some, nasty images of diabetic retinopathy itself. This is a patient that I operated, was following up for a long time. You can see the sclerosed vessels going into the periphery, so it's very useful to prognosticate. This is how the patient progressed despite doing PRP, and then finally he required surgery. This is post-op of this particular patient. So vascular diseases also, to know the extent of the disease, to even show this is a patient with hypertensive choroidopathy and inflammatory disease of the retina also. So many times we're not able to really image into the far periphery because of non-dilating pupils in these patients with inflammation, but they actually do quite well. This is even a tumor that you can see here post-inflammatory. Some more conditions is a patient with syphilis who eventually underwent treatment, syphilitic vasculitis, and improved. This is also a similar patient. Now, going forward with respect to especially refractive surgery, a lot of our patients are undergoing peripheral retinal screening, non-dilated, because it really does help. So these are patients with HST. Also, patients are more amenable to treatment when you show them, look at the tears that you have, it's helpful. This is a patient there, you can see a slit-like tear in the HST there with the RD. And a closer look shows you more peripheral retinal degeneration, including a lattice. Again, to show them pre and post treatment, most often they don't know what we have done. They think it's a surgery. Here, this patient required more of barrage to show to them that, convince them that treatment is required, because there are some leftover lattices there. AMD, again, when it's peripheral, when you want to see a PHCR like this, and again, when you want to plan treatment itself, extremely helpful here. This is again another patient with massive subretinal hemorrhage. We think AMD post-pole is adequate, but here you can show how the disease is more extensive. This again a patient we've treated. Extremely useful in blood dyscrasias, because you can see their entire extent, and also to impress upon the patient as to how they could potentially have life-threatening either anemias or leukemias or blood dyscrasias. Tumors, this is a patient where we could literally count about 17 tumors, one-eyed young boy, of course eventually underwent surgery. Some more of these, this is a sphenoid ridge meningioma with secondaries, some more tumors here again. Another very important indication is pediatric retinal diseases, because avulsion here. So why ultra-wide field? ETDRS is very limited, and most of the studies have shown that 60% of the disease is actually beyond the ETDRS standard field. Therefore, we need to know the extent of the disease so we can actually plan treatment and prognosticate accordingly. So these are some of the papers that I was part of, where we did lesion distribution for peripheral retinal degenerations and also for diabetic retinopathy itself. So yes, it does have enhanced resolution, shorter imaging processing time, faster acquisition, ease of duplication, manipulation, and the possibility of transmission via electronic route. And even those patients with cataract, we do get good images, non-compliant young pediatric patients with small pupils, simultaneous imaging of the entire retina. Most of these devices have FA, ICG, and FAF enabled. Some of the problems are the cost, the pseudo color in these images. Some of them have lash artifacts which they are trying to overcome. So these are what I have summarized over all the images that I showed. Most importantly, if they can become more affordable, will be a great tool for diabetic retinopathy screening. Thank you so much.
Next we have Dr. Dinesh Talwar to speak on anti-VEGF for DME. In the meantime, anybody wants to give a quick comment before Dr. Dinesh is ready? Dr. Shobhit.
The number of Indian patients with peripheral diabetic changes are much less. So a multi-centric study done in India, I think your center was also involved, showed that, Claris gives a better diagnosis rate as compared to optotic. Compared 3 cameras. This is, I think, by the Shankar Nethralaya group. It's a very interesting study, and because the changes in the posterior pole are picked up better by the Claris than the optos.
Thank you. In the meantime, I think we welcome Dr. David Brown, who's online. Dr. David, first I think Dr. Dinesh Talwar is speaking, and the suggestion is next you can give your talk. I hope Dr. David is...
To give first?
No. I don't know. He just came online. What happened?
He just come online.
Hey, okay. Okay. Thank you, David. You go next. So first, Dr. Dinesh Talwar.
Thank you, Dr. Natarajan. I wish to thank RP Center for inviting me back to my parent institution, and it's very nice to be here. In today's world, anti-VEGFs are being given right, left, and center for DME, and now we have a lot of anti-VEGFs to give. So question becomes which one to give. And this is my disclaimer, and there is a financial disclosure which is relevant. Now, before you go to anti-VEGFs, keep in mind that optimal management of diabetic maculopathy requires a multi-pronged attack, which includes medical management. And that is done by controlling the lipid profile, the HbA1c monitoring, hypertension, and nephropathy management. Secondly, it's very important to understand that patients whom we consider even as center-involving diabetic macular edema, many of them on fluorescein angiography will have leaks which start more than 500 or 750 micron from the foveal center. So these are easily amenable to laser, and this is a fairly large number, both in DRCR-NET protocol I and Restore. Almost 50% of the patients had a possibility of being amenable to laser. If you don't use the laser in these patients, you actually skew the treatment towards more and more injections. So from a therapeutic point of view, if you have leaks within 750 micron from the foveal center on angiography, the way to go is intravitreal agents. On the other hand, if it's further away, then it's a question of adding focal macular laser plus antivitreal, intravitreal agents. Now the question comes, which anti-VEGF drug do you choose? Now the protocol T actually gave us a comparison of aflibercept, bevacizumab, and ranibizumab, and said, well, overall, if you see the whole group, aflibercept seems to be better than the other two drugs, but the difference between aflibercept and ranibizumab becomes less in the second year. And if you see the effect on the central subfield thickness, even that is higher with aflibercept than with the other two drugs. However, what is more important is that it's the patients who have lesser vision, less than 20 by 40, that's 6 by 12, who have the best gains with aflibercept as compared to the other two drugs. So if you have patients with poorer vision, they need to be preferentially treated with aflibercept. In patients with better vision, it really doesn't make a difference which drug you give. The most important thing to keep in mind is that 50% of patients can be considered elite responders on aflibercept. They respond to 3 injections with more than 10 letter gain, and these patients will do very well over the next year or so also. On the other hand, you have another 25% who don't do as well. So this is the important thing. The other important thing to keep in mind is persistence pays. If you keep on with the injections, regardless of which one you give, whether it's bevacizumab or aflibercept, over a period of time, it makes a difference to the degree of they are very active. They need their near vision and their distant vision as quickly as possible, and the longer the period of time you can give them that, the better it is. So the area under curve with aflibercept is much better than it is with the other 2 drugs, which is why aflibercept is a better drug to start with. Yeah. Now, in terms of central subfield thickness, are the patients who have poorer vision, do they do better with aflibercept? So, well, if you look at this, you find that, in fact, aflibercept is one drug which can be used as monotherapy, and even patients who have poorer vision, they do much better as compared to ranibizumab and bevacizumab. However, in patients with good visual acuity, it doesn't make a difference whether you are on ranibizumab or aflibercept, the same degree of drying of the lesion occurs. The other important thing to keep in mind is that patients with a central subfield thickness of more than 400 micron, these patients are best treated with aflibercept. On the other hand, if the thickness is less than that, can't afford aflibercept, then what to do? Then if you add laser to the treatment, the combination of laser with anti-VEGF ends up giving you the same degree of central subfield thickness drying as in monotherapy with aflibercept. So the important thing is, when the patient can't afford it, you have the alternatives in terms of combination of ranibizumab with laser. Another important thing which we need to keep in mind, and we seem to not stress this enough, is the fact that today with anti-VEGF agents we can actually make the disease regress. So you can have a 2-step improvement in the diabetic retinopathy severity score in many of the patients. And if you take patients with NPDR with DME, almost 1/3 of these patients can end up with better in a regression in their diabetic retinopathy if you put them on anti-VEGF drugs. And in terms of proliferative diabetic retinopathy, the results are even better with aflibercept. 75%, that's 3/4 of the patients, can be made to regress if they have DME. So this is one aspect we are not giving enough importance to, and we must keep that in mind. The paradigm today for most clinically effective management, we are not talking about the most cost effective, but I want to know what is the best I can offer. Initiation with anti-VEGF, and aflibercept is the drug of choice, especially in patients with vision less than 615 and a central subfield thickness of more than 400 micron. In patients with thickness less than that, both aflibercept and ranibizumab are equally effective. If the patients don't respond to the first 3 injections of anti-VEGF, which will happen then you can consider adding steroid. That inadequate treatment will happen only in 25% of patients with aflibercept. 50% of patients with aflibercept and 75% with ranibizumab. When you give retreatment after the steroid, use aflibercept, because that is a better drug to allow for steroid washout. And finally, please add laser to focal macular treatment, laser as focal macular treatment to your anti-VEGF treatment if you want to get the best results. Keep in mind, this is a finite disease in many patients if the treatment is taken rigorously. So to conclude, ladies and gentlemen, judicious, rigorous use of intravitreal agents and laser treatment along with medical treatment can provide improved and sustained visual outcomes in our patients with diabetic macular edema. Thank you very much.
Thank you, sir. Thank you for giving us such a nice paradigm for diabetic macular edema and telling us about comparison up till aflibercept. So I think we'll take the next talk with David Brown. Sir is joining us online. He will be talking to us on DME with the newest agent that we have now available, and then we can together take a discussion on DME after that. So Dr. David Brown, please, sir. Can we have audio from Zoom?
Can you hear me?
Yeah, please go ahead, sir.
Perfect. Let me just share my screen here if I can figure it out. Presenter mode.
Please allow a shared presentation.
Okay, I'm share content and I'm browse my computer. I bet we got it right here. Can you see my slides?
They're loading. Yeah, now we can see them.
Perfect. First of all, thanks for having me. Great early talks. They showed me some video around the room. It feels like I'm there. I wish I could be. I think I'm coming to India in May. Just a comment on the first two talks. Absolutely agree with everybody said on the cameras. The Optos, I'm on the Optos dewarping patent, but it doesn't work that great. We're working on better dewarping. Comment on the last one, I absolutely agree. The most important thing you can do is to control the hypertension, the diabetes, the sleep apnea. Sleep apnea is something you really want to think about. A lot of patients have sleep apnea. You control their sleep apnea and their DME gets better. All right, I'm going to talk about brolucizumab, new trends of diabetic macular edema. The disclaimer is I was on the brolucizumab steering committees and designed Kestrel-Kite. Most of these slides came from my original presentations, but Novartis helped me as well. We're going to talk about unmet need, which you all know, the molecular characteristics of brolucizumab, which we talked about in the past, but it's been a while. Now that you're having this molecule, I want to talk about the differences. I'm going to talk about Kestrel-Kite and then summary, including how to manage some of the inflammation, which is real but rare. So we all know that there's a lot of patients with diabetic macular edema throughout the world. I live in South Texas, where there's an epidemic of diabetic. 40% of our population is either pre-diabetic or diabetic in Texas. They have often the way you get diabetic retinopathy is 15 years of non-compliance to a medical regimen. So if they haven't been compliant for 15 years, what are the odds they're going to stay compliant with your regimen? And that's one of the biggest problems. The other problem is these eyes have so much ischemia, they have very high VEGF levels, and often they need a lot of whatever drug you give them. Agree with the previous talks, all the drugs work, but the more anti-VEGF blockade you give, the longer you can control their dry retina. And that's why aflibercept superior to ranibizumab in our DRCR trials. The molecular characteristics of brolucizumab are incredibly unique. It was developed at the University of Zurich. And on the left, you see, number one, a full antibody to VEGF. Here you have two arms, both the light and heavy chains, with the CDRs hooked to an FC domain. This molecule is totally manufactured separately. You basically take the CDRs that specifically just bind to VEGF, just the smallest part you can get, and put them together with a proprietary human SCFE scaffold. It's a very complicated molecular biology experiment. It actually took University of Zurich 15 years to make this molecule stable. It's kind of like two positive magnets kind of wanting to not stay together. It's the first SCFE approved in ophthalmology. And the reason it's unique is by making it so small, and let's show you the size of it, is 26 kilodaltons, which is about half the size of ranibizumab. But note that all of it's functional. Half the weight of ranibizumab is non-functional in terms of not binding VEGF. It's approximately 1/5 the size of bevacizumab, or 1/6 the size of bevacizumab, and about 1/5 the size of aflibercept. What that means is you're essentially giving 22 milligram ranibizumab, or 6 or 7 milligram aflibercept. So you're giving a very high dose, which really controls or attacks recalcitrant DME and dries the retina very quickly. I'm not going to go over this summary much since I just said it. The main thing is you get high ocular concentrations and a lot of anti-VEGF blockade. Here it says 12-fold higher molar dose than aflibercept. That's probably more correct. It's just like ranibizumab and aflibercept, and then it binds all the isoforms of VEGF. I'm going to show you the Kestrel kite high-level data. Here we had, it was a 100-week trial. The primary endpoint was 52 weeks. We were in 36 countries, including India. Kite was predominantly India, Asia. Kestrel was predominantly North America and Australia. The study design was we gave 5 loading doses of 6 milligram brolucizumab, and then extended to 12 weeks or 8 weeks, and with some retreatment criteria to come down. We compared that to 5 loading doses of aflibercept monthly, and then aflibercept every 2 months. The baseline characteristics, well balanced, pretty robust diabetic macular edema like we see here and in India. 450 to 480 was the average. There was about 13% Asian in Kestrel, and Kite was approximately 25% Asian patients. Almost 100% of patients had intraretinal fluid for the reading center. The objective is to see if it was non-inferior and to see if we could use this drug less frequently. We were also looking at the safety and specifically the treat and extend intervals. Here you see the primary outcome in Kite. Actually, brolucizumab was a little above 1.2 letters despite lower dosing. In Kestrel, about the same, 1.3 letters below, all within 5. It's the only time in the history of anti-VEGF we didn't have a dose response curve. It's not that 0.3 was better, it's just really hard to randomize diabetic patients. Here you see anatomy. Even with lower dosing, you see comparable drying of the retina, actually statistically superior drying in Kite, 0.001. These were pre-specified endpoints showing you eyes that were drier, less than 280 microns. These times, 32 weeks is exactly 8 weeks after a dose for both groups. So it's a head-to-head. And 52 is a pre-specified. And here you see the blue bars are higher, dried out more retina. Makes sense with the higher molar blockade of aflibercept. Looking at specific, the reading center, again, this one you want lower bars. This is looking for any little cyst anywhere. Let me make it clear, I don't treat diabetic macular edema totally dry like I do AMD. I think fluid's tolerable outside the fovea, and you often can't control all the fluid unless you give monthly dosing of very strong agents. This is throughout the trial. Here you see throughout the trial we had fewer patients with intraretinal fluid and at every standpoint after week 4. Diabetic retinopathy severity score. We are approved in the United States for a lot of our agents for diabetic retinopathy severity. It's not used that frequently just because they're asymptomatic patients and often doctors wait until they have diabetic macular edema or PDR. That being said, it's an indication of, are you turning the clock back? Are you making the eye more like an eye with 10 years of diabetes as opposed to 20 or 30 years of diabetes. Here you see actually a little better improvements in DRSS despite less dosing than aflibercept. How many patients could actually be maintained? It was a pretty tight retreatment criteria. We could maintain 55%, 50 to 55% on Q12 with brolucizumab. And once you got that, approximately 90% were able to maintain. And so in that population that went to 12-week dosing, you were able to maintain that with pretty tight control of the edema. Let's look at the safety profile. Safety profile really was pleasantly, one case that affected vision with 3 milligrams. Doesn't make sense, but retinal vascular occlusion that happened in the study, we looked at all the cases. They really didn't look to be involved with inflammation. They looked more like a small BRVO or BRAO like you'd see in this diabetic population. You know, it's of note that in this study, the drug was given Q12. When we saw the most intraocular inflammation and vasculitis was in Merlin, where we're giving it monthly. And so I think if you need monthly therapy, I would not give this agent. I feel much more comfortable at the levels we gave it in this study or less, which is approximately quarterly. In summary, brolucizumab non-inferior, curves on top of one another with fewer injections, significant improvements in OCT, higher portion of patients with dry retinas, and in the United States and Europe, most of us treat and extend. What that means is if you dry the retina out, you're going to extend longer, so a priori you have higher, more durability. More than half the patients were on Q12. And overall, the safety profile was well tolerated in this study. I'm going to show you a couple of case studies very briefly, then I'm happy to answer questions. This was a case in the study showing you, just what this agent does. It's an amazing drying agent for controlling diabetic macular edema. Here you have 30 letters at day 1, by week 28, 44 letters. And then at the end, 50 letters on Q12 dosing. I really showed you this because I had serial fluorescein angiograms. Here you see on baseline a lot of vascular tortuosity, capillary non-perfusion, with actually what looks like the beginnings of IRMA. And by week 28, you see a lot less tortuosity. You see resolution of the microaneurysms, and potentially some improved perfusion by week 52. Here's a case in the real world, 57-year-old, A1C of 9.2, vision was 618. Here you see the same type of picture, dilated venous, cotton wool spots, a lot of dot blot, microaneurysms. This is the right eye and the left eye. Left eye was much more affected. Here I'm showing you a single dose of brolucizumab. Really absolutely controls the disease. I would not treat it 1 month and treat and extend here. I would go another month, see if she stays dry. And even though I'm presented loading doses every 6 weeks, I don't think the loads, particularly magical. I think if it dries out the retina and you're still getting effect, I don't think you have to do a load. But that's up to each individual patient and doctor. I'm going to talk a little bit about the potential for retina vasculitis and intraocular inflammation. It is rare in the AMD population. It's about 1 in 200. In the DME population, it seems less. We had a big worldwide think tank trying to figure out what the exact cause is and how do you mitigate it. Really still haven't figured out exactly how to figure out which patients are going to get it. So if you do have patients on this agent, you're going to treat less often, and that's good. and they're going to save some drug costs, but they probably need more frequent and more intensive clinical exams. I recommend clinical exam looking for subtle vitreous cell. Sohan Hayre was one of my mentors and heroes, and he could see vitreous cell way better than me. And I'm, he passed away this year, and we miss him. But those of you who are great clinicians, please look. I'm going to show you some tricks for those of us who rely more on imaging. The peripheral retina exam for sheathing, vascular occlusion, love the Optos. I do an OCT at the macula and RNFL at baseline, and then repeat that. I'm going to show you why. I do a fluorescein at baseline. If in doubt, you repeat the fluorescein, see the hot nerve, treat. Highly recommend treating aggressively. We use intravitreal steroids predominantly in the US when we see these cases. We have intraocular dexamethasone implants, but I'm totally fine with triamcinolone. I'm showing a patient with neovascular AMD just because I have the best OCT images. This is a patient that was on 8 weeks brolucizumab and was doing great. We tried to extend out to 12, but before we could do that, she presented with a little fluid in vitreous cells. And those little dots are real. They weren't there before. This is her baseline RNFL, and that's the main reason I'm showing you this case. This is on a Heidelberg spectralis. Here you see, if you look at the change map at the bottom, subtle but real elevation of the RNFL. I like to do the flicker on the Heidelberg between the two. And I'm hoping this shows up. The bottom is where it's flickering to showing you the increase in RNFL thickness. I actually learned this because I'm the retina specialist for NASA. And we get these same changes in space due to venous overload choroidopathy from the lack of gravity. But it actually, if you're using this for cystoid macular edema post cataract surgery, it's a great way to tell if you've controlled the CME, the Irvine gas CME. It's also a great way to see subtle early disc edema. We gave them an intravitreal dexamethasone. We switched them to ranibizumab. A month later, the fluid's gone and the vitreous cell's gone here on the macular scans. We scan through the volume scan. You still see a cell here on the RNFL, but note that the RNFL is quieted down now. In summary, brolucizumab is an incredibly strong molecule. If it wasn't for the rare intraocular inflammation, I think it would have taken over the treatment of DME in the United States. You get the same benefits as aflibercept with less dosing. The concern is the retinal vascular occlusion. It was less frequent in this younger population, but you need to look for it, catch it early, and manage it aggressively. Thank you.
Thank you. That was a wonderful talk on this new molecule, and also the clinical cases that you showed were wonderful. So I would just like to ask you, like the previous speaker, Professor Talwar, had told that if in cases where aflibercept doesn't respond, do you think brolucizumab would be a good alternative, or we should rather still stick to switching to steroids?
Yeah, I guess it will be a better agent. It will dry the retina. I'm concerned that those patients may need frequent brolucizumab. So we have patients that really respond that you can give, that can be given Q12 dosing with brolucizumab. But if it requires monthly, I wouldn't do it based on what we saw in Merlin. The problem with steroids is everybody gets a cataract, which is fixable. But the intraocular pressure, you have a tough problem in those that are steroid responders. If they're a non-steroid responder, I would certainly think about brolucizumab, but also think about steroids.
So can you just stop sharing your screen? I think then we'll be able to see you in the entire screen.
Yeah. Let me show how to stop doing that.
Any other questions from the panel, please?
Dr. Brown, I noticed
Here we
that your one of the slides mentioned that 80% of patients had intraretinal fluid at 52 weeks. But we are saying 50% of the patients were actually on 12 weekly injections. So how do we reconcile the two things?
Yeah, that's a good question. So the slide with 80% is the Duke Reading Center looking at every picture throughout the entire macula. The retreatment criteria really just involves center thickness. So that was, like I said, I typically don't, aggressively chase fluid if it's extrafoveal.
So if your vision becomes, say, 6 by 9, that's what, 20 by 30, would you stop the treatment even if there are cysts? If the foveal contour has come back, some cysts are still there, vision is 20 by 30, would you consider stopping the treatment, or would you still pursue the treatment till you come to 20 by 20?
I treat more the OCT than the visual acuity. And so if they have center cysts, I would keep treating. In AMD, some of the cysts are non-responsive. They're over geographic atrophy or whatever. In DME, the way you tell is if you see them a week later and it's gone, that means they're anti-VEGF responsive. They're just not getting enough. Those patients are particularly the ones that you make sure their hypertension's under control, sleep apnea, fluid. You try to get them to control all that stuff, which is usually fighting against you.
Any other questions from the audience? Yeah, please.
Just a quick one. My practice, I've changed over and moved to faricimab because there's no incidence of intraocular inflammation. Do you think your practice, you're still continuing to use brolucizumab? Because we are finding faricimab to have much better results both in AMD and diabetics. And that's the reason we are all switched over. And the reason, we don't have to monitor them for inflammation, which is so random in patients with brolucizumab. So what is your take on that? Or do you still, in your practice, your first line is brolucizumab?
Yeah, faricimab's, I'm hearing an echo, sorry about that. The faricimab is, recently came out in the United States about a year ago. It is a very good molecule for recalcitrant patients without the inflammation. In the United States, there's lawyers on every corner. And brolucizumab, because of the rare inflammation in AMD, is not marketed much because of that. I think it's still an appropriate agent for patients if you want to watch them. But faricimab is taken over. Both those agents are over $2,000 in the United States per dose. So brolucizumab hasn't been on did not get on as many insurance plans. So we really don't have a way of head-to-head testing brolucizumab versus faricimab and DME. I apologize.
Thank you very much. And thank you for joining us from overseas, and especially for our annual day. Thank you, and we'll go ahead with the next talk. Next talk is by Dr. Shobhit on myopic maculopathy. Dr. Shobhit, please.
Thanks to Dr. Tityal and the retina team, Dr. Parijat, Dr. Rohan Chawla, Dr. Venkatesh, and Dr. Rajpal. So, back in the days when there was no OCT, I used to always wonder when my patients would not improve or patients referred to me would not improve, myopic patients after their cataract surgery, what lurks beneath. And this is one of my favorite comparison slides. What you see up on the left is juvenile foveoschisis, and this is myopic foveoschisis. See the difference in the behavior of the ILM in both. It's just both are foveoschisis, both are different, both of different etiologies, both of different origins. So MTM has gained interest because of OCT coming in, and in fact, it gained interest even when fundus photography used to be done because of the dullness in the reflex which used to be seen. And it affects a fairly large number of myopic eyes with posterior staphyloma. The average age of detection is about 53 years, and the symptoms are blurred vision, reduced visual acuity, central scotoma, and metamorphopsia. We all know that it's precipitated by abnormal growth of the posterior pole, which has been documented both by CT scans and MRI. Lovely studies from Japan on this. And there is resultant traction on the inner retinal layers, resulting in foveoschisis. And once the macula is detached, the tangential forces influence the outer layers. There are a lot of classifications, couple of them given by Dr. Barbara Parolini and her associates. But what I like to follow is, for my clinical purposes, a very simple classification. When I see a patient, I'm looking at the clinical picture, because there's whether my technique of surgery, which is an ILM peel without a macular buckle, will do any good. Let's see one case example. 6-9 vision right eye, 6-12 early posterior subcapsular, and there was myopic foveoschisis. I identified this traction in this patient on her first visit, but there was no hurry to operate. The patient was explained about the possibility of phacoemulsification and vitrectomy surgery along with ILM peel. Normally I use SF6, I don't use C3F8. Patient didn't undergo the surgery and returned 1 year later with 636 visual acuity. And this was the picture, but the temporal traction remained. So she underwent phacoemulsification with IOL, with a vitrectomy, ILM peel, and a C3F8. How do I play the video? To monitor drop in vision and their visual complaints. So I do a same phaco with ILM peel. It was an only-eyed patient, so I was very careful, followed him up for nearly a year. And when his vision really slipped, I went ahead, and after phaco and a good ILM peel, that time I was not doing a sparing peel, we achieved 20/40 vision. Another only-eyed patient with only counting finger 1 meter vision, the other eye, the fovea, was badly scarred, as you see some scarring here. Patient was very keen, I do something, and we could achieve a stable counting finger vision here. One with a macular hole, 618, follow-up 636. We did the surgery, there was a secondary closure despite flaps, but she reaccumulated fluid and had to undergo surgery with silicone oil, and I had to put a free flap. So there is a variability of response to surgery. Combined surgery in my hand works better. History of recent progressive decrease in vision is a good prognostic marker. Peripheral retina checkup is very important at conclusion. In the absence of macular hole, I feel ILM peel can get good results. So that's what's important. Thank you.
Excellent presentation, sir. Nice video. Any questions from the panel? Sir, you do peeling generally under PFCL or?
It's always. Okay. I do use an extended forceps. It's longer than the Reich-Haber's forceps, the old synergetics forceps. Okay. I have 2 of those. So they are longer, and at times I just remove the what everybody.
True card.
Extended forceps is available? Where?
It was available when I bought it. 25 gauge was available for a very brief period, and they are reusable. They are not.
That's a very difficult thing.
No, but now you are having disposable extended ones also. They are available by another company. I'll coming as disposable. They are very good. I'm using those.
So just for the audience, in some cases where the contrast is very poor, sometimes I prefer to use PFCL and then restain under PFCL and then do it. It becomes a little easier. So we'll move to the next.
Thanks to Dr. Titial and the AIIMS faculty for inviting me. Not moving, slide. Yeah. Okay. So we all know what is the expulsive hemorrhage. The incidence of spontaneous suprachoroidal is not known because it occurs rarely, and these are the systemic risks, and these are the ocular risk and intraoperative risk. And I am not going into the detail because of the time. The key to preserving eye with an intraoperative suprachoroidal hemorrhage is early recognition and prompt action prior to the expulsion of intraocular contents, and recommendation to minimize risk of expulsive choroidal hemorrhage during the surgery. And these are the intraoperative signs and symptoms, and there's a difference between serous and hemorrhagic choroidal detachment. And management of intraoperative massive hemorrhage. If a suprachoroidal is suspected, immediate closure of the wound should elevate the intraocular pressure sufficiently. I hope I'll be able to demonstrate. It happened when I was doing vitrectomy. So this is an ultrasound showing a suprachoroidal hemorrhage like a kissing choroidal. And then I have a 76-year-old male with a post-open globe injury, post-primary repair. He was sent in a day, and then I took up in a 2 days' time. And this is the video where you can see the initial repair was done in actually in Lucknow. And then the next day the patient, because the patient's son was an IAS officer who was a principal secretary to the government of Maharashtra, so they came, and you can see, increasing the intraocular pressure. So I was actually putting a belt buckle by making a scleral flap and then passing it 360 degree. I thought I made sure that the intraocular pressure is always maintained on the higher side, but you will be seeing now while doing vitrectomy, expulsive happen. And so I don't know what is the mistake I did, but you have to be, in spite of all the experience, and I think that when the expulsive is happening, I didn't realize. So first, when the mound is happening, I thought the suprachoroidal infusion is happening because of the wrong placement of the cannula. So I think you can see a bullous detachment happening, but actually it was the early sign of expulsive happening. But when I realized, then I used PFCL, used AV oil which was there to arrest the bleeding, and so, but nothing happened. I had to close the case. You'll be seeing shortly. I'll be closing, and then I realized I have to keep the intraocular pressure high. You can see the cornea STEMI high, and then I also use some oil to keep the intraocular pressure. And I thought I can go inside and see what's happening, but it was terrible. There was almost a total detachment happening. You can see retinal folds, choroidal folds, and I think it's a mistake to continue at that stage. You should have just come out. And this is again checking the infusion line. And then I also thought there's no use of the encircling band, and I removed the encircling band also, leaving the intraocular pressure high, and managed the intraocular pressure and then I closed the wound. And this was after 18 days. You can see we again planned surgery. And so I remember one of the local, since he was a principal secretary, he told me, how can the expulsive hemorrhage, why not you talk to the head of the department in JJ Hospital? And when I called him, he said, how can expulsive happen? I said, nobody has taken the appointment, or nobody is afraid of any official. And he was an 85-year-old man who had an injury and had this expulsive. So I told, expulsive happens, whatever you do. So I do a vitreous lavage. You'll be seeing a large retinal tear after I clear the vitreous hemorrhage. And you can see there's a large tear, and there's a subretinal silicone oil. And so I clear the preretinal hemorrhage, also the subretinal hemorrhage, and then I also remove the subretinal heavy oil, and that's another problem. Heavy oil sinks down, so it goes almost to the optic nerve. So I'm now patiently removing the oil through the large break, and you can see like a golden reflex of the oil bubble which is there. I also cleaned the surface of the choroid using the retinal brush. It was easy to give up, but I think the patient and the family was ready to try. I did that, and I'll be able to reattach the retina in this eye. So I always suggest don't give up, and you can see there was no PVD, so there was a vitreous blood clot. So I also saw macular hole, so I decided not to use PFCL. It will go into the subretinal space. So I tried to open the fold, which is like a disc is not seen, and I keep stretching the retina using the endodrainage through the retinal break, and also remove the, using the forceps, remove the clot from the posterior pole. And I also went through the macular hole, and I will don't recommend for the young surgeons, because you can damage the macular hole or even the RPE and the photoreceptor layer. But you have to be careful, and if you can manage it without touching the RPE, you can do that. So I do this. You can see I also done the endo laser around the large break temporarily, and also over the macular hole, and left the eye with the heavy oil. And this is the fundus photo with an attached retina with the laser around the macular hole and the large tear. And this was an 88-year-old female, again referred as a expulsive hemorrhage, pre-op perception of light. And you can see, so I use the AC maintainer a lot, and then you can see the choroidal hemorrhage is being drained. And so this, I think I do multiple ports, and I made a scleral flap. You can see I put the port multiple, maybe 3, 4, and also finally made a sclerotomy because the suprachoroidal hemorrhage was not draining through the scleral ports, and usually I can manage it. And so this is how I keep draining, and you can see the picture during the surgery, and then I keep draining more because you can see some more hemorrhage. And this was a lady who was playing with a grandchild and hit in the corner of the table and had this expulsive hemorrhage. And I think I've done 4 surgeries for saving the eye. Patient got about 1 meter vision, I think. And it depends on, and again you can see I've done the removed the subretinal blood, suprachoroidal hemorrhage, and also subretinal blood, suprachoroidal hemorrhage, and also closed the scleral wound, and the patient got about 1 meter vision. And then this was the post-op with attached retina, and this is again a 70-year-old suprachoroidal hemorrhage. You can see a decimus fold, and this man is luckily the other eye was good. He underwent a corneal surgery in Hyderabad, and then came back with a glaucoma valve. I don't know what happened. He had an expulsive hemorrhage, and this is one of the terrible eyes. And this man asked me, I told him that you have question mark PL, and whether to operate or not you have to decide. And I'm draining. You can again see multiple ports. Oh, sorry. So you can see, I can see the optic disc. I could clear the suprachoroidal hemorrhage and then reattach the retina somehow. And you'll see it was a big struggle. The nasal retina was not getting detached. I used PFCL to reattach the retina. And being a glaucomatous eye, you can see the optic disc pale. You may ask why I'm operating, but when the patient is ready after explaining all the pros and cons, and that's what I learned from my second mentor, Dr. Jovanovich. He says you should be ethical and do the surgery in case you can repair it. And each surgery like this will increase your experience. And I think I've done one of maximum number of choroidal detached, suprachoroidal hemorrhage, and many have got some vision. And one patient got even 6/9. This is the last patient I would like to show following a cataract. This was a one-eyed lady. This was a senior surgeon operating in Mumbai, and he called me. I said, oh, close the wound and send. You can see some amount of cataract material was left behind, and you can see the corneal sutures. And I removed the after cataract which was left behind using the AC maintainer, and then I placed the trocar and go inside, complete the vitrectomy, and finally use the PFCL to reattach the retina. And you can see the things are cleared, retina is reattached. I do a PFCL oil exchange, which again these sort of eyes it works. And this patient actually got 6/24 being one-eyed. And you can see this is a post-op picture with a glaucomatous optic atrophy, attached retina, and doesn't look like it had a suprachoroidal or expulsive hemorrhage. And this is the last case where he was Sardarji using that nail to keep comb is whatever the turban, and then this happened, and you can see suprachoroidal hemorrhage being drained. and here also I make a sclerotomy, drain it, and then there's a PK there, and but I think unless you attempt, you will not be able to repair these sort of eyes. And I keep telling the patient, I operate, you get vision, thank God, don't get vision also, thank God. Thanks to my team who made this presentation. Thank you very much.
Thank you very much, sir, for these challenging cases, and you nicely showed how they can be managed. But instead of making a sclerotomy, Dr. Pradeep sir has described, and we have done a few cases with him where we just use the trocar 23 gauge. So would you like to comment?
It's already there.
I
adopted that.
yes, no, most of the cases I use trocar.
Yes.
But when I couldn't drain, because sometimes you wait long enough, the choroidal hemorrhage is not liquefied, then I made a sclerotomy and drain. And that particular patient had a kissing choroidal right from the ciliary region to the disc, so I had to drain the anterior part of the fluid.
Some of these glaucoma patients are much more prone, and we get it in most of our post-TRAV or post-glaucoma patients, and it becomes a challenge. And
exactly.
Kissing choroidal, you can't even wait for 8 to 10 days, and you have to intervene early.
Yes.
Can I have
please.
View of everybody here on where we don't have access to heavy silicone oil. In some of my bad cases, whether it be a bad PVR or such a case, I've been using temporary tamponade of up till 7 days with PFCL and then going in again. I just want to know whether I'm doing the correct thing, because my results are very decent with this technique. Now my co-consultants in retina there in my setup are also using this technique.
Yeah, I think, no, I think this was practiced 10 years back. In, when, yeah,
so
only because you have to position the patient.
I think there's a quite renewed interest in this, because I think the purity of the PFCL and the quality has improved, and we are also using it. I use it generally in pediatric cases now, especially GRTs and PVR. And yes, if you do a large retinectomy or something, you can use it, and we keep it for 7 to 10 days.
But you have to keep the patient in the supine position. So that's one of the disadvantage. And with the heavy oil, you don't have to do that. The patient can be normal.
Yeah, but heavy oil, unfortunately, is very difficult to.
No, you will get it now.
I hope so.
Yeah.
Thank you, sir.
Thank you.
So we have the last. Sir, any other comments? Okay. We have the last talk by Dr. Nachiketa. Will show us some interesting retinal cases.
Thanks, RP Center, and I've got my guru, Professor Talwar, my colleague Pradeep is there, and I think it's a wrong time for this presentation because we are all hypoglycemic, and I wanted to test a few registrars over there. I don't think that we've got enough, but let's carry on. I've got a few interesting cases. I try to remember my patients and the story that begins. Most of them are straightforward, and you should be able to pick them up. But it's just that little story that we remember, a story of our lives that we remember, a story from RP Center which we remember. Same applies to some of these cases. I don't have any financial disclosures for this. The first lady was a straightforward 76-year-old lady who presented with a vision 618 with a lot of distortion. And she had this big pale lesion in the center, which was a band or serous pigment epithelial detachment with subretinal fluid. And the story behind this is that her vision 618, and this is her only eye. Her right eye had a macular scar due to a bad disciform lesion. We don't know the exact presentation. And the question was, what should we do now? The patient is noticing more distortion in her. Should we give her anti-VEGF or not? Obviously, we don't have enough crowd, but there's always a discussion around only eye patients that anti-VEGF will probably help her, but might also cause more problems for her. But on balance, we counseled her and we said, like, there's a risk that if we don't treat, you'll go blind. If you treat, there's a risk that it might burst and you might still go blind. And on balance, we thought we'll just give anti-VEGF treatment. Fluorescein, obviously, it's not very clear, but you can see a little notch of an occult membrane in the serous detachment over there. So we treat her with anti-VEGF, and she comes as expected, probably. And when the patient phones you and they say, oh yeah, I've suddenly lost my vision. And you see over here is like a typical ripped pigment epithelial detachment. You can see if you go back to the fluorescein, we see that we got the little occult membrane, and quite often when the rips happen, this is the membrane which constrict and gets fibrous and pulls the whole thing towards the center, towards where the membrane is. That's what happened to her. And her vision dropped to 636. Which would have happened anyway if you're not treated. The only good thing about rips is quite often the fovea is still kind of spared, and the patients, although they need notice a drop in vision, usually the disease stabilizes after that. And this is how she was. And then she stayed stable for a long time, maintaining 618 vision. So this is a very typical case, and these patients you have to be a bit careful when you treat with anti-VEGF, and you have to counsel them very carefully. So this is a lady who was noticing some slightly reduced vision. She's 38 years old, and she had this like some kind of maculopathy happening in both eyes. Some kind of she's myopic, and vision was 6/9, 6/12. And we did and was referred to as suspected central serous retinopathy, and it was present in both eyes. And at that time we were not very sure, and this entity wasn't a very common entity, and we did try PDT with the reduced fluence, and eventually we found out that this is actually a case of dome-shaped retinopathy, which is now being recognized as a known entity in high myopes. We've got this little dome. When they get a cephaloma, they get a dome, and quite often there's a RP dysfunction, and they lead to this accumulation fluid. With OCT angio, now you rule out a CNV, and quite often you just have to observe them. They do fluctuate a lot, but I think PDT usually doesn't work much. So they can be mistaken for CSR or myopic CNVs, but it's a very known distinct entity now, and just keep in mind when you see any of these typical dome shaped on a OCT. This was an interesting man. He was an IV drug user, a sudden loss of vision in the right eye, 360, and seen by one of our registrars. And we had this picture in the right eye with a pale lesion in the center, with a lot of with the intraretinal fluid and some kind of subretinal scar. And it was referred to as like, because it was a history of intravenous drug user, one of the registrars thought, oh, probably it's a case of candida endophthalmitis or some kind of infective lesion, and ended up having all kind of PCRs and blood tests. What they didn't see was the other eye, which also had a similar lesion. And when we see a symmetrical kind of lesion, you have to think about, like, is it genetic? And when we did a OCT, it turned out to be like a vitaliform lesion, and with some kind of layering of the vitaliform material. And our high suspicion then changed on to be a case of Best disease. And we went on to do electrodiagnostics, and we see that the pattern and the dark peak upon light ratio was pretty flat as well. So obviously the electrodiagnosis confirmed the diagnosis. Again, like these cases are not very rare, but but then again, just keep a bit switched on when you see anything like that. It's a Bastron gene disease, which we saw. Now this case is a 12-year-old girl, and she was complaining of intermittent blood vision, and is referred to my retina practice. The referral was for one of the professors of ophthalmology who works with us. So when they saw me, this was her right eye. The mother wasn't very happy to see me because she was expecting to see a big professor, because she was referred from a peripheral unit. And her left eye had this typical picture where her retinal arteries are very tortuous. And the mother was adamant, like, her blood vision is very blurred, and she's complaining of blurred vision all the time. And I kind of, like, you take a bigger help from colleagues, and I eventually made that probably it's a diagnosis of a congenital tortuous central retinal artery. And the OCT was pretty good, it didn't show any major issues, and I was trying to say that obviously she has got this probably a genetic condition. It's not at the moment we cannot see any problems with her retina. But she was adamant, no, I want to see the professor. And I said, and I was pretty happy. I said, okay, that's fine. If they want to have a second opinion, why don't you go and have it? And she goes on and to have the opinion. And when she sees the professor, she's got macular edema, so she's kind of bounced back on me, like, that doctor wasn't good, and that this is about how she is. And that time she was having this macular edema. So she was getting this intermittent central macular edema because of her underlying tortuous central retinal artery. And as I said, like, again, a bit of story around her that, you learn from that what you see on the day might not be on the next day. Obviously, like we were not sure how to treat, and then we decided should we give intravitreal steroid, and probably that was tried, but the caution that a young girl might end up having a cataract. So it was big discussion with my family and the professor. So this one is a 6-year-old, obviously a quick case, right? I was fine, and the left I just went for a routine check. It comes out with this lesion in the macular area. Got a lot of these typical round grape-like lesions, very typical cavernous hemangioma. They've got this layering of, you can see the layering of RBCs when they're sitting straight. And obviously it's too young to fluoresce, but it's one of the few cases I've seen with this kind of presentation. Obviously, with the much larger practice, you will be seeing much more. But this typical cavernous, which is a slow-flowing kind of angioma. Sometimes they are associated with the cerebral hemangiomas as well. So you have to be just keep a low profile of getting an MRI done for these cases. This is another lady, 35-year-old, blurred vision in the left eye, and she came with a marked macular edema in the left eye, and it was thought to be inflammatory by the team. She underwent a fluorescein angiogram, nothing very particular coming up, and then comes to my practice. And I was just looking at the color photograph, and I could notice that there was a little optic disc pit over there, which was causing this CSR, which was causing her drop in vision. And it was a very difficult one to what to do now. Like you cannot laser because it might affect the peripapillary bundle. And then eventually thought, okay, let's get a vitreoretinal opinion because they might do vitrectomy and put in a gas bubble or maybe plug it in. So I referred her to the vitreoretinal surgeons, my colleagues. And when she reached there, it was gone. So it was like, again, as I said, like it just disappeared. So she was lucky enough to get it. And I've seen her for a little while now. I haven't seen her coming back, but somehow by the fear of surgery, probably just. So again, like just be careful when you're looking at some of these sketic retinas that it might be a small optic disc pit which might be causing the condition.
How long was the reference? How long?
Oh, I think it's within 6 weeks, 6 to 8 weeks. Yeah. Yeah, so lucky here in that case. But I don't know how you guys treat. Probably it'll be like a vitrectomy with some plugging, with some all those things you might try. So this was like what was planned, and eventually she recovered. This lady was 58. She was asymptomatic. Went to the opticians and noted to have these multiple vitreoform lesions in the right and the left eye. And it was like very difficult for us to do. We did all kinds of angiogram, ICG. We couldn't find any underlying lesion pathology leading to it, and these lesions were being observed for quite a while, and we couldn't find any reason why she's getting these multiple. It was like what we call as described by gas like acute multifocal BESS kind of disease with accumulation of this material, and a wide field again angiogram was very impressive. And you see this in autofluorescence as well, we couldn't find any cause. And then I was speaking to the lady and I said, like, she was fit and healthy, and when we were intensively questioning her, she said, oh, I had a melanoma removed a few years ago, and it turned out to be a paraneoplastic with underlying melanoma which is removed. We couldn't find any hotspot on PET scanning, and she was clear otherwise, but maybe she still had the autoimmune response going on. And she's still under my follow-up. She's actually a general practitioner. She's very, very nervous about it, but we are just keeping watch. They're not disappearing as well. They're just staying like that. It's been like about 7-8 years of follow-up, and nothing else is changing. This one again, an asymptomatic lady, my practice, who had this very impressive autofluorescence imaging, and she was asymptomatic, vision is good in both eyes, and we thought it's some kind of retinal dystrophy and all. And I think I took it to a retinal conference, and I think the consensus was probably it is a rubella retinopathy. I don't know how many you've seen, and our electrodiagnostics were normal as well. And we thought, that was the consensus diagnosis. I'm still not sure whether we were right or wrong, but I've seen her for a long time. She hasn't changed her electrodiagnostics stay to be normal. So that's what we think. Now this one is the last case, and it's a quite interesting one. He was a young 14-year-old who came with a sudden loss of vision. He was hit in his left eye, and this is how he was. So just a minor hit in the left eye, and he had this multiple hemorrhages in the left eye. The vision was pretty poor. And if you look at the fundus carefully, you can see some like pigmented areas. And this is his right eye at that time. He was that was 2009, and eventually he ended up having a lot of scarring. And you can see that he has got underlying angioid streaks, and he had pseudoxanthoma elasticum. So the story doesn't end over here. He was young, he was 14, and then he goes on to the college, and we said, okay, be careful, don't go in a pub, be careful, you're not hit. And it was a very minor trauma that he had in the left eye, and he 8 years later has come to me with his right eye. Now this is good eye, and he had a very minor trauma. Somebody just like did a small nudge and ends up in the same manner. And at that time, like when he came to 14, this was his better eye, and we thought, okay, what to do now? We just gave him a shot of Avastin because we thought like at least it might prevent some secondary neovascularization. And this was his left eye at that time, and it started resolving, and eventually this is how his OCT was, you know. So he, after one injection, after a few months, he regained a vision of 6.4. Surprisingly, his vision of the left eye improved as well. It was used to be 6.18, it's about 6.12, 6.9. I don't know whether there was a cross boundary. So again, like angioid streaks, common causes pseudoxanthoma elasticum and a lot of other conditions, adenose and sickle cell. And the last one is like a one with the sickle cell I saw recently, who again has got angioid streaks, no other problems otherwise. But you can also see the sickle cell signs on the white field and imaging in them. So again, white field imaging helps. So yeah, so that's just a few cases I wanted to share. Obviously, if you had more time, then we could have made it more interactive. But it's good to come over here and see all my old friends, all my teachers, and a very nice gathering over here. Thank you very much.
Thank you, Dr. Nachiketa, and thank you for coming from UK. And we would like to honor you with a memento. Dr. Pradeep and Dr. Talwar, would you kindly present a memento of our appreciation to Dr. Nachiketa? Dr. Natarajan, Dr. Shobit, you can also join, please.
A big thank you to all our speakers, our chairpersons, and our moderator. And thank you so much, everybody, for joining in at the RPC Ophthalmic Carnival 2023. Have a great gala night, and we'll see you all tomorrow. Thank you.